Hello, good morning, everyone. Thank you all for coming here on the third day of the DRS conference. I'd like to start with our first session, Save the Feet Symphonium. I'd like to call up the chairperson, Dr. Bijal Patni. and Dr. Dipanjali Pawar. Please come on the stage.
Good morning. Welcome to the third day of this symposium. And we are starting with a very important session, that is Save the Feet Symposium. Are you all aware of this? The bold step taken by RSSDI started with last year. And this is 2.0. The whole idea probably is to identify via mass screening the foot at risk in people living with diabetes. And I think we are collecting data for that. And then we have to look into how well we can use the data for the outcome as well. And also to educate the healthcare professionals as well as those who are actually undertaking this procedure of screening as well as management. So we have three erudite speakers for this particular symposium. So would you like to add anything? So we start with Dr. Sanjay Vaidya. Sir, please come on the stage, sir. And he'll be speaking on role of plastic surgery in the management of diabetic foot ulcers. Dr. Vaidya. He is a practicing consultant plastic and diabetic foot surgeon since 1988, attached to the SL Raheja Hospital, PD Hinduja Hospital, and is a professor examiner for fellowship in diabetic foot surgery. He's a treasurer of Diabetic Foot Society of India, Vice President, Asia Pacific's Association for Diabetic Foot Programs. So obviously he has a number of credentials to his name. So I'll request him to start his deliberation. Thank you, sir.
Good morning, everybody. So I'm the opening batsman today, talking about the role of plastic surgery. I think as a plastic surgeon, we play a very important role because whenever we get a diabetic foot ulcer, it's very important to heal the ulcer at the earliest. And as a plastic surgeon, we can definitely do certain skin closure procedures such as skin grafting, flaps, different types of flaps, what I will just show you. So rather than just allowing the wound to heal by secondary intention, we try and expedite the wound healing process by doing certain skin closure procedures, as I mentioned, like skin grafts or flaps. So still not connected. ये बहुत आगे गया. Do you want me to give the pen drive, because I have mailed it actually yesterday. I checked it, it's there. Issue with the cable. It's very imperative to heal the wound as fast as possible for the simple reason infection in a neuropathic ulcer leads to amputation, and 85% of the higher level amputations are because of infection in a neuropathic diabetic foot ulcer, which is totally preventable. So we have to see how fast and how well we can heal the wound. पीछे जाओ, first slide पे go to the first slide. Okay, here we go again. So sorry, this is not working. Anyway, I'll operate from here. So as I mentioned earlier, fundamental goal of a reconstructive surgeon is to preserve form and function and promote healing, reconstruction coverage and prevention of recurrence, which is very important. As you all know, as plastic and diabetic foot surgeons in tertiary care hospitals, every day we come across this kind of different types of complex wounds. And as we all know, it's a problem triad of neuropathy, ischemia and deformity. And if there is an infection, that is the challenge. So whenever we are talking about wound closure procedures, first, as a plastic surgeon, we have to look at the kind of wound we are looking at, location, depth, size, then of course look at the vascularity, which is very important. If there is a PVD, if there is a varicosity, then also look at deformities like Charcot, and whether there is an infection, superficial or deep, in which case we can't obviously go ahead with plastic surgical procedures unless we control the infection. And then of course host related factors like a patient of CKD and other problems, coronary artery disease or a patient having vasculitis. So all those factors we have to take into account. So first and foremost, of course, we have to establish adequate blood flow if you want to achieve success in reconstruction. And the first step in reconstruction again is a good debridement. Unless we do a proper debridement, we will not be able to have a successful skin closure. So this is the kind of aggressive debridement which is required in necrotizing fasciitis. And then of course I use various newer modalities like a hydrosurgery system, which gives us a very selective debridement. As you can see here, this was a 95-year-old lady with a PVD with a heel gangrene, underwent angioplasty, and a very nice selective debridement done with a hydrosurgery system, preserving the underlying viable tissue wherein the negative pressure wound therapy was put and subsequently skin grafted and the leg could be saved. Or a CO2 laser, which I have been using for a long time. We have a non-contact laser which especially can reach to the depths, and you can excise deeper tissues, especially when it is near the joint capsules or tendons. What is important, what has happened in last few decades is we came to know about the anatomy of the angiosomes, a particular vessel supplying a particular area. So nowadays, if there is a patient of PVD, we tell our intervention radiologist or a vascular surgeon, look, this is where the wound is in the region of anterior tibial territory. So try to open up the anterior tibial, because that is what is going to give us a direct blood flow coming there, and which will aid in wound healing and also help me in putting a flap. Like here, actually this patient came to me from outside with a non-healing ulcer after second amputation. As you can see, there was a SFA block, so we got it opened, and subsequently, of course, just a small debridement and the wound went on to heal. So again, the first thing is to correct diagnosis. So assess the extent and type of missing tissue, and then we go to what is known as a reconstructive ladder. So just starting for a simple, this is the reconstructive ladder we as a plastic surgeon use while dealing with the DFU. But there is a concept of reconstructive elevator. Now, if we are in a tertiary care center where we have adequate facilities, a team and trained plastic surgeons who can directly go for microsurgery, we can even take a elevator and directly go for the more complex procedures. Now this is just a healing by secondary intention, where of course offloading was a must. With a standard wound care, this has gone on to heal. This is a top closure system, which is a tension relief system, especially when there is a small area, say around ankle or around a joint, where you don't want to put a major flap. You can just put this top closure system. This is a zipper-like system where you slowly keep on pulling and getting the wound edges together and heal the wound without necessitating any flap. As you can see, another example. As Lister said, skin is the best dressing. So split thickness graft, of course, is our workhorse. As you can see, I of course prefer to have a electrical dermatome and a mesher, which makes life easy. As you can see, a very nicely meshed graft there. And This was an extensive debridement which was carried out in the necrotizing fasciitis with a CRP 550, 46,000 counts, and of course patient underwent negative pressure wound therapy or VAC therapy along with hyperbaric oxygen, and within 15 days he was ready for skin grafting. And this is 5 weeks after skin grafting. That means within 8 weeks from the onset of his necrotizing fasciitis, patient was back on his feet. There are different kinds of skin grafts. I am just showing just to show you that plantar skin grafts do very well provided you give a proper appropriate footwear. There is no reason for us to put bulky flaps because this is a much simpler, especially in a vascularly compromised patients. Coming to bioactive dressing and tissue engineered skin substitutes. Now we have got various allografts which are available like dehydrated human amnion chorion membrane allograft. Ease of application in a non-infected wound, once a week change of dressing, and as you can see, couple of weeks the wound has gone on to heal. Or you have also areas where there is a small area of a tendon which is exposed, then you can use what is known as a human umbilical cord derived membrane allograft, which is a little thicker version, which will help in the creeping of the granulation over the exposed tendons or bone, and thereby obviating the necessity of putting a flap. Coming to tissue engineered skin substitutes, Integra was the first one to be launched in India. It is dermal regeneration template, which again obviates the need of the flap. As you can see here, a patient came from out of Mumbai, undergone great toe amputation after angioplasty. Looking at this, I knew there is a restenosis, so I got a repeat angioplasty done, got a good flow going there, and then did a forefoot amputation. You can see there are exposed bones. I didn't want to shorten it further, so just put a Integra dermal template there to cover those exposed areas of bone, put a wax dressing on top, and subsequently skin grafted, and thereby maintaining the length of the stump. Another example of a lesion on the gangrenous lesion on the MTP joint. Again, patient was very keen on saving the great toe. A Versajet debridement, a very clean wound bed, application of this dermal matrix, and you can see a completely healed wound and a great toe could be saved. Coming to cell-free dermal matrices, we have Dermacell and Matridome, which is available in India. Dermacell is a cellular dermal matrix which undergoes through a patented process of matricell, which renders the graft cellular but still maintains its biochemical and biomechanical properties. So this is just one example. As you can see, this can be OPD basis. Neuropathic patient, you just scoop, debride, and just clean the wound. Put 3 or 4 staples around, and as you can see the last picture there, patient has a completely healed. Otherwise, healed wounds are very challenging. Now, this is one case which was done during COVID times, so the last picture has been shared by the patient from his home. Matridome is also a cellular dermal matrix, is a collagen elastin matrix, which again is helpful in covering small areas of bones and tendons. Now, this is a very interesting case. I'll tell you, a very chronic smoker started with a small gangrenous patch on the toe, subsequently went on to have a toe gangrene, went to a vascular surgeon, got an angioplasty done, and got a great toe amputation done. The last 4th picture is where he came to me. The previous 3 pictures have been shared by the patient daughter to me. Looking at this, of course, I was not very happy. I knew in a chronic smoker with diabetes, they're going to be severe PVD and restenosis. Got again repeat angioplasty done and did a proximal forefoot amputation, almost a midfoot amputation. Not looking good at all. I thought he's a candidate for below knee amputation. The patient was absolutely reluctant to undergo higher level amputation. He said, "Doc, try to save my leg." So you have to be patient. Patient is patient. Then we started using a negative pressure wound therapy along with Recosma RBM YAG laser, which I've been using in my practice. This is a regenerative laser. I've been using it for more than 5 years now. And you can see gradually from here, second slide, he has almost come nicely to a granulating stage, but there were exposed areas of bones. Again, putting a flap in such cases, a patient microvascular flap poses a significant risk because a recipient vessel may not be good. So here, as you can see, I put that Matridome on top. Subsequently, once it is integrated, put a skin graft. Then you can see a very well settled skin graft. And the last picture is when you can see that the patient is standing on his own feet with a modified footwear, and that leg could be saved. Endoform is another natural restorative bioscaffold which has got advantage. It has got a 0.3% ionic silver. So potentially infected wounds also you can use. Other matrices what I showed have to be used in uninfected wound only. Now this was one case, again PVD, had undergone angioplasty with a debridement followed by grafting over the heel, came to me with again a small tunneling wound, and just packed the cavity endoform. Every week you keep on packing that, and as you can see, in about 6 weeks time it is almost completely closed. Myriad matrix is a thicker version of endoform, multiple layers which are used specially to cover the exposed areas of bones and tendons. And this also patient was very keen on saving the fifth toe. So I did aggressive debridement. You can see the exposed joint capsule where the myriad was applied, and this has gone on to heal, and that toe could be saved. Coming to different types of flap, we have random pattern flap, we have axillary pattern flap, we have free flaps and perforator flaps. Now, local random pattern flaps, actually I'll just show you few quickly. This is like you on table decide and try to rotate and try to close the defect so that we don't have a open wound at the end of the procedure, and that will depend on the type of necrotic and viable tissue which is available to us. So another example where local flap has been used, filleted from the dorsum of the great toe. Now these are the local random flaps or rotation flap for a heel defect, as you can see, which you can cover a heel defect, or a transposition flap where you can see there is a small area of exposed tibia, and I have transposed the flap and the donor site is been skin grafted, and this has gone on to heal completely. This was also another case where you can see I have put up stimulant antibiotic beads to control the infection in the bone, and in the end down you can see a very well settled flap. Transposition flap, again another example of small MTP joint ulcer following grade 2 amputation, or a VY flap, which is a VY advancement flap used to cover the defect over the plantar aspect at the first MTP joint, or a large rotation flap which is used to cover a defect on the heel, and a small skin graft put at the after the rotation, but that's on the non-weight bearing area. So this is another rotation flap which has been done. Again, a grafted area is a non-weight bearing, and we have got good thick quality skin on the plantar aspect in the weight bearing area. Coming to axial flaps, this is a medial plantar artery flap which is rotated around the axis to cover the heel defect, or a reverse sural artery flap, as you can see here, necrotic calcaneum there. I have done a debridement, and that has been moved to cover the defect. And another dorsalis pedis artery based flap, again rotated to cover the tibia. And then various kinds of muscle flaps, we use intrinsic muscle flaps, like this is the abductor hallucis muscle, which is abductor hallucis brevis, which is rotated to cover the heel defect, or a abductor digiti minimi to cover the heel defect, or a free tissue transfer such as this, where after amputation of the great toe and extensive debridement, a free flap was put, muscle flap, or a free anterolateral thigh flap, as you can see here after a good debridement. Again, another case of a heel defect with a free ALT flap. So as you can see, we can start from a simple procedure and go to complex procedure depending on what kind of a wound we are dealing with, what kind of a defect we are looking at, what is a good, whether it is a vascularity, what is the comorbidity that the patient can tolerate, extensive procedures, and then accordingly we take it forward. So I think this is how we as plastic surgeons and diabetic foot surgeons try to save the limbs. Thank you very much.
Thank you, sir. Excellent outcomes, I would say, as far as Save the Feet is concerned. We can take the question straight away. Can you come on this? The concept of Save the Feet, what he has done is the secondary and tertiary way of saving the feet. Obviously not the primary way, but the outcomes of his various cases was excellent. Thank you, sir.
Thank you.
And we can definitely take one or two questions from the podium. Yeah, please. Can we have the mic, please? Yeah.
Yeah. In case of diabetes, how can we prevent these foot complications occurring initially only? Is there a special footwear they should wear?
Oh, yeah. Actually, I run a comprehensive foot clinic where prevention is the best thing. And what I advocate is annual examination, where I have a podia scan to do a gait analysis, a neuropathy assessment by VPT, hot and cold sensation, and a small Doppler to do ABI and check the toe pressures also. So once you have seen that, especially on patient developing neuropathy, and on podia scan you see patient developing certain high pressure areas while he's standing or while walking, is overpronation. Then you have to provide a corrective orthotist, which of course I have orthotist again who does that by doing a customized orthotics or a customized insoles which can be fitted in the patient's footwear. For a patient who has a very mild neuropathy or no neuropathy, he can have a simple diabetic sandals, but the shower hardness should not be more than 20 to 25. Unfortunately, what is sold across India as so-called diabetic footwear by the companies, I have checked, and the shower hardness is always unfortunately in the region of 40 to 45, which is absolutely wrong. But that is something which we have to look into. And in small ulcers like this, actually, very often you can just offload them by a good dressing, and offloading by just putting say double EVA in the sandal and scooping it under the great toe or first MTB joint region, and the ulcer will heal. We don't need any very advanced footwear. Of course, we can provide them in affording patient, but even simple measures like this go a long way in preventing complications.
Thank you.
Any other question? Thank you so much.
What is the role of HbO2 locally? If one foot is ulcer, then no need to give body oxygen.
Oh yeah, those are two different, they work on a different mechanism. If you ask me, my first choice will be hyperbaric, but there are cases where patients either have some middle ear problems or more than that, cardiac issues where we cannot put the patient into hyperbaric chamber. I definitely use extensively local oxygen therapy, which definitely helps, though not as great as hyperbaric, but yes, it is definitely useful, especially in a little compromised ischemic wound. It's an adjuvant which should be used. And in fact, I started using it more during COVID times when I was worried to call the patients in the hyperbaric chamber for fear of catching COVID either in the chamber or in the ambulance. So that is when I started using it more and found reasonably good result. But minimum 14 sittings is what you can see along with standard wound care before you can see the results. Minimum 14 days to see some result. Actually, you can even continue a little more, but definitely 14 days is something which you require.
Thank you, sir.
Thank you.
So we'll move ahead with our next lecturer, Dr. J.C. Thomas. She had done her MBBS from Bangalore University, DLO, and she underwent training in establishing diabetic foot clinics conducted by the World Diabetic Federation in association with DFSI. So she is a well-known trainer, and she is going to deliver a lecture on foot debridement and role of NPWT. Over to you, ma'am.
Thank you, ma'am. Good morning, everybody. So this is going to be a repetition slide in every diabetic foot conference just to understand the magnitude of the problem. So this very clearly says at any point of time there are 50% of patients with diabetic foot who require hospitalization, and out of them there are about 25% of them who land up with some kind of surgery. 85% of these amputations somehow are preventable. Amputation, there is an amputation going on, a higher level amputation going on in this world, not only in India, every 20 seconds because of diabetes. This is a huge number, a huge burden to all the doctors. So only a handful of doctors, a handful of surgeons cannot be a part of saving the limb. I think in my lecture, this lecture actually is to promote more and more wound care practitioners to get into Save the Feet, more and more physicians to look into smaller kind of wounds, which is a great burden. It's not that everybody come to a tertiary care center with a large wound which requires a surgical expertise. There are smaller wounds which can handled by a trained wound care expert, who could be a 12th grade pass or a staff nurse or even a diabetologist for that matter. There are a lot of diabetologists with whom I work who are interested in diabetic feet and diabetic foot ulcers, and they are very much successful in healing the wound and preventing an amputation. So this was Saint Vincent's declaration. Way back it said that by mid-90s they wanted to reduce the amputation rate by 50%. Are we anywhere close to it? No, not at all close to it. We have, I think, 10 times more burden as of now. So, but why? this is a very big. Now, if you, where is the missing link? COVID was, we had COVID in similar number. We were very good in controlling. India did an excellent job with that. But when you talk about European Wound Care Association, there we have a, they have this trained nurses who handle these wounds. And in India, when you see, it's only the doctors who are with cleaning the wounds or doing surgeries or trying to save the limb. But I think this has to change. More and more nursing practitioners will have to get into wound care and work towards saving the limb and healing the wounds. So coming to debridement, what is debridement? If you actually get into the definition of debridement, it says removal of viable and non-viable wound components. Viable meaning removal of non-viable wound components using the most effective method with fewest side effects. I will get into the detail of what are the effective methods. It is executable by a healthcare professional with knowledge and capability. It doesn't mention, this is a definition by Journal of Wound Care. It's not just doctors. Even nurses and trained wound care professionals can do wound care within the boundaries of their sphere of practice. So let us not give this responsibility only to a surgeon. So what are the other methods of debridement? Of course, using a scalpel or a blade, I think everybody is worried about. Most in India, nurses cannot even think of using a blade or a scalpel for surgical debridement. There are other methods of debridement. There are other creams, gels, lotions, enzymatic debridement, chemical debridement, other forms of, like Dr. Vaidya said, hydro surgeries using Versajet. All these with good training, even a nursing staff or a trained wound care specialist can do. However, surgical debridement, I think it's restricted to surgeons who can understand the anatomy of the feet. So factors influencing the choice of debridement, you need clinical experience, competency. You also need to understand how quickly it needs to be done, the level of inflammation, how urgent it is, the treatment objective. Is it limb salvage? Is it life salvage? Is it the treatment setting, the wound type, general condition of the patients, and associated comorbidities. There are certain prerequisites for a diabetic foot debridement: a thorough clinical examination, evaluation of the neuro and vasculopathy. Also, tissue biopsy is very important. Wound swab and culture is not advocated. Tissue for culture is how you should do. How do you take a tissue for culture? First, you will have to rinse the wound, clean the wound, take a bit of tissue and then send it for culture. Never you swab the tissue and send it for culture. X-ray of the foot is mandatory. Ankle brachial index, color Doppler, and TCPO2, depending on the need to assess the vascularity and the availability. TCPO2 is not available in every hospital. It's transcutaneous oxygen pressure monitoring. Sometimes when you have heavily calcified vessels or non-palpable vessels, ABI is it's not possible. Color Doppler also is a technique. There are sometimes technical glitch. You might not get a correct information. So understanding more of collaterals and how the tissue is perfused with oxygen, transcutaneous oxygen pressure monitoring system is a good evaluating tool. And of course, as and when required, peripheral angioplasty and revascularization has to be considered. Addressing the comorbidities, it's a very important part of diabetic foot. Diabetic foot always comes as a package of complications. Mostly cardiorenal complications, which is very important. The associated hypoalbuminemia, anemia has to be addressed along with taking care of the infection. Why? Because leg is a dependent organ. So edema because of hypoproteinemia, anemia, hypertension, venous stasis always interferes with wound healing. A good compression dressing has to be thought uh, like when there is a wound, there is an increased perfusion. You have to address the edema simultaneously. So addressing the comorbidities and nutritional status of the patient is very important. Of course, loss of toe or loss of body part is not easy for the patient or the relatives to accept. So, a psychological counseling and post surgery, there is a minimum of for any kind of surgery, minimum of 4 to months together for a healing time during which patient has to be offloaded. In Mumbai especially, people live in chawls, one room. So, when you talk about offloading, giving them bedpan, urinal, everything in one room where 4 people or 6 people are staying, it's very difficult. So, counseling of the patient and family is very important. Post debridement, culture specific antibiotics is a very important part of treatment. Sometimes when we use culture specific antibiotics, there are certain drugs because of the renal status, we are not able to administer fully or avoiding the complications. So we have other ways and means to clear the infection. Like Dr. Vaidya said, we can use local antibiotic beads which penetrates much better. However, these things can be thought about only after controlling the sepsis. Once the WBC comes down, once the creatinine comes down and patient is in a state towards discharge. Usually we advise this kind of treatment towards discharge. Offloading of the foot with the wound is a very important part, and wound care. Wound care is one of the most important part. I think it's very important to understand. I was just talking to Dr. Vaidya that the concept of our wounds in the past have healed with betadine and mercurochrome. Why do we need to use such expensive products for wound care? I think that myth has to go. Bugs have become very intelligent, or they know how to adapt to the changing environment. So we need to be smarter than them. So one of the important part of wound care is wound cleansing. Again here, how do we clean the wound? Is normal saline the option, or is betadine the option, or do we have any other solutions for wound care? Why should we use this newer solution? They are so expensive. Yes, wound cleansing and debridement contribute to wound healing. How does it contribute? It cleanses the wound environment from all the debris, biofilm, and reduces the bioburden. Nowadays, we are dealing with another set of problems. It's not just the bacteria, one bacteria or two bacteria which you are culturing. We call it biofilm. This cleansing the biofilm is a task. There, even though it is called a film, it's not a film, it's not a slimy layer. It has got deep roots into it, and actually just by washing it's not going to clear. You need to use a surfactant which can lift the biofilm up, and only then you can wash it off. So this newer wound cleansing solutions help to clear the biofilm, which is a very important part of wound care. These are some of the available wound cleansing solution, which can be as simple as distilled boiled cooled water to ionic silver solutions, or we have this hypochlorous acid, so on so forth. But when you use water or normal saline, it is more of mechanical debridement. When you use the others, you are targeting the biofilm. So this picture is of a professor who was operated in 2016 outside, and then he has undergone all the major wound care products or technology like stimulant bleed, wax. He has undergone culture specific antibiotics. He has used collagen granules, daily dressings. However, he was a professor, and he was teaching at Mitibai College. But then because of the smell in the wound, can you imagine, because of the smell in the wound, he had to take a resignation. Oh my God, it's done? Okay, sorry. Okay, so this wound was healed by a nurse. No doctor was involved. What he did was a thorough debridement, cleaning the wound, and you can see how within a span of 8 weeks the wound has healed so well. This is the power of wound care. Here, no surgeon. So it need not be only a surgeon. A good nurse, a trained nurse can heal a wound. So this was the missing link. So only doctors, a handful of doctors cannot deal with this magnitude of problem. Okay. I've got these students who are coming, diabetology students who are coming from a government hospital who learned wound care, and in their medical practice they are healing the wound. So this is again a debridement which staff nurses can do, the callus care. A carefully excised callus will not leave a ulcer behind. This again is another very interesting case. He had this wound for more than 6 years, and this healed in 3 weeks, and once a week dressing only. So what was required was a good wound care. So now when a surgeon gets into the picture, the way you debride is totally different. There is a very specific way of these wounds traveling. It travels mostly along compartments. You have 3 spaces in the foot. These are the 3 spaces. I will show you some pictures. Medial, central and lateral plantar spaces. So most of this surgery is done under ankle block when the infection is restricted to foot. Under ankle block, blocking all the 3 major nerves around the ankle, the anterior, posterior and the peroneal. So this is one of the picture with medial plantar space abscess. Can you see that wound? You feel just by excising, not working. Just by excising the skin, that's not going to work. The infection has traveled along the medial plantar space. Can you see the extent of the wound and how well it is healed? This is not a grafted foot. This is during COVID. This was by negative pressure wound therapy, and this whole thing was again done by a staff nurse who was trained in negative
Excuse me,
pressure
ma'am.
wound therapy.
Ma'am, please wind up your session. Please wind up.
Oh yeah, okay. So then this is the central plantar space, and look at the way it is traveled along central plantar space. This is how it travels. This is, sorry, I think I'll have to stop. Thank you. Thank you. I think some other time.
Thank you, ma'am. I think you showed a lot of cases. We are rather going the backward side. Now we need to understand anatomy now. So we have Dr. Amit Nagate, who will be talking on knowing foot anatomy to save the diabetic foot. And he's the chief diabetologist and foot care expert at Nagate Diabetes and Foot Clinic, Aurangabad, Century Hospital, Aurangabad. He's a consultant diabetic foot surgeon at Kamal Nayan Bajaj Hospital, Aurangabad. And he has a lot of credentials as well. So organizing secretary DFSI 2016 and also the midterm one 2023. Welcome, sir. Please continue.
Thank you, Chair. Leonardo da Vinci has described the human foot as a masterpiece of engineering and a work of art. We have got 26 bones in the foot, 107 ligaments, 19 muscles, 125 sweat glands. If we say that a person walks around 7,500 to 9,500 steps per day, it is roughly around 185,000 kilometers in his lifetime, and it's going around the world 4 times. So this is the most abused organ of the body, and we don't care for it. These are the, as anatomy goes on, majorly we start with the arches. Arches are found with bones, ligaments, and tendons. Their main function is for weight bearing, locomotive organs, for walking and running, provide spaces in the sole to accommodate muscles, nerves, vessels, and provides stability and support. Medial longitudinal arch, it runs from the most prominent arch of the body. It runs along the inner margin of the foot. This arch absorbs majority of the shock and impact while walking, jumping, and running. Medial longitudinal arch is formed of apex by the talus and two extremities, that is medial tuberosity of calcaneum and the head of first, second, third metatarsal head. It is formed from callus, talus, navicular, three cuneiform bones, and first three metatarsal bones. Lateral arch, which is found on the most lateral part of the body. It is basically formed from lateral tubercle of the calcaneum, head of fifth and fourth metatarsal head. It is flat arch, mainly occupies formation because of the bones. Transverse arch, which runs along the midfoot, lies at the level of transmetatarsal joint, provides support, flexibility of the joint. The arch is maintained by muscles, ligaments as the longitudinal arches form. The major factor of maintaining the arches are your bones, which are interlocking with each other, muscles and ligaments. Maintenance of which interlocks with each other, the tendons which run across the arches, and the ligaments. We have got a very strong ligament in the plantar surface. It is basically not a plantar surface, which is called as a sling ligament, which is exactly a plantar aponeurosis, arises posteriorly from the calcaneum and distally divided into 5 more major branches, which continues as fibrous digital sheets and enclosed with the flexor tendons of the toes. It has got flipping action, where you can see once it is tightened up, the first metatarsal goes up. So this is called as a whiplash mechanism. This is what the mechanism looks like. And this mechanism is hampered in diabetes, and because of which the first metatarsal head get more pressure while walking. That is the reason why we get a first metatarsal head ulcers frequently in a diabetic foot. Ligaments, we have got major 5 ligaments: deltoid, lateral ligaments, spring ligament, strong plantar ligament, and long and short. The spaces which madam has started upon, I will approach more enlightenment on that. Medial plantar space, that is the dorsal is from the surface of first metatarsal head, medial from plantar fascia extensions, laterally from intermuscular spaces. It contains of abductor hallucis longus, flexor hallucis longus, tibialis posterior, and rest of the things. Central plantar space is formed laterally by plantar fascias, inferiorly by plantar fascia, laterally by intermuscular septum, and dorsally with transmetatarsal joint. It contains flexors, longus, brevis, lumbricals, and the rest of the muscles. Lateral space, which is formed dorsally by fifth metatarsal head, medially by intermuscular septum, laterally by plantar fascia. So this is what the concept. If you can see the arrows, A is your medial, B is your central space, and C is your lateral space. The infection coming into that space will extend and infect the tendons and the muscles in that space and lead to spreading of it. This is the cross-section study: medial, central, and lateral. If we say that the central plantar space has an abscess, then the septic arthritis occludes the plantar arch, which leads to necrosis of the third, fourth, or second toes. This is the image, and this is what the debridement comes from. Because we need to debride the whole space, we need to remove complete infection. So this is what the debridement goes in. The lumbricals are considered to be the major plantar flexures of the metatarsopharyngeal joints and extensor of the interpharyngeal joints. So this is the anatomy of the deep plantar fascia. You can see it right extends from, the pointer is not pointing it up, right from your calcaneum towards your soles. So this is the deep plantar fascia. It holds, protect the feet. It has got a major support for the longitudinal arches. We have got 20 muscles individually in the feet, 14 on the plantar aspect and 2 on the dorsal aspect. So the muscles which are on the plantar aspect, which are divided into 4 layers, and the muscular actions are not that complex just because like our hands. They only act together to support the arches and in the locomotion point. This is the main joint, which is called a subtalar joint or talocalcaneal joint. Inversion and eversion is the movement which occurs at that joint. If the joints collapse, the foot is not going to work. So we need to protect this joint. Nerves and arteries, tibial nerves and posterior tibial artery divides in posteriorly towards the medial malleolus into medial and lateral plantar and supplies the intraosseous muscles. This is the venous arch, where superficial venous arch and the superficial Cephalic vein and the great cephalic veins meet each other, and the main, what we say it as, their clinical implication is varicose veins and venous thrombosis. Dorsalis pedis artery we can see running straight along the tendon, and this is where the arch is formed dorsally and supplies to the deeper plantar arteries. This is anatomically where we can judge the dorsalis pedis, we palpate it. This is what the anatomical structure goes in. This is another space called as tarsal tunnel, which is formed between the bones and the flexor retinaculum. This is another one point where the tibial nerve is being compressed if there is an infection, inflammation, or tumor or fracture over there. This can lead to numbness and burning sensations and tingling sensations. So this thing has to be analyzed or diagnosed before labeling the person to be diabetic neuropathy straight away. These are the fascias where we can see that there is connections. Okay, you can see this. So this is where the infection spreads along the fascias. The most important understanding point is that these are various compartments, just like the legs. We have got various compartments in the foot also. If the infection happens in the compartment, then we need to remove the tensions from the compartment, or otherwise everything would be necrosed. This is from surgeon points of view, and as well as physicians should know that, so that the extent why this debridement is needed, the physician has to know it, so that we can guide the patients and help the patients. So this is on the plantar view, where you can see lateral, central compartment and the medial compartments, and these are the fascias which has been entangled. Floor is more complex or compromised, or the compartments are more rigid. So the plantar aponeurosis is the outermost fascia and represents the anatomical layer located beneath the subcutaneous tissue. The medial and the central plantar compartments are separated by the medial sphincter space, which we have already discussed. So infection in these spaces need to be tackled very carefully. We need to reach to the fascia. Just merely removing the unwanted tissue, it's not going to help. The same thing has been there. This is the cross-sectional sections, medial, central, and lateral spaces have been described. I'm just running out because previous this thing, the transverse foot space, where we need to remove this complete toes, so that the debridement is to be removed, so that so that the spaces and the infection won't spread further. So the infection usually spread along the tendons. Any kind of tendon infected area is going to spread along with it. So this is what the central compartments instrumentation is done. So if you can see, it is more deepened in. So central compartment needs to be removed completely or explored completely to prevent further complications. This is necrotizing tissue. Need to remove the tissue completely. This is where the flexor hallucis longus tendon has been. Yes. Nah, this will do. This is flexor hallucis tendon. We can see. So that tendon is between the two sigmoid bones. So osteomyelitis of sigmoid bones or any inflammation of sigmoid bones, this tendon is going to get infected. So the ulcer or infection of the first metatarsal head is going to go along the flexor hallucis longus tendon. So you need to track the tendon and remove it. so that the infection is to be prevented. This is another example where the extensor tendons has to be removed completely. The space has to be removed completely so that we can prevent further complications. This is another way where a lower pressure area is being infected from the higher pressure area. So this is a high pressure area. While we walk, this is a high pressure area. And once this is osteomyelitis of the third metatarsal head, and this is what the dorsally we can look like. So from lower pressure area to the higher pressure area, the infection spread. The infection rather can spread through the interosseous spaces or interosseous compartments. Third metatarsal, third toe spreads along that. So we need to remove completely because the interosseous has been infected. So need to remove it so that the further prevention of or spread of the infection is being done. The simple fact, I will just take 2 minutes. The simple fact is that the bipedal gait requires that the high weight bearing is to be from the bottom of the foot. So this has been, everybody knows that neuropathy, vasculopathy and immunopathy and injuries are the most common problems which the diabetic patient faces. Pathobiomechanical changes due to the peripheral neuropathy is the main etiology. This is what it is: sensory neuropathy, loss of sensations, inability to feel high pressures, loss of position sensations, changing walking pattern, hyperpronation, and the muscle weakness, imbalance, stamping gait. We need to have a high index of suspicion. Diabetic foot patients are very vulnerable. Neuropathy, immunopathy, and altered biomechanics. Very narrow window of opportunity is there. No complication, no examination is the philosophy. That is not going to be there. If a neuropathic fit comes in, high stamping gait, if sleepers slips out, sensory neuropathy, drop of the foot, ulcer with walking comfortably, it's severe neuropathy. So once you can see the patient walking in, you can guess clinically what exactly it is. 85% of diabetic foot ulcers are from within out. So repetitive modern force or prevention of walking by will damage more. Diabetic foot ulcer is a mechanical problem. No amount of antibiotic or dressing will heal the wound unless and until you reduce the pressure. This is the main crux. So this is the current scenario and what we call it as a foot attack, just like an heart attacks. So main aim of diabetic foot care is to prevent the ulcers, prevention of ulcer, prevention of ulcer, and prevention of ulcer. Nothing else. This is a diabetic foot. It's calling to us, please help me, please save me, please save me, please save me. Thank you for your patient listening.
Thank you, Dr. Amit. So we learned about foot anatomy, and then we went to foot debridement, and obviously we learned about the therapy as well. The foot surgeon told us about the various therapies. So basically still Save the Feet program is basically about how to prevent. So most important is awareness, screening, and then education. So that is what we need to do in order to prevent the foot problems related to diabetes. Thank you all. And this ends the foot symposium.
I can just add one thing, sir.
Yes, sir, please go ahead.
Yeah. Usually diabetic foot definition comes in, or when we say that this is patient is having a diabetic foot, is when the ulcer is formed, deformity is formed, and everything is formed. But which I believe I practice at my center is that the instant we label the individual as a diabetic individual, his feet becomes a diabetic feet. If you try and save that feet at the same instant, then and then only it's going to help us. Otherwise, we'll land up in more problems and more amputations. Thank you.
Thank you. So we do not call them as diabetic patient. They are people living with diabetes and not diabetic foot disease. Diabetes related foot problems. Okay, yeah. Thank you. So thank you all for the foot symposium. Excellent one. I think give a big round of applause for each one of them. And now we move on to the next talk, which is very different. I asked my fellow chair to do it.
Thank you, sir. So our next speaker is Dr. Mahendra Narvaria, and he's going to speak about the weight loss surgical, who, when, and why we need to treat them. And he had done surgical gastroenterologist, bariatric, and robotic surgeon. He is a famous chairperson and AB Plus Specialty Hospital at Ahmedabad and Surat. He has received Limca Book of Records for the youngest bariatric patient, aged 4 years and 10 months, for operating on 20 patients in a day in 2014. He is recognized as Gujarat Gaurav and a 2019 Times Health Icon, awarded at the Bharat Navratna in 2023. He is the pioneer in first laparoscopic sleeve gastrostomy in India, first scarless sleeve gastrostomy in India, first hybrid nodes transvaginal sleeve gastrostomy in Asia Pacific region, and highest weight patient had gastric bypass surgery performed by him, weighing 248 kgs. First time in India, for pioneer in new procedure after revision of RYGB. He is metabolic surgeon and renowned for hypercholesterolemia in lean patients. He is a pioneer of bariatric surgery in India and has performed 20,000 plus bariatric surgeons, GI, robotic, and laparoscopic surgeries. So we are introducing Dr. Mahendra Nevaria. We welcome you on DRS.
Thank you.
Thank you, sir. Move to you.
Thank you, chairpersons. Thank you, Manoj and Purvi and Dr. Bansi, my close buddy. Thank you for inviting me. I'm the only old person here. I'm a surgeon speaking in front of the august audience and learned scientists, we call. So obesity is a medical disease which needs a medical treatment. It is not a cosmetic problem. We know that a lot of complications are there because of obesity. If we don't treat it, the risk of hypertension about 5 to 6-fold, diabetes is about 3-fold, hyperlipidemia 2-fold, different type of cancer, osteoarthritis almost 2-fold, and it leads to gallstone formation, it leads to fatty liver, and nowadays NFLD or MFLD, and cirrhosis is the commonest sudden death in few patients, low backache, impotence, infertility, menstrual disturbances in females, psychosocial issues, depression, suicidal tendencies, different type of cancer like colorectal cancer, gallbladder, breast, endometrial cancer, and cervix, hiatus hernia. And these patients, if they develop accident, the injuries are more severe than the normal people. So we need to operate just to prevent these illnesses in these people. Now, whatever we do to treat obesity, we need treatment which is a lifelong, because it is not a temporary disease or not a short-term disease. Since obesity is a lifelong disease, we need a lifelong treatment. If we talk about treatment part to treat obesity, we know about diet, which is helpful about 5 to 10% of weight loss if it is being modified for the whole life. Similarly, to lose 1 kg, you need to burn about 7,500 calories. Means somebody who is 40 kg need to burn about 3 lakh calories, which is again very difficult. A normal person can do exercise, but a person who is morbidly obese cannot do effective exercise. And if they do, sometimes they develop complications because of the weight itself, like joint pain, injuries to tendons and muscles, and they cannot continue exercise for the whole life. Similarly, medicines, last 40 years, 40 different medicines were discovered, but none of them could stay longer. We recently, last 3 years, we got newer molecules, GLP-1s and analogs, and the combination of GLP and GIP, and like tirzepatide, having a promising result, saying about say 20% of weight loss, but we need to believe that it has to be lifelong. Who can afford these medicines for the whole life? And we don't know the lifelong complications of these medicines as well. So obesity is a serious chronic disease which needs a serious chronic treatment. Surgery is option for morbid obese people, and prevention is when you are overweight, we can avoid obesity. There was a consensus meeting in America in 1991 wherein they invited all the experts dealing with obesity, whether they were diet specialists, exercise experts, physicians, surgeons, endocrinologists, everybody, and it was concluding that consensus meeting in 1991. Just imagine, almost 35 years back. that bariatric surgery is the only proven method to control weight loss. It does not remove, it does not lead to removal of the fat. It is not a cosmetic surgery. Surgery is adjunctive and not curative, in the sense you need to have a modification of lifestyle even after surgery to maintain the weight. These are the indication of obesity surgery, bariatric surgery. These are the universal indications, like BMI equal or greater than 40, but in India we changed these criteria to in 2008 to 37.5 without any comorbidities, or BMI equal to 35. In India it is 32.5 with significant comorbidities, and there is documented effective non-surgical attempt of weight loss at least up to 6 months and committed to long-term follow-up. Individual risk-benefit ratio need to be evaluated in every individual to offer the surgery. These are the criteria for bariatric surgery in adolescent group. Adolescent patients are only considered after failed attempt of weight loss for at least 6 months, attain an early physiological maturity. Severely obese who are more than 40 BMI with serious comorbidities are offered, or super obese who are more than 50 BMI with less severe comorbidities can be offered bariatric surgery. They should be capable or willing to come for follow-up, and provided the family is supportive to follow these people. So the goal of surgery is not only to reduce weight, but also to improve the quality of life and to improve the associated comorbidities which are there, like diabetes and hypertension. How bariatric surgery works? Bariatric surgery leads to reduce appetite, reduce satiety, after alter the taste of food, restrict the intake. It leads to malabsorption of nutrients. It increases energy expenditure, and certain aversion of food also effective in losing the weight. These are different type of surgeries. We have predominantly restrictive surgery, malabsorptive surgeries, and we have a combination of restriction as well as malabsorptive surgery. This surgery, which was started in 1952, which is very, very old. Those days it was done by open technique, so people were not opting for it. But since 1995, it is being done by laparoscopy, and surgery can be performed in half an hour to 45 minutes to maybe maximum by 1 hour, and person can go home on the same day or maybe within 24 hours. This was the gastric band, which was introduced almost 40 years back, which is not being used nowadays. It was only a restrictive procedure, putting a band near the G junction, allowing this patient. Here, patient need to go to a surgeon or doctor to get it adjusted repeatedly, and the band was causing problem because it can erode into the stomach, which leads to major complications. So this is discontinued, and nowadays we don't use it. I don't think India it is available in our country. These are the malabsorptive surgery like biliopancreatic diversion, wherein we remove the distal part of stomach and joining the ileum with the stomach. Here the food capacity is significantly high, but the bile and pancreatic juice is diverted to terminal ileum about 50 cm proximal to ileocecal junction. This surgery was developed by Professor Scopinara from Italy, and only his group is doing this surgery even today, which is less than 1% surgery in the world. The commonest surgery which was being done is Roux-en-Y gastric bypass, wherein we make a small pouch of stomach, then we disconnect the jejunum about 50 cm distal to DJ flexor, and then joining jejunum with the jejunum here, and the other part of jejunum is joined with the stomach pouch. So this is Roux-en-Y gastric bypass, and this is the final configuration. So one can eat small amount of food, and that will go through this route. This is called Roux limb, and this is the Y limb. That is why it is called Roux-en-Y. Another commonest surgery which is being done in our country nowadays is sleeve gastrectomy, wherein we reduce the stomach capacity from this size to this size, and portion of stomach is taken out. Here we have a G junction and we have pylorus, so it is a high pressure tube created in between two walls. The sleeve will increase in size, and after 3 to 4 years you start gaining weight, and that is when we have to teach this patient. A patient has to learn how to restrict the quantity of food so that sleeve will not enlarge in size. So the problem with sleeve gastrectomy, because of the high pressure, sometimes these patients, about 30% people will develop reflux, and 40% patient will come back for weight regain after sleeve gastrectomy. So I personally don't recommend and not do it, but we have modified the procedure. Another procedure is mini gastric bypass or one anastomosis gastric bypass which is being done. Here we divide the stomach, keeping a larger pouch, and that pouch is joined with the small intestine. The diameter of anastomosis is 6 centimeters, so there is no back pressure created. It will never increase in size. At the same time, one can eat more than the sleeve gastrectomy because there is no restriction. But here, the malabsorption is a major factor. So you need nutritional supplement for the whole life, and your protein intakes should be very high in these patients. I usually recommend it to those who are having more than 50 BMI and weight loss requirement is more than 50 kg. This is a combination sleeve and MGB wherein we just join the loop here with the sleeve. So sleeve pressure is reduced by joining the stomach, the jejunum here. And this is another modification of Ru and Y combination. So we join the Ru limb here. So food can go through this route to this route, and at the same time it will go through the main route also. So nothing is blind, and we have access to duodenum and the whole GI system by endoscopy. So this is the preferred surgery by me nowadays, because here we can achieve benefit of both sleeve and Ru and Y gastric bypass. The quality of life is good. There is no nausea, vomiting, and they can lose weight. And we can customize it according to the need. Like we can change the length of the biliopancreatic limb, and we can change the length of Ru limb depending on the requirement of their weight loss as well as the resolution of the comorbidity. And this is how it is being done. This can be done in patients like cirrhosis like this. We have significant number of patients who underwent surgery, and here these patients are not fit for transplant because of the cirrhosis and weight. BMI is too high, so we reduce their BMI by doing this surgery, and they are candidate for future transplant. And the transplant, they can even delay the transplant if we lose the weight. And this is our publication on cirrhosis in bariatric surgery by my team. Similarly, we have designed a surgery wherein we don't cut the stomach and just do the suture like this. And the problem here is because if the two valves, there is high pressure which is created, it will increase in size. So just to avoid that, we can put a loop jejunum here to decompress it, and we can achieve the similar. And this is a randomized trial which I published in 2009. This is all being done by laparoscopic. It can be done by robotics. It can be done by single puncture like scarlett surgery. And these are the benefit of this surgery. This is a article published in year 2000, almost 25 years back. The results of 500 patients of Ru and Y gastric bypass, wherein type 2 diabetes is resolved in 95%, cholesterol in 97%, hypertension 92%, cardiac improvement in 95%, osteoarthritis means you can avoid the joint replacement in almost 82%, sleep apnea in 75%, and stress incontinence and GRD in 87 to 98% respectively. This is my youngest patient of 3 years who underwent surgery. She is 15 years, who has severe psychiatric problem, and now she is disease free without any treatment. Now this is when she graduated. It's 10 years, and she is 9 years, and he was 4 years 10 months. Now you must be thinking, why I do pediatric patient? Look at this girl. This picture is shared by my friend Dr. Ramchandran from Kota. Look at this girl of 11 years, and look at her bone. So these kids, they develop deformities because of the weight, and we need to treat them. And similarly, this boy of 254 kg with almost 100 BMI, I brought him to 84 kg. Losing 177 kg by surgery is possible. And similarly, this girl of 23 years who was 206 kg was brought to 60 kg. And this is bedridden patient of 83 years. For almost 11 months, we brought him, we did surgery, and now he is able to walk. And this is the picture after 10 years. With this, I conclude my talk, and thank you so much.
Thank you, sir, for extensive surgical intervention in obesity. A small question from my side is what's the preferred technique for diabetes?
So it all depends on the duration of diabetes. Even up to 5-year diabetes, even sleeve gastrectomy is sufficient to lose weight and have resolution of type 2 diabetes. So the early
Only the surgical technique I'm talking about.
for diabetes.
Yeah.
So Roux-en-Y gastric bypass, mini gastric bypass, we have ileal interposition with duodenal switch. There's so many varieties of surgery which can be offered to these patients. So we have ileal interposition wherein the 170 cm of ileum is interposed between the duodenum and the jejunum. So that is another topics are not covered in this, but there are so many varieties which can be offered.
You did show this also as well, one of the slides. Right. So thank you for that. And secondly, the take-home message post-op.
These patients need to follow with the surgeon lifelong. That is what is very, very important. We need to do a nutrition assessment and including the laboratory tests every 3 months for first year, every 6 months for the next 4 years, and once a year for the whole life. And they need supplement for the whole life.
So both micronutrients, you mean to say the supplements should be there?
Yeah, micronutrients.
And lifestyle need to be for life, right?
Yes.
Thank you, sir. Any other questions, please, from the audience?
Thank you, Dr. Narora. It's a beautiful presentation. Now we have medical therapies which can reduce body weight up to 25%. So if we'll see surgical versus medical therapies, so what is your take on that? Who are the patients whom you will expose to surgical? Because of course you are doing a surgery. Here with medical therapies, 25% weight loss is quite significant because in your surgery that much you have lost. So what is your take home from that point of view?
See, newer medicines have weight loss of 20-25%. I agree, but we need to understand that we have to take them for the whole life. Muscle loss is a major problem. If these patients, they can't eat because of gastroparesis and suppressed appetite completely, they cannot eat at all. If they take a high dose, that is where the maximum weight loss is achieved. In bariatric surgery, they can eat because there is no gastroparesis or paralysis of the organ, and they can eat well. So the muscle loss is comparatively less compared to the medical management which we offer. In my practice, I offer these medicines for those who are not reaching the target or those super obese patients, sometimes who are not fit for surgery. We bring them to some level, improve their health status, and then we take them for surgery. And those who are regaining weight, we again start them on the newer medicines, AOMs.
Thank you.
Thank you very much. Congratulations on your highly skilled techniques. I am a pediatrician and interested in your bariatric surgery in adolescents. How many of those you operated rebound the obesity and regained their weight? How long have you followed them up for? Thank you.
Yeah. See, most of time, 70% of these patients are able to maintain, 30% will have regain. Most of them who are having syndromic obesity will regain. I have done many syndromic kids also. The reason is just to have a better quality of life and better nursing. Like the parents can take better care. Otherwise, we cannot cure their disease by bariatric surgery. So we've done Prader-Willi syndrome, we have done Down syndromes, and many syndromic kids underwent surgery. Those who are healthy kids, they do maintain very well, and they attend their good lifestyle, and they can maintain the weight.
Thank you.
Thank you so much, sir. I request Dr. Amit, Dr. J.C. Thomas, and Dr. Vaidya for the felicitation and the photograph.
Moving to our next session, DRS Spotlight, Diabetes Through the Gender's Lens. I would like to call up our moderator, Dr. Usha Shriram from Chennai and Dr. Purvi Chawla.
Good morning, everyone. We welcome you to day 3 of DRS Cody. And this session is definitely of particular interest to me. And we have a legendary panel, if I may say so. And it has been curated by none other than Dr. Usha Shriram herself. And we all know that she's one of the pioneering, she's one of the experts in the country who's done pioneering work in this field and continues to guide us and inspire all of us to develop that focus and work in the direction of diabetes and women. So without much ado, may I welcome ma'am to just set the context and invite our panelists.
Good morning, everyone, and thank you, Purvi, for very, very kind words. Thank you very much. And I'm so excited that Purvi and Manoj, while organizing this program, have dedicated a session to this really important topic, which is looking at diabetes through the gender lens, because for long we've always thought diabetes is diabetes, one size fits all approach. And as we know, and as evidence has accrued, that diabetes is a very different animal when it comes to women. The adverse outcomes are more and more severe, and I'll discuss some of the actual numbers as we go along. But it's really important to look at it through the gender lens, not just to look at of course, there are biologic differences, but also the lived experiences of girls and women with diabetes, how the health system treats women with diabetes, and how women themselves look at any chronic disease for that matter, particularly something like diabetes. And so we'll try and put all this together. And more importantly, since we have such an amazing group of women who are going to be discussing this, the experts who are here, international experts like Professor Juliana Chan and Professor Asma Deep, and we have fantastic person from the Mumbai Municipal Board Corporation. And of course, Professor Neeta Deshpande, who not only is an expert in women's health, also her focus on bariatric health, I think brings a special dimension to this discussion. So without further ado, again, let me invite all the panelists. Purvi, you want to invite them? Sure.
Professor Juliana Chan, please.
Ma'am is a senior endocrinologist and one of the best epidemiologists in the world today. And with her body of work, I think we are all set to get some questions on, our gender disparities really coming out in clinical trials. Welcome, ma'am. We also have with us Professor Asma Deep. She's a senior pediatrician with a lot of focus on women's health and also type 1 and technology use. She's multifaceted, and again, I think we'll get a lot of insights into what we want to bring to the fore today. Dr. Neeta Deshpande, a leading obesity management expert, a bariatric physician from Belgaum, and she is, everybody knows her here and outside, even for diabetes remission work. And may I welcome Dr. Neeta Deshpande. Dr. Daksha Shah, I think this was a much needed, a track that we wanted to discuss, and we couldn't think of anyone better than Dr. Daksha Shah in Mumbai in particular. She's the executive health officer in the Mumbai Municipal Corporation scheme, but she does some outstanding work in the field of NCDs, and she's been leading. I mean, it's surprising that such great work is happening in our corporation hospitals itself, but it's all being led by her, and we invite her to the panel as well. I'm going to take a step further, and this session has been very well curated by Dr. Shriram ma'am, but I'm going to request her to actually join the panel and not moderate it.
Sure, thanks. Go ahead.
Please take seat, yes. Andolan. Almost everyone, right? Beti Padhao and Aage Badho. That we all know that. But how many of us are really aware of any awareness programs or any public health drives in our nation today by the government focusing on NCDs, particularly in women? I am very, very happy to see that at least our social media handles from the Ministry of Health and Family Welfare is now taking some extra efforts in sort of posting things in obesity, in NCDs, and their general awareness messages. And that's great because PM Modi also talked about the Fit India movement recently, a few months ago, and it's getting some impetus. That momentum is coming up. But at the same time, how many of us are really aware of what is going on and what is exactly, where are the gaps? Why are we not focusing on this huge burden of NCDs in women? And because that's going to take us a long way in actually preventing the next generation from suffering from it. So, that's the entire focus of this discussion, and we are hoping that we are actually able to come up with something in writing as well and publish it so that we can get more actionable items from that. So, Professor Chan, I'm following very actively, but I can see majority of the studies are focusing on the cardiovascular health and differences in men versus women. But do you really believe, as someone who's a global authority in this, are there enough intersectional studies considering not just gender but also class, ethnicity, and geography in diabetes research?
I think I agree there is a huge data gap in this area. As you already pointed out that, there are huge differences between men and women. Women, 50% of the world population. And biologically, but also there's culturally, also socioeconomically, behavioral, all very different. And I think, diabetes in women, it really represents a opportunity, where we can prevent this, diabetes begetting diabetes. That they can influence the transgenerational diabetes. So I think there is really a gap of knowledge. I think we need to have some dedicated research documenting really the life course of a woman with or at risk of diabetes and their subsequent generations in order to make a difference. I think these data collection are very important to drive actions.
Fantastic. Thank you for, consolidating all our belief that there is a data gap that exists, and we probably have to attempt to bridge that very quickly. And it's not going to happen just with registries and stuff, but we really need to have large-scale studies with different parts of the country also involved. And I think that's pan-Asia. So that's the point well taken. And I think you alluded to a very good point that, diabetes or, women, it's a great opportunity, and we should look at that window of opportunity. And that brings me to my next question to Dr. Deshpande. Gestational diabetes, a great opportunity, completely missed actually, except the last few years that we're talking about it and bringing it in focus. So obviously the numbers with every IDF atlas, we know they are just exploding. The prevalence has increased. But as a physician with special interest in bariatric medicine, how do you feel that the challenge of maternal obesity can be tackled at an individual, community, and then at the policy level?
Well, you said it well that gestational diabetes is now exploding, and we know that obesity is one of the major drivers of getting gestational diabetes, major risk factors of getting gestational diabetes. However, although we have been talking about it amongst ourselves, amongst the HCPs, how much of this is actually percolated down into the community is the question. We don't see many people coming for preconception obesity treatment, which makes life much easier in terms of gestational diabetes reduction, obesity reduction in the offspring. So none of that is happening. So I feel that more than anything else, at the individual and at the community level, a lot of awareness needs to be created for preconception counseling, for checking for obesity, treating obesity before even thinking of conception. It's not easy to do because not many people are aware that obesity can be the major driver for gestational diabetes. So a lot of work needs to be done, I feel, at the community level rather than just, it has to go hand in hand, or it has to run parallel with the awareness that we are creating among the HCPs. So a lot of work needs to be done in that. Nobody is coming to us for preconception other than if the gynecologist feels that this lady needs to lose weight, or if it's a case of PCOS, then okay, they come for preconception obesity treatment, but otherwise it's not happening unless it's for cosmetic reasons.
I think India has done great on the screening front for gestational diabetes as far as that universal screening goes. But any thoughts on how can we make a policy change in this matter?
As far as a policy change is concerned, I think people talk about blood glucose as being the fifth vital sign or the fourth vital sign. I think at least for starters, body mass index should be. How many of our GPs or how many of our primary care physicians really bother to measure the BMI and tell the patient at what grade of obesity or otherwise the patient is at? It doesn't happen. So unless our general physicians at that level are told that please tell your patient that you need to lose weight, a simple sentence, like it's like smoking. So everyone knows that they should not smoke, but that one line from the physician is so important to reiterate every time. And in the same way, if the body mass index is considered as a vital sign, just like pulse rate and the other things, then I think we can go a long way in creating that. So that's not exactly a policy change, that's a change in practice. But as far as policy is concerned, there are n number of things that can be done. Packaging labels, making that compulsory, keeping calorie count in hotels, in every small little hotel. So there are a lot of things, and a policy change can happen at the level of the school. I think that is very important, on what is kept in the cafeteria, uh, the teaching that goes on to the students in schools about what they should eat and what they should not. So in that sense, a policy change can come at the level of the school, it can come at the level of the supermarket, and sugar tax maybe. So a lot of things can happen at that level.
Thank you for bringing up that built environment that maybe we need to aggressively target that and bring about changes there itself. But you alluded to preconception care, and I just cannot think of anyone else but Dr. Usha Sriram to ask the next question. So, ma'am, why is preconception care your pet peeve? And again, at the individual level, how soon should we start talking about it? And at the policy level, what can we do? Some high level thoughts at least.
Thank you, Purvi. First shining the spotlight on this very important issue, because just as a segue from what Neeta just said, prevention of gestational diabetes can only happen if we start things before the pregnancy, because repeatedly we have seen anything that we start after the pregnancy has started really doesn't provide much, doesn't have much of an impact. So everything has to start from before the beginning, as they say. And unfortunately, across the globe, preconception care, there is somehow the adoption of preconception care has not been good, even in countries where there is a established program and people think about. So majority of pregnancies in low and middle income countries are unplanned. Even the ones that are planned, when we say they are planned, they're only intended pregnancies, but they're not like planned in the way we are thinking about it, not metabolically or otherwise planned. So if you look at it that way, most of pregnancies are unplanned. So when you have unplanned pregnancies, everything from unsafe abortions go up. Pre-existing conditions. There was a recent audit from the UK which showed that women with diabetes, even with established condition like diabetes, there is very little preconception care, even when the services are available. So people with pre-existing conditions do not get the necessary care. The third one is the health of women of reproductive age, 15 to 49, whether you look at the NFHS 4 and 5, or you look at independent studies, we see a lot of multi-morbidity, not just single morbidity, but multi-morbidities in these women. So the health of women of reproductive age of today has changed a lot. Pre-diabetes, obesity, overweight, thyroid, vitamin D, mental health issues, and other risky behaviors like smoking, drinking, medication, so many things like that. So we have all of these as well. And then, of course, going in things like polycystic ovary syndrome, other conditions. And as practitioners, whether it's OBGYNs or physicians or GPs, we're not getting into looking at women's life cycle. When we see a patient in our office, we're only seeing them as a person with diabetes or as a person with this, but not as a woman of reproductive age. Or, just ask that one key question: what is their reproductive plan? So all of these have to be factored in. It's actually not that difficult. As we heard in the previous talk, it's not a cakewalk, but it can be.
So I think that sensitizing is extremely important, because once we develop that gender lens, I think at least start with the key questions and then start intervening accordingly. We have Dr. Asmadeep, and till I'm completing my first round of questions, audience, gear up for your questions because we are going to, have you ask them yourselves. So, Dr. Deep, adolescence is a very, very precious development phase where they are neither completely in charge and not completely unaware. Obesity in adolescence is rising globally, and at least in India, it's a huge challenge now. And I think the pandemic really worsened the scenario completely. And in fact, we have been seeing so much of adolescent obesity around and people coming to us for help, and that's actually a positive change that they actually want to get treated. What is your experience and how exactly can we tackle this age group? We would love your expert comments on this.
Thank you very much indeed, Perry, for this. And I thank you specifically for including me as a pediatrician amongst the expert panel. Very good question. Juliana started by saying there is a gap in the literature about studies and diversity. And I cannot agree more. In fact, I would like to widen that gap when we talk about adolescents and pediatrics. You are all aware of how difficult it is to run research in pediatrics and how difficult to recruit pediatric patients in research. So my adult colleagues, if you have a gap in your literature and studies, I have even a wider gap when we talk pediatrics. And this is really interesting and puzzling me. We've heard yesterday our politician talking in this very podium saying that a country like India is a young population. The same applies to the Gulf. Yet, we have one pediatrician in a panel of 5, and we have much less work and research and clinical trial. So many of your questions, Bervi, in adolescent, will unfortunately remain unanswered. But to answer your question about obesity, and I like such panels to be a little bit more provocative, we need to pause and revise the definition of obesity, because if you rely in adolescent that obesity is BMI centile, then we might be leading ourselves in errors. If you look at India in particular, then prediabetes, PCOS, and others are in fact more common in malnourished girls. So are we taking the wrong definitions to come up with wrong conclusions? There are multiple studies in India which shows that girls with malnourishment, those who have a little bit of higher waist circumference, are in fact carrying more risk of obesity comorbidities like prediabetes. I'll save some of my comments on PCOS if you have questions about that. But if people are talking longevity, and that's the case nowadays in United Arab Emirates, so they say we need to make elderly people live better. You can't do that unless you start from pediatrics. In fact, like you said, start earlier. Look at the fetus, look at the newborn, school children, and then you can guarantee better geriatrics. So I can talk forever, but I'll leave the chance for my co-panelists.
Thank you so much for those very cogent comments. And I think they're all very well taken and gives us a lot of food for thought for further discussion. Let me rope in our public health expert from Mumbai Municipal Corporation, Dr. Daksha Shah. Closely working within the corporation, and you probably are more exposed than all of us to that strata. Do you see the burden of NCDs in as high as in the private sector? And what are some of the challenges you see at the clinic, BMC clinics, in women with diabetes in particular?
So thank you, Purvi, and Greetings to all the co-panelists. See, as far as the burden of diabetes or NCD is concerned, I don't think so there is a difference between public and private sector. So let me clear out that very clearly. We should see the city as a whole, the Mumbai city or maybe a district or the state. And what is the burden of NCD over there? So do we have the sufficient data? So I would first say that we have done WHO STEP survey in 2021 and we published in 2023. And we have found that the diabetes prevalence is around 18% in the age group 18 to 69 years. And in that itself, we have seen that amongst the women, we have 21%, and amongst the men, it was 16%. So there we found that 5% higher rates of diabetes in the women. Similarly, for all the parameters which we measured in WHO STEP survey, we found that women, diabetes, pre-diabetes, everything is higher. The cardiovascular risk factors over 10 years is more than 20%, and amongst women again it is more, that is 8.8% compared to men 7.7% something. And as far as treatment is concerned, amongst the treatment seekers, we found that the woman is less taking treatment, 5% less than the men. And as far as diabetes control is concerned, around 42% control we have found amongst those who are taking treatment, who are diagnosed diabetes, and in that amongst the men, we found 50%, while amongst the women, we found 35%. So on an average, it was 42%. So again, the diabetes control was less amongst the women. So we all know, I think Dr. Neeta also described, Usha also described about various barriers which is there. So the same barriers, we see it in even the BMC clinics. There are social barriers, economic and, cultural barriers. Like women don't come out. They don't seek care early. And of course, even among the lower strata, I would say that the women are really burdened with so many other responsibilities. They are also the breadwinners in so many families, and they will put their health the last priority. So family, children, relatives, and all that, and then they are earning. So this all multiple, pressurizes them not to come to the clinic. So what we have designed is we have ASHA workers and PHVs who go door to door. So we have started these door to door services where every Wednesday, like we have fixed one day, where our ASHA workers will go in the houses and they will screen them for NCDs. We have CBAC scoring about the high risk, risk factors, and then they will promote this opportunistic screening of the women as well as the men, of course. But most of the time we don't get them because they are at work. And we measure the blood pressures and we promote them and we push them to come to our clinics to do their diabetes screening. So this is one proactive measures, as you were saying, that they are not much done on the public front. Yes, there are a lot of things which we are doing. The second thing I think Neeta was mentioning, Madam was mentioning, and you also mentioned, about the adolescents. So we now have a RKSK Karyakram, that is Rashtriya Kishore Swasthya Karyakram, which is now very much part of the government initiative. It's a comprehensive public health initiative which covers the age group between 10 to 19. And it has key 6 initiatives where the nutrition counseling, mental health, substance abuse, sexual violence, and of course the NCD is a part of that. And we have started the adolescents friendly health clinics. So these are the initiatives which is just kind of starting, or it is in a process of starting. So we are also kind of planning establishing some adolescents health clinic this year in BMC area. Around 33 is our target, and we are kind of taking baby steps. I would say that there is a beginning somewhere, and the difficulties and the barriers are there. The system barriers are always there, but we are trying to overcome by improving the access. Like if you have every 15 to 20,000 population, we have health and wellness center. As you know that the government have a mandate to now start a health and wellness center for every 20,000 population. So that to improve the access. So we have started such Apla Davakhanas in all over Mumbai. Plus we have yoga centers. Now what we have found is today itself also we have 130 yoga sessions going on in the morning. And these are very near to the communities. And what we have found is that the woman uses this yoga centers more because, the houses are so small in the slum areas and they want to utilize these services. So I'm very glad that we could now do this yoga centers and this concept of health and wellness center bringing near to the community. So such initiatives are there, but yes, there are still barriers and we are trying to kind of connect with the community through our health centers, through our staff, and we are sensitizing and we are trying to develop our TOTs, like, some of the ambassadors, we are asking the CHVs and ASHAs to be the part of this initiatives. So I hope, some of the initiatives I've described and it's happening in the field.
I have good goosebumps as you speak. This is fantastic. Very, very heartening to know you've actually cleared the air around what the corporation is really doing in the health sector, and particularly in the NCD space. And I think we need more leaders like you to actually even talk about it and make everybody else aware about what is going on. I think the picture is very similar to what's happening to the type 1 diabetes care in our country. We do not know enough of your initiatives, and that's why there's no partnering, there's no collaboration, there's no scalability of that to the private sector as well, because everybody seems to be working in pockets.
Just adding it to your thing, partnerships. We do have, partnership for healthy cities, Bloomberg initiative who is partnering with us. We are also roping in multiple national, international NGOs to take this forward. Like, you cannot do everything the government cannot do. So we need to have the partnerships. CBOs and NGOs have been roped in. Some of the NGOs like Sneha and so many other NGOs who are working with us. And, in the space of adolescence clinics as well as others, we have roped in the nutritionists. Like, we had partnership with Indian Dietetic Association, and we had roped in the dietitians who go every 15 days to our clinics. And especially they have the sessions with the women. So within the communities, those Mahila Bachat Gat and those Mahila Mandals and all that. So we are having a community sessions also. Then there is this nutrition month, Poshan Abhiyan, you might be aware of it. And individual targets are given to our primary health centers. And there's close monitoring. We have an NCD wing now, and we have been doing a lot of campaigns. I brought one campaign if you would like to play the clip. We just launched in the month of February for the awareness.
Thank you. Thank you for that. Let me open Dr. Juliana for the next question. What kind of gender responsive policies, we know that, again, there is good work happening in, say, N of 1 as compared to all the multiple thousand districts or lakh districts that we have. But what is your suggestion? What about the gender responsive policies that the governments and professional associations like the RSSDI or other bodies, what can we do for both research as well as new initiatives?
I think we have heard some very, exciting initiatives from India. I think they can really serve as an example for the rest of the world, because, I forgot to mention, that we have this multi-centered Joint Asia Diabetes Evaluation Program register, where we have recruited more than 120,000 patients from 11 countries from Asia, and really reinforce some of the observations that the female patients were actually having worse risk factor control, particularly in lipids. And very interestingly, while the men were more likely to smoke, right, the women were actually less physically active. And I think that's really very important, that how we can create opportunity for these women to really do some exercise. And yoga is, of course, one of the really proven strategy to improve physical health and probably also improve glycemic control. The other thing is the waist circumference is also very interesting. Although women had lower BMI, but they actually have larger waist for the sex definition. And we know that the central obesity might be related with emotional health. And on that basis, we also know that women are also more prone to develop depression and distress. And these will also be very responsive to peer support. So having this kind of community-based program, right, where you can address physical inactivity at the same time providing peer support, I think this is very, very interesting. Now, of course, those occasions, this is really where they can actually start learning more about, women's health, right, their impact, the impact of their health on the second generation, on their generation. I think a lot of women don't really know that during that 9 months, right, they can have a impact on the future development of the child. And there's a lot of studies like HARPO have already shown how intrauterine exposure, right, to hyperglycemia can have a long-term impact on child obesity and also hyperglycemia. And the important point is, I think it's just all about literacy. I think women, once they realize that they have very, very strong motivation for, to improve, themselves and also to improve the patient's health. And what we observed, right, in these different countries, we also found a lot of diversity, and education level is very, very important. Women with higher education level, they really do tend to have better health than men with higher education level. So, so this is really societal. So I think we must elevate the educational standards of women, right? And I think with that, they will help the husband, they will help the children, they will help their parents. But I think with a lot of community support. I think medical policy is important. Universal screening for gestational diabetes. It has to be, has to be put in place, because that is one opportunity where we can identify high-risk individuals, right? And then these people should be followed up, systematically followed up. And that is the opportunity to also evaluate the children. But what I really wish to emphasize is these data should be documented and to evaluate the impact and the program, because those data would drive policy change, because there are many, many competitive needs, right? And I think policymakers really want to hear this data, and we as practitioners would also want to see the impact of these practices and policies as well.
Fantastic. I think it's fantastic. I mean, I'm so happy that we're doing this panel because it's not now N of 1, it's at least N of 6 who are speaking the same language and bringing out, important points. And we must come up with an action point from this particular panel discussion. Any questions from the audience? Okay, so I'm going to move on. Yes, please.
Yeah, hi, fantastic discussion. Just a small query. So nowadays, young women are more prone to PCOS, and most of the young women have a fear for taking treatment, whether they are very much comfortable to go to lifestyle modification. So just wanted to know that is diabetes preventable, or is it getting delayed while they are on the PCOS treatment? Or what is that timeline they can end up in diabetes in the future if they are on treatment or not on treatment?
While all of them can, give you fantastic answers on that, I'll request Dr. Asma to start.
You might regret choosing me. You might regret choosing me because I have lots to say about the terminology of PCOS. Perhaps by the end of the year, you will stop hearing the terminology. There is a lot of work that's happening at the moment to correct the PCOS. We can talk forever about it, but that might be a side issue. PCOS is based on clinical criteria of menstrual irregularities and hyperandrogenism. That has nothing to do with cysts in the ovary, so this is just a side issue. Now, your other point is critical about people with PCOS and their relationship with prediabetes and diabetes. And I'd like to go back to the story of the definition of obesity and take young girls in India who are not obese by definition, but they have the metabolic prerequisite of having metabolic abnormalities. So we should move towards the modern medicine of definitions. People with obesity not necessarily are more predisposed to prediabetes and PCOS. It depends on what you mean and what your definition with obesity is. Are you basing that on just BMI? Or are you measuring the waist circumference and taking note of the genetic predisposition of prediabetes? So lots of complex things, and the way to treat PCOS is variable. Again, you have lean PCOS, you have girls who are defined as obese with PCOS. So are you going to start OCPs? Are you just going to start metformin, or would you rely on lifestyle modifications? lots and lots of. I think this needs a panel in itself. So I'll stop there, Parvi.
Thank you. I took the point on peer support. I'm going to expand on that because I think we don't talk enough about peer support in the chronic ailments, particularly type 2 diabetes or obesity, and particularly women. I would like to bring that forward also because education will be the backbone of that peer support initiative also. But I would love to hear from our experts, Dr. Deshpande and Dr. Shita. Can start.
On peer support?
And education.
Oh, I think that's absolutely critical. And even just to continue this PCOS discussion, if I may. Um, so the woman with or girl with PCOS and their family are primarily concerned about the menstrual irregularities and acne and hair growth and hair fall. But I keep telling them that's you are primarily concerned about that. But I am more concerned about the 4 to 7 times higher risk of diabetes or the metabolic, the liver disease and other issues that are cardiovascular disease. Those issues are, top on my list, and that's very important for us to. So as we talk to our patients with PCOS and their families, it's really critical to constantly keep bringing up the metabolic health of these girls because they're at higher risk for GDM, they're higher risk for type 2 diabetes, higher risk for cardiovascular disease, mental health, liver disease, all of those things. So that education coming from us is really important. But coming to your question, I'm a very big believer that what we need now is a campaign, big campaign on the on diabetes in girls and women, which will include all of these aspects. And this can be, come down from the government, or it can be public-private partnership, or even a private initiative, or RSSDI, or anyone can take that up. Something like the Go Red in the US that has completely changed the trajectory of heart disease in women. Before the Go Red was started, heart disease was going up like this in women in the US. As soon as they launched this, just an education program, not only it's come down so much, so that it has actually shown tangible results. So education at every level, from school level, community level, workplace wellness. This year's IDF theme is that workplace wellness. Everywhere, if we keep introducing the concept of how women can be both aware and what can they do to stay healthy and metabolically healthy. I think it will benefit a lot. And of course, all the professional societies can take this up in a big way.
Well taken, ma'am. Dr. Meeta, so with respect to adolescent obesity, I think that's really one of the areas of my interest because I think that's the turning point in the trajectory, in the life course, because, there's a lot of autonomy that gets self-taken at that point. So what is the best strategy you feel that we make them aware and make them make tangible changes which will result in better outcomes?
Yeah. Like I mentioned before, if you look at adolescents, right, I would say from the 8th grade onwards, you would want to call them adolescents maybe. So from that until the junior college and the first degree college. So a lot, they are actually, because I have been doing a lot of these programs where I address the students and they come up with a lot of questions. So what I feel is that more such lectures and programs, and then talking to the authorities in the school or college for initiating or bringing about this awareness program, this you can have workshops for them where they understand where they are headed metabolically. Everyone talks about other things, and of course they're worried about the cosmetic issue, but once you talk to them about the metabolic implications of what they do now or do not do now in terms of lifestyle and activity, they're not going to understand. They have a rough idea that obesity is not good, diabetes is not good, but they don't know how they themselves can actually prevent it, what steps they can take, one, two, three, four, and they're simple ones. Screen time, for example. Give them alternatives of what they can actually do to make life easy, to make life pleasurable other than the screen. So, this kind of a comprehensive program at the level of the school, not much time is given. They are not given even two. That's what we found out in the schools, that the syllabus is so big, there's so much to be covered, that if they have uh, 1 hour slot every day for playground, that is taken up by teachers who are rushing to finish the syllabus. So they end up with just 2 such periods in the entire week. So it is taken away from them, as if those are times that you can just draw upon to do other things. So it becomes an option rather than a compulsion. So there are various things you can do at that level.
But to begin with, I cannot agree more with you, because I think, and a lot of smaller studies, because we don't have a countrywide registry or countrywide initiative that any association has taken to study this. But there's
Actually, if I may interrupt you, 10 years ago, we did a survey on 3,000 children. So we took 1,000 children from government schools, 1,000 children from partially aided schools, and 1,000 children from completely private schools. And we studied their screen time, how many times a week they ate outside, what their BMI was, and all of that. And now we are planning, after 10 years, to go to those same schools and do the same survey again and look at the difference. Because the screen time has increased, I'm pretty sure, because there was no Netflix even 10 years ago that much. So all of that we're planning to do in the same schools and see what we come up with. And maybe that could drive a little bit of policy at least the local level in our community.
And I think sleep, another important issue with that adolescent age group is sleep, and the sleep hours. So I think that's a very important point, but we don't talk enough to them where they can make tangible changes. Yes, Doctor.
I think the sleep is really, a lot of data now coming out. The pattern of sleep, right, is really associated with adverse cardiometabolic risk profiles and poor outcome. And it's very much related to screen time. Yeah, and I think, this is almost like a war, because we're living in a very interesting time. There's a lot of messages. And so it's really up to medical professionals, people who have the knowledge to really, balance, right, these kind of news, right? There's a lot of fake news, right? A lot of, sort of unrealistic expectations, right? Quick fix and myths. And so I think this is important, as Nita was saying, that it needs to occur at all levels, community, clinic level, school level. And starting with, it is a family-based business, really. I think women, gestational diabetes or polycystic ovarian syndrome, or even a young onset diabetic person, is already an opportunity for you to actually start identifying high-risk individuals with this family. And so that you can concurrently, implement prevention and also care strategies. I think it's a challenging time, but there's also, the opportunity to change the trajectory for both generations and beyond. Yeah.
Fantastic.
Just
Yes,
add
Dr.
one
Nisha.
thing in the school. You know about the Eat Right India campaign, right? So I think all the schools in the city of Mumbai as well as outside, they have this curriculum. Plus, there is a scorecard for every school that if they implement this physical activities, healthy initiatives, and all, they get certain points. Second thing is the critical thinking. You have to invoke among the students the gimmicks of the marketing. Reading the labels and how this food marketing has been done. I think they are very smart. The students, if you give them this analogy and this comparison, I'm sure that they are smarter than us and they will realize it early, the better. So I think this critical thinking component, and make them the ambassadors or make them the champions, and then they will then, you know, have a peer educator programs amongst them and just propagate those campaigns, and kind of a movement should be started in the schools, more than the schools, I would say colleges, because school is a control environment. While the moment they step into the colleges, they
more
are like
autonomy.
free. So there is the catch where we have to catch them. And I feel that we have done a couple of films and campaigns, but we need to do more. Let them be creative and create for themselves, you know. So I think empowering the students, especially the adolescents, and taking over their lives is more important.
One simple slogan that can, or a simple activity that can be done is for the adolescents and children is do not eat anything that comes out of a packet. Simple message. Don't eat anything that comes out of a packet. That automatically goes to whole foods and fruits and vegetables. So don't eat out of a packet.
Fantastic. This is actually my dream panel, and I'm so elated, and you know, I'm actually really happy, and it has been satisfying talking to all of you. I hope it has been the same for the audience, but you will see a paper from this coming out soon with all the thoughts enumerated. Thank you very much for this fantastic discussion. We could have taken the entire day, like Dr. Usha Sriram ma'am would, you know, have loved, and we should have that probably at some point. But thank you again, Dr. Chan, Dr. Deep, Dr. Neeta, Dr. Usha ma'am, and Dr. Daksha. Fantastic points brought out. Thank you again.
Thank you. I request Dr. Purvi ma'am to felicitate and thank you all beauties and brains. Thank you so much. What a wonderful session. So we are moving ahead with our next session, Solutions by Masters. I would like to invite our next chairpersons, Dr. Arvind Arjikar, consultant diabetologist at SL Raja Hospital, Mumbai, Dr. Balaji Chidambaram, consultant diabetologist at Meenakshi Hospital and Diabetes Specialty Center, Kumbhakara, and Dr. Rahul Dhope, consultant diabetologist at Jupiter and Global Hospital, Pune.
Welcome to the next session. We have two masters of diabetology who will be talking on this. I invite Dr. Vijay Panikar and Dr. Vijay Negrur, both Vijays, to the podium. Dr. Vijay Panikar will make the first talk.
Good morning, ladies and gentlemen. It's wonderful to be here at GEO. All nostalgic memories coming back of the 2023 National Conference here, which we had conducted. At the outset, must congratulate Purvi, Manoj, and their entire DRS team for the wonderful hospitality and inviting me to give a talk here. The topic given to me is pioglitazone and its combination, type 2 diabetes and MASLD management. Basically, if you look at pioglitazone, it has got this trifecta effect. It treats insulin resistance, metabolic dysfunction associated steatotic liver disease, abnormal fat distribution, and visceral fat becomes subcutaneous fat, and all this has emerged as a very powerful tool in addressing the metabolic abnormalities simultaneously. Insulin resistance in Indians, is the phenotype different? In fact, insulin resistance is very common in Indians. We are an insulin resistant population. All studies all over the world have shown that Indians have the highest insulin resistance in any ethnic group. You must have all seen this. This is Professor Yagnik from Pune on that side and Yudzik from Austria here. Both of them have the same BMI. But look at the body fat. So this has become the thin, fat Indians. Indians are thin but more fat. But unfortunately, that fat is more central. It's visceral. And if you see the Indian phenotype, you see the Caucasian. He's fat all over, chadya, absolute. But you see the Indian, his belly. When he enters the room, the belly comes first and he follows. That's a typical Indian phenotype. And insulin resistance, clinical consequences last. It is a cause for all those things. I won't go into the details. Now let us look at what are the implications of untreated insulin resistance. Increased risk of type 2 diabetes. Diabetes prevention studies have all looked at diet, exercise, pharmacotherapy. And in the pharmacotherapy, the glitazones have been the best, right from ACT NOW to IRIS study, which showed reversal or prevention of type 2 diabetes. And this was Ralph DiFranzo's study, which said that the annual incidence of occurrence of type 2 diabetes in a pre-diabetic was 4.1% for lifestyle modification, 1.7% when it is pioglitazone and metformin, and no occurrence of diabetes when you have a pio, metformin, and a GLP-1. So basically, pharmacotherapy, non-pharmacological therapy does not work. And if you look at the ACE guidelines, that for pre-diabetic, if you're overweight, then you go for GLP-1 analogs, and now you have the coagonists like tirzepatide. But if you're just looking at a dysglycemic goal, then you have metformin, pioglitazone, and acarbose. Treating early. So progression of type 2 diabetes depends on the beta cell. As the beta cells die, you have less and less insulin, so blood sugars rise, and that is what leads to the progression of type 2 diabetes. These are studies using sulfonylureas. You see initial good HbA1c reduction for 1 to 2 years, and then the HbA1c begins to rise, which is suggesting that the beta cells are dying and insulin is becoming less. These are 8 studies using glitazones. Good decrease in HbA1c, and it is maintained. What does that tell you? That the beta cell apoptosis probably slowed down or even prevented. And the main reason why this does is, if you look at the action of glitazones, there is a mobilization of toxic lipid metabolites out of the beta cell. Lipotoxicity is addressed, and that is how it prevents the apoptosis of the beta cells. Now let us look at the cardiovascular complications and the metabolic syndrome. Atherosclerosis, hypertension, dyslipidemia, and all these things. 80% of patients with type 2 diabetes have insulin resistance. These are few studies which show that insulin resistance itself is a major independent predictor of cardiovascular and myocardial infarction and stroke. This is the nurses' health study. I won't go into the details, but what it tells you is that the risk, elevated risk for cardiovascular disease begins at least 15 years before the diagnosis of diabetes. Let me repeat that. The elevated risk for cardiovascular disease begins 15 years before the onset of diabetes. So when you talk of treating diabetes, you're not just talking of glycemic control. It has to be multifactorial because there are other factors which are responsible for cardiovascular disease. Is there evidence that treating insulin resistance will work? For treating insulin resistance, you have diet, exercise, weight reduction. Pharmacological, you have metformin and pioglitazone. You now have the GLP-1 analog semaglutide, and you have the tirzepatide, and you have a retatrutide in the pipeline, and SGLT2 also is there. This IRIS study is very important. This was done in non-diabetic patients who had type 2 diabetes, who did not have diabetes, non-diabetic patients who had a stroke or a TIA. And they looked at the HOMA. If the HOMA was more than 3, they were insulin resistant, and they were given pioglitazone followed up for 5 years. And what did they find? That recurrent stroke reduced by 24%, myocardial infarction by 24%, and new onset of diabetes by 52%. And this was first time that any therapy which is directed purely at insulin resistance, nothing else. They were non-diabetics given pioglitazone to treat insulin resistance, and that was the benefit that was shown. But in this same study, there was a subgroup of population of 2,800 plus patients who were pre-diabetic. They were not diabetic, pre-diabetic. And when they analyzed that data, fantastic outcome. Stroke, myocardial infarction combined reduced 40%, stroke alone by 33%, acute coronary syndrome by 52%. Remember, these patients all have had a stroke. They were non-diabetic. And the outcome at the end of 5 years, acute coronary syndrome reduced by 52%, and new onset of diabetes reduced by 80% over a median follow-up of almost 5 years. So this study tells you the importance of treating pre-diabetes. The benefit of treating pre-diabetes is fantastic. So now when a patient comes to me with pre-diabetes, I don't tell him you're pre-diabetes. I tell him you're early diabetes. Treatment chalu karo. This is what is required. So your phraseology has to become different. So the American Heart and Stroke Association recommends pioglitazone for prevention of recurrent stroke. Cardiovascular risk factors and biomarkers, all these studies, Proactive, Chicago, Periscope, IRIS, and several meta-analyses have shown excellent results. The Proactive study showed a recurrent fatal MI by 28%, acute coronary syndrome 37%, and stroke by 47%. And it was this Proactive study which showed a 47% decrease in stroke, which prompted these neurologists to do this study with pioglitazone in the IRIS study, that will it prevent stroke. This is a Chicago study, carotid intima media thickness comes down, means showing that it is anti-atherogenic. This was Steve Nissen's study, the one who killed rosiglitazone. It shows the atheroma volume comes down with pioglitazone, increases with glimepiride. But this is a very interesting study done by Helen Strongman, who looked at the European multi-database cohort study it was, where they looked at patients who took pioglitazone and patients who didn't take pioglitazone. 31,000 patients exposed to pioglitazone. And look at the deaths on patients exposed to pioglitazone and not exposed to pioglitazone, not exposed to 3 times more deaths, non-cardiovascular and all cause, 3 times more. So, and if you look at cardiovascular cause specific, myocardial infarction, again 3 times more in patients not receiving pioglitazone. Stroke, heart failure. We say pioglitazone causes heart failure, but look at this. Heart failure, those who didn't have pioglitazone had more heart failure. So this analysis showed that almost 67% less mortality in patients given pioglitazone over a decade or large study. So insulin resistance and NAFLD, that is where we come to. Basically, fatty liver is because of insulin resistance. Full stop. That is the cause or the most important cause for a fatty liver. I won't go into this for time, Basically, this is the ACE endocrine practice guidelines, which said that when you look at type 2 diabetics, 90% of your type 2 diabetics will already have had a fatty liver. 37% of them will have NASH, and 20% will already have significant fibrosis. So when you talk of NASH or NAFLD or MAFLD or MASH, whichever you want to call it, your diabetic patient has it, whether you have proven it or not. And this was a study we did and published, which was done in our clinic, almost 1,500 patients. Randomly, as they walked in, we did a fibroscan for them. 75% of them had fatty liver, and 27% of them already had fibrosis, asymptomatic patients. So that is where it is. So what are the recent updates on management? Lifestyle modification, diet control, weight reduction, management of obesity, basically treating insulin resistance by either weight reduction or with drugs. That is the basic fundamental here. Now, if you look at this, weight loss, the last column says 3%. If you lose 3% weight loss, steatosis improves by 35%, 5% ballooning inflammation improvement, 7% NASH resolution, and 10% even fibrosis regression. But the sad part is, at the end of 1 year, how many patients actually can maintain that weight? In the top, less than 10% can maintain that 10% weight loss. So pharmacotherapy has come in, and now we have the GLP-1 and the co-agonist tirzepatide, excellent weight loss figures. This is semaglutide, which has given a weight loss of almost 15%, and it shows improvement in NASH and improvement in fibrosis. And in fact, on 15th August, the US FDA has approved semaglutide 2.5 milligram for the treatment of fatty liver. So this becomes the second drug which is officially approved by US FDA for treatment of fatty liver. Tirzepatide studies are going on. Very soon, I think that also will get approved. But here they have an almost weight loss of more than 20% and 22% at the end of 72 weeks. The BMI can come down from 38 to 30, which is very, very significant. Waist circumference can come down by almost 9 inches. And if you look at MASH, yes, the MASH can improve without worsening of fibrosis, and fibrosis can improve without worsening of MASH. The enzyme levels, your SGOT-PT or ALT, comes down very significantly with these drugs. And you have another molecule which is a triple agonist, which is in the pipeline, retatrutide, which is a GLP-1, GIP, and glucagon agonist. And there, if you see at 24 weeks, there is a 80% resolution of hepatic steatosis. And that figure becomes 90% at 48 weeks. So this is in the pipeline, undergoing phase 2 and phase 3 studies. Like I just told you earlier, on August 15, 2025, semaglutide was approved by the US FDA. In India, the first drug to be approved for fatty liver was saroglitazar, based on the evidence 1, 2, and 4 studies. Basically, saroglitazar is a PPAR gamma and alpha agonist. PPAR gamma works just like pioglitazone to reduce insulin resistance. PPAR alpha reduces triglyceride level, which is a component of fatty liver. That excess triglyceride also contributes to fatty liver and has decent results. Resmetirom was the first drug to be approved by US FDA. It's a beta-selective thyroid hormone receptor agonist, which is specific and has been shown to be effective in reversing even fibrosis. And that was the reason that it was approved by US FDA. Unfortunately, extremely costly drug, not available in India and not available in most parts of the world yet. SGLT2, there are a lot of studies now coming showing that it has an improvement in fatty liver. Even on the FIB-4 score, this is a paper presented by Krishna Sheshadri from Chennai. In fact, pioglitazone, if you look at these are the benefits here, SGLT2 there, and they join together, have a beneficial effect on MASLD. cardiovascular effect of SGLT2 and pioglitazone. If you look at it, the last line is the combined pioglitazone and SGLT2. Very good results when you combine an SGLT2 with pioglitazone in MACE, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. So that becomes a deadly combination of pioglitazone and SGLT2. The side effects of pioglitazone, like slight fluid retention, is countered by SGLT2. The weight gain of pioglitazone is countered by SGLT2, and you have a combined synergistic beneficial effect across the board in fatty liver and even in cardiovascular outcome and mortality. These are old studies before the advent of GLP-1 and or the newer molecules, which showed that for resolution of NASH, NAFLD score, or steatosis, you look at the last two columns, it is pioglitazone 30 and 45 milligrams. You look at the ACE guidelines, this was 2022, pioglitazone and GLP-1, and if you look at the last one there, it's GLP-1, pioglitazone, and SGLT2 which has come in. The ADA guideline of 2023 says pioglitazone and GLP-1 analog. This is the EASD guideline which came out in September 24. Here they talk of resmetirom, which is now approved by US FDA, and GLP-1, SGLT2, and metformin. If you look at the ADA guidelines for 2025, GLP-1, SGLT2, yes, but if you look at the last column down there, agents with potential benefit in MASLD and MASH, GLP-1 coagonist and pioglitazone in combination with GLP-1 RA and pioglitazone can be used. This is the MASLD treatment algorithm, that if you have only fibrosis 0 to 1, obesity therapy is GLP-1, but diabetes therapy is GLP-1, GIP, and pioglitazone SGLT2. If you have grade fibrosis grade 2 to grade 3, again GLP-1, GIP, okay, 2 minutes, GLP-1 RA and pioglitazone. But once it goes above that, I mean, for cirrhosis compensated, same continues, but decompensated, then you discontinue all this treatment. These are again ACE guidelines which says pioglitazone all the way. These are the treatment modalities which are available to us to treat fatty liver. Resmetirom, GLP-1, GRP, they are very expensive. Resmetirom is not available, and GLP-1 RA and GIP-RA combinations are beyond the reach of 99% of our population. I would say 99.555%. So what are we left with? We are left with pioglitazone, saroglitazole, SGLT2, and vitamin E. This is what our common people will use. And here, what is the evidence? That pioglitazone has got a lot of cardiovascular evidence, and as an insulin sensitizer, the strategy. Macrovascular damage starts many years before the onset of diabetes. Microvascular complications are linked to dysglycemia. Insulin resistance and its complication in beta cell preservation have to be adequately addressed from day one of your treatment for positive long-term outcomes. And if you treat them, you will be able to prevent and minimize all diabetic complications, including fatty liver. So metformin, pioglitazone, and an SGLT2 combination is the most durable. There is no weight gain and gives the best results when there is endogenous insulin present. What does it mean? Means you start treatment on day one. You don't wait for him to be 10-year-old diabetic to start this combination. From day one you start. So metformin, pio, and SGLT2 with endogenous insulin is the best. And in fact, now you have a lot of companies who are coming out with a combination of SGLT2 and pioglitazone. So pioglitazone is a powerful metabolic agent. It's just not a glucose lowering agent, it's an anti-atherosclerotic and lot of pleiotropic effects. And there's a lot of evidence And most important, what is highlighted in yellow is it is most suited for Indian phenotypes who have the visceral obesity, insulin resistance, and for them. And it combines all the scientific data, clinical relevance, commercial availability, is cheap drug, and is not an outdated choice. Everybody thinks, "Arey, ये तो बहुत पुराना molecule है." Arey, it is the molecule. Thank you.
Thank you very much, sir. Please have a seat. We'll take questions later. Now, I would like to call upon Dr. Vijay Neglud, sir, another master. He's going to elude on interaction between diabetes and cardiovascular system. Over to you, sir.
Thank you, chairpersons, for your kind words. Thank you, Manoj and Purvi, for this invitation to speak on a very interesting subject, which is the interaction between diabetes and cardiovascular disease, which is frequent, forgotten, and often fatal complication of diabetes. This was the editorial written Diabetes Care in 2003, and that's what we're going to discuss today. So we know we'll get to 1979, almost 47 years back, when the Framingham Heart Study for the first time demonstrated the association between cardiovascular disease and diabetes for the first time. And now they said that the high sugar was taken as blood sugar of more than 150. That was the cutoff point they used to diagnose diabetes at that time, way back in 1979, showed the association between cardiovascular disease and diabetes. This is the global data looking at more than 4.5 million patients. And what it tells you that the incidence of diabetes and cardiovascular disease is pretty common. If you see, for example, 1 out of 3 patients have some cardiovascular disease, 1 out of 5 will have coronary artery disease, 1 in 7 will have heart failure, 1 in 10 will have myocardial infarction, 113 have stroke. So high burden of vascular disease in patients of diabetes is very evident for these prevalence studies. This is data again from India, which looked at more than 5,000 patients, so a new onset diabetic patient, and it looked at the possible cardiovascular disease risk in these patients. And what it looked at, the high-risk patients and a very high-risk patient, you'll be surprised to know that 40% of these patients of new onset diabetes have a high risk of cardiovascular disease, and 60% have a very high risk of cardiovascular disease when they're new onset diabetic patient. And that's why you see the life expectancy is reduced in patients of diabetes by 6 years with the diabetes alone. It has, along with the cardiovascular disease, is reduced by 12 years, and with kidney disease, it reduced by 16 years. So that's how the reduction of expectancy of life. We have either diabetes with heart disease or with the kidney disease. And we know that diabetes is a very complex disorder. We know that type 2 diabetes, kidney disease, and of course the cardiovascular disease is the most important risk factor for the problems of cardiovascular outcome and the expectancy of life when you look at patients of diabetes. You can see here that large number of patients have all these diseases together. And what is very interesting is that one disease interferes with the other negatively. That means if you have a heart failure, it worsens your type 2 diabetes. Type 2 diabetes worsens the atherosclerotic cardiovascular disease. That in turn worsens chronic kidney disease. And all of this to be taken holistically. You need to treat them totality, not in isolation. So therefore, it's important to realize that it's a very complex disorder. And these are the risk factors. We all know them, that either it's obesity, age above 50 years, hypertension, smoking, and dyslipidemia are the standard risk factor that you see in patients with diabetes with ischemic heart disease. This is a very interesting study, the old study, Mr. Fit trial, which looked at more than 350,000 patients. In that, about 5,000 patients were diabetic. They looked at 3 important risk factors. The risk factor could be hypertension, more than 120, presence of smoking, these patients, and the presence of the obesity. And when you see all the 3 factors together in a patient of diabetes, the dark line or dark bar that you see, that more the risk factor, more are the cardiovascular event in these patients. Therefore, every event contributes immensely to the cardiovascular outcome in patients of diabetes. This is the Indian data which looked at the prevalence of dyslipidemia in this country, which looked at north, south, west, and east. And you see that the high prevalence of the dyslipidemia in terms of triglycerides excess and low HDL. You can see the low HDL is to the tune of 60% that we have. Our population has this disease. This could be epiphenomenon in this country where we have low HDL, high triglyceride, which is a very important risk factor for the ischemic events in diabetic patients. And the atherosclerosis that you see in patients with diabetes is also very premature. It comes early because of various factors, and the most important being the endothelial dysfunction, which is produced either because of diabetes itself and hypertension associated with that, and we have the oxidative stress because of the hyperglycemia, which also contributes to the endothelial dysfunction, which is responsible for the early atherosclerosis that you get in patients of diabetes. Hypertension, diabetes are again interlinked quite effectively. You can see that the RAS activation that you see in patients of hypertension and retention of sodium and the sympathetic overactivity is responsible for hypertension. And in patients of diabetes, because of the dyslipidemia, the insulin resistance, hyperglycemia, and the obesity also brings about atherosclerosis. So both put together, the hypertension, diabetes are the cousins inseparable from each other that you see in patients of diabetes. 40% of the patients of hypertension have diabetes. 50% of diabetic patients have hypertension, such a close association that you see here. And furthermore, the inflammation, the endothelial dysfunction, and hypercoagulability also contributes to the problems of ischemic events in patients of diabetes. What is interesting and important to realize that diabetes and heart failure are the two sides of the same coin, because both of them have increased sympathetic system stimulation, both have high renin-angiotensin system activation, high aldosterone levels, and high neprilysin levels. And these two altogether drive either the microvascular complications or a heart failure progression. So therefore, it's important to realize a patient with diabetes, the risk of heart failure is pretty high. And you also see what you see here, that the heart has those receptors, which are this transporter, which is called sodium hydrogen exchange transporter, and a similar transporter also exists in the kidney. And the upregulation of these transporters brings about retention of sodium and therefore increased amount of heart failure. And what's also important to realize that insulin, pioglitazone, and saxagliptin stimulate sodium hydrogen exchange transporter, and therefore the risk of heart failure is very common when you use these particular drugs in patients of diabetes, especially those who already have either incipient or obvious heart failure. We all know that type 2 diabetes, cardiovascular disease, and kidney disease is the most important problem or the most important public health issue today of this particular century. And this was driven entirely by the adiposity, which is the excess adiposity, which also dysfunctional adiposity, which results into cardiovascular disease and the kidney disease. And therefore, the American Heart Association in 2023 in the advisory guideline talked about what is called as CKM syndrome, which is very important in patients of diabetes, which is responsible for the cardiovascular and the renal impairment in these patients. They also brought in staging in these diseases, because when you have staging, you can find about how much improvement you have created in the patient or how much patient is worsened, similar to what the oncologists do with staging in the cancer. Similar kind of staging is also done in patients of CKM syndrome. So when you want to manage such patients of diabetes, we have the 4-pillar approach. You need to have good glycemic control, need to have good pressure control, the lipid management, and of course the agents which cardiovascular and kidney safety. This is the study from Thailand, which looked at 666 patients. The entire idea was to see what happens if you delay intensification at 6 months or beyond 6 months. And it's interesting to see those patients who get intensification much early in the treatment have a less incidence of nephropathy. Even if you delay the intensification by 6 months, the incidence of nephropathy increases by 2-fold, which is pretty high. And therefore, it's important to realize that you need to intensify treatment much early. And that's what the message from this particular study. This is the American Diabetic Association 2025 guideline talking about management of hypertension, patients of diabetes. Talks about using the ACE inhibitors or ARBs as a first-line treatment for the patients of diabetes, identification of the patients have albuminuria or not, and based on what patient has findings, use the combination therapy right from the day one to control the blood pressure effectively. And just to remind you, in the patients of diabetes, controlling blood pressure is more important than controlling glycemia, because the outcome depends more on controlling blood pressure rather than blood sugar. This is the Lipid Association of India talking about various kinds of risk factors for patients with diabetes. They talk about very high risk patient, and moderate risk patient, and just look at the LDL targets, which are less than 15 very high risk patient and less than 17 high risk patient. In other words, your treatment in management of lipid is also aggressive, besides treatment of hypertension, which is also aggressive. This is the overview of the SGLT2 inhibitors, which Dr. Panikar did mention earlier, looking at 71,000 plus patients. Either they are the cardiovascular disease outcome patients, or they have been renal outcome patients, or patients of heart failure. But you see across the globe, across all the trials, you can see there's a benefit, whether it's a cardiovascular, whether it's a renal, or whether it's a heart failure. So these drugs have improved a lot of benefit in patients of diabetes in giving protection in the various problems the patients could have because of diabetes. And the important thing to realize this is how do they help so much? If you look at the myocardium does not have SGLT2 transporters. It works through sodium hydrogen exchange transporter, and what it does, it improves the tissue biology. And what happens in patients of diabetes because of excess insulin and the adipose tissue expansion, there's an accumulation of the glucose and lipid intermediates in cytosol, which brings about increased stimulation of AKT pathway and mTOR pathway, and reduction of SIRT1 pathway, PGSC1 alpha and FGF21. It is reversed by the SGLT2, and therefore you get benefit in the cellular outcome, and therefore these patients have better outcome in patients of management of various cardiovascular disease. And also important to realize that when you have patients of diabetes, there's excess glucose utilization by the myocardium, and therefore it brings about metabolic inflexibility. And when you use SGLT2 inhibitors, it improves the metabolic inflexibility by allowing the myocardium to use fatty acids, use ketones, and also interestingly now, the branch chain amino acids are also utilized effectively by the myocardium, and therefore you get the benefit of the outcome in patients of heart failure because of the substrate utilization efficiently and effectively, and therefore giving better outcome for the heart failure management. This is the data of the GLP receptor agonist, more than 60,000 patients. This is the 8 meta-analysis looking at outcome in the cardiovascular disease. You can see here there's a reduction by 14% in MACE, reduction in cardiovascular disease by 13%, also heart failure reduction by 10%, and therefore these drugs have really proved benefit in management in heart failure and the myocardial infarction in the diabetic patients. And we have these extended drugs, the GLP receptor agonist, like either a dual agonist or the triple agonist, which have proved benefit in not only reducing weight, but also reducing the cardiovascular outcome. Talking about the heart failure, there's a 5-pillar treatment in the patients, and these drugs have beneficial effect using ACRBs, neprilysin inhibitors, beta blockers, MRA, and the SGLT2 inhibitors have really proved very beneficial in managing the heart failure problems in patients of diabetes. As I mentioned earlier, the heart failure and diabetes are the two sides of the same coin, and therefore understanding this is important. And also interesting to remember that every time you use a drug like insulin or sulfonylurea, which may help the patient to gain weight, and when patient gains weight by 1 kilogram, the risk of heart failure increases by 7%. So therefore it's important to realize when you treat patients, see that the patient doesn't gain weight. And therefore the guidelines do mention that the use of these drugs, the GLP-1 and the SGLT2, in managing the patients of cardiovascular disease. If the patient has chronic kidney disease or a kidney involvement, then use the SGLT2, and use the heart failure, you can use the SGLT1, SGLT2, or also the GLP receptor agonist, especially with accompanying obesity. We have this STEP heart failure trial talking about the benefit of using GLP receptor agonists in patients who have obesity. If you summarize the various treatment modalities we have the CV benefit drugs, 3-point or 4-point MACE drugs. We have the metabolic benefit drugs and the renal benefit drugs. This slide does not mention the finerenone, which is also an important drug in the renal benefit. And if you see at the bottom of this slide, you can see that the agents proven to be saving lives in patients with diabetes are the empagliflozin, liraglutide, and oral semaglutide. All reduce the all-cause mortality and the cardiovascular death. So these are the important drugs. They give benefit to these patients much early in the treatment game, and not only they have the beneficial effect in cardiovascular outcome, but they also increase the lifespan and also prevent the dialysis by at least 12 to 14 years. So therefore, to take home message that what I said last 15-20 minutes, that the Indian patients have a type 2 diabetes are clearly at a high risk of cardiovascular disease. The cardiovascular risk assessment is the first and a simultaneous step in the type 2 diabetes screening and management. Aggressive management of risk factor control is recommended. Target of A1C below 7% in the most of the patients or 6.5 without complications of hypoglycemia and weight gain. ACRBs are the drug of choice for hypertension control. Gliflozins and GLP receptor agonists have immense benefits in the CKM syndrome. Statins, don't forget to add every patient to diabetes with the age of 45 years. With this, I conclude my talk. Thank you very much for the patient listening.
Thank you. Thank you, sir. So, after learning from the two masters, I hope more questions from the floor of things. It's welcome.
So my name is Dr. Mukund. I was looking at pioglitazone. In fact, fantastic presentation done by sir. Pioglitazone, in fact, is an old molecule. We are rediscovering pioglitazone. I wish both of you, sir, who have given talk, we should have a paper, who killed pioglitazone? Because pioglitazone, if you remember, is an old molecule. We are rediscovering it. Now we are combining it with new molecules. Let me tell you, pioglitazone is an excellent molecule. Before that, metformin we have. Metformin is also very good. We are getting new molecules. I have nothing against them. But the problem is, younger generation of doctors are preferring the costlier molecules, which today, yet clinical trials have to show how safe they are. Indian patients, affordability is biggest problem. So I would suggest that we should look at pioglitazone in newer line. That's what I wanted to say. Thank you, sir.
So pioglitazone has always been there.
It's not killed by anybody.
It was, no, many people tried to kill it.
Exactly. Many people, in fact, that is the reason we have to have an investigative paper. Who were the guys who wanted to kill it?
No, forget that. Because all those people are dead.
Yes, yes, you're right, absolutely right. You know this.
No, see, I'll tell you.
Thank you, sir. Thank you.
Government of India had banned pioglitazone.
Yes, sir. Yes.
In 2013. And I was the one who called a press conference.
Yes, sir. Yes, sir.
There was Dr. Rajiv Koil with me. And there was Dr. Siddharth Shah with me.
Yes.
And we had a press conference.
You had a press conference.
Which became viral.
Yes.
And we were quoted across in all the channels.
Yes.
And within a month and a half, the government had to back.
Yes, sir.
And take back the...
It was in the papers also. Sir.
Yes.
But we have forgotten. 2013.
Yes. No. Yes. See, that is history. So since then, people have had their hesitations.
To write.
Yes.
Absolutely.
And all the other molecules have actively suppressed
pioglitazone. Exactly. Exactly.
But yeah,
other detergents.
We should be sensible enough to understand that.
Yes, yes, I agree.
That's what the crux of the matter. It's a wonderful molecule. So I agree with you.
Thank you, sir. Thank you.
In fact, if you see that CKM syndrome, when they talk about, is basically the adiposity, the dysfunctional adiposity, and that's where exactly the drug works. So therefore, it is again calling back the same thing that we are now talking about. Adiposity is the main disease in diabetes, the dysfunctional and the position in the viscera, which has to be managed and treated effectively, not only to prevent cardiovascular, but also kidney disease. So CKM became a big spectrum of the activity now, and you have to look at holistically, and all three are important and they involve together. And secondly, one negatively influences the other. So that's again important. You treat holistically all of them together. And therefore, these are the drugs are useful in that.
Sir, one question to you, sir. We have got the DAPA CKD trial. We got the EMPA, which has come with a special kidney trial. We tend to get a little confused. Is EMPA actually equally good as DAPA, or DAPA is better than EMPA? Because we don't have a head-to-head trial. So how do I really choose in my practice?
Yeah, that's a very good question. See, the two studies have a different kind of outlook. The DAPA kidney study looked at patients with diabetic kidney disease and non-diabetic kidney disease with good amount of albuminuria. And they used the cutoff of GFR about 25. So therefore, they restricted those patients. The inclusion criteria was the GFR about 25, and you have proteinuria of more than 500. And the average proteinuria was about 3,000 in these patients. So therefore, the important thing was to look at the benefit in this. In the EMPA kidney, what they wanted to see was all this time they have shown benefit in patient with proteinuria.
Yes.
Because proteinuria means there's an endothelial dysfunction, and if you treat that normally, you get the benefit. And the treatment of proteinuria could be even controlling diabetes well. If you control diabetes well, you can reduce proteinuria. Even you have drug like DPP4 also have shown that benefit. So they wanted to see if you have a patient of kidney disease without much proteinuria and have different causes for kidney disease, for example, IgA nephropathy or other kinds of kidney disease were also included. 50% of the patient in EMPA kidney disease did not have diabetic kidney disease. So therefore, across the spectrum of involvement of kidney problem in these patients, the EMPA showed superiority. So whatever you have cause for the kidney disease, you have the EMPA as a good drug. So when you want to select drugs, if you have a GFR on little lower side, about 20, you can use this drug, empagliflozin, especially in patients of diabetic and non-diabetic kidney disease. And dapagliflozin little above eGFR, but usually have proteinuria and usually in diabetic kidney disease. I think both drugs are similar. Both drugs have similar action and nothing to choose between those two. Both two are effective. And what you should appreciate and remember that these drugs can prevent dialysis for 12 years.
Exactly. I
Imagine
that.
if you have a patient of dialysis, the quality of life is so bad. And this can improve the quality of life. And therefore, you should insist on using these drugs early in the game rather than waiting too late for begin these drugs.
So little bit of 10 milligrams and 25 milligrams of EMPA.
There is no difference in terms of the outcome of the in the cardiovascular trial. So all the trials, for example, the kidney trials are used 10 milligrams only. Only the cardiovascular outcome trial used 25 and 10. Both are equal, glucopoise was equal, both of them. And there was no difference. The curves did not separate much. So therefore, between 10 and 25, there is no much difference. But the cardiologists tend to use 25 milligram because they feel that it reduces weight much more than 10 milligram. But to my mind, both are similar.
Thank you, sir. Sir,
May I just add to this?
Yes, sure.
1 minute. May I just add to what my friend Vijay has said? Excellent. There are chota differences between the two, and that is because of the style and the way the study has been conducted. But if you look at the ADA guidelines, you look at the American Heart Association or Endocrine Association or the KidGo, they say there is nothing to choose between the two. You can use either DAPA or EMPA in all these situations. Am I right, Vijay?
Yes, yes. Whichever company you're close to.
That's a good one. Sir, in diabetics, and for reducing the blood pressure, usually we start with ACE or ARB. In our country, we start with ARB. Then if it is not getting controlled, then we probably move on to CCBs and all that. So does ARNI also have a role in reducing blood pressure in diabetic patients without a heart failure?
Yes. Actually, originally, the entire heart failure history, as Milton Packard said, this is his word, not mine, are all the stolen drugs. They stole drugs from diabetes like the SGLT inhibitors. They stole ARNI from hypertension people, kidney people. They're using this drug for hypertension. They found a benefit in patients of heart failure. So ARNI is also basically a drug to treat hypertension. You can use that. But what you should remember in treating hypertension and diabetes is you cannot use a single drug to treat patients. For example, you give diuretic to a patient. There'll be a drop in the pressure for a short while. Afterwards, kidney senses the contraction of the vascular compartment. It will retain the sodium and the pressure will come back. That is called escape phenomenon. And therefore, when you treat hypertension patients, always use combination. And only 3 drugs you should remember: the diuretic, the calcium channel blocker, ACE or ARB. Use the combination of these 3. If all 3 if you use, patient still has hypertension not controlled, then that by definition is called resistant hypertension. And then you can use spironolactone as a drug to treat that resistant hypertension. So to remember only 4 drugs. Use them effectively. And if you use them, majority of patients of blood pressure will be controlled adequately.
Thank you. Sir, I got one question that if the cardiovascular effect starts 15 years prior to the diabetes, then at what stage of little rise in the weight, should we start anti-diabetic or whatever? Means, and what in what dose?
See,
And how can
basically,
we convince the patient from that point of view?
see, basically, we Indians are all prone to early atherosclerosis. In fact, cardiovascular problems starts 10 years earlier in Indians than in Caucasians. That doesn't mean that we treat every Indian from birth. No. You have to wait for some time. Let him become a pre-diabetic, then you can treat him adequately. If he has got significant dyslipidemia, treat him properly. But lifestyle can be used. And for insulin resistance, one is obesity, one is central obesity. In dyslipidemia, a low HDL and a high triglyceride also points to insulin resistance. A random fatty liver which is found means insulin resistance hai. So lifestyle modification in terms of exercise and weight reduction is very important. And obesity is on the rise, so all these complications are on the rise. So treatment of obesity, lifestyle, exercise is the best way to prevent all this. But once it comes to a pre-diabetic stage, then you have drugs like metformin, pioglitazone, SGLT2, acarbose, and so on. And even GLP-1 and the co-agonists can be used to treat and prevent type 2 diabetes.
I can add one
Thank
more
you,
thing
sir.
here. See, many times you see patients, they have hypertension, and you say, yes, you got a hypertension, I want to treat you. The patient will reply to you saying, don't worry, I just came running, I was in tension, and therefore my patient is high, so I don't require treatment. Now, at this point of time, it's quite confusing. How do you manage such patients? Because treatment of hypertension is the most important thing in a diabetic patient. How do you look at it? You always use those Q-risk scores. It's very easy to do it. It only requires certain parameters. If you Q in that and if you find the risk is high, you should treat that patient. Even the patient says that I just came running, that's why my blood pressure is high. Don't worry about it. The patient tries to assure you that the pressure is not important. But for you, it's most important to treat. If at all today what you learned is the treatment of hypertension is most important because that tells you the longevity of survival. The pulse, respiration may not give you that information, but the important vital sign is hypertension. So therefore, use these various engines or search screening patterns to identify risk for these patients and treat effectively. See that the blood pressure is controlled well.
Thank you, sir. Sir, one last question to Dr. Panikar. Sir, we have had studies with 3.75, 7.5, 15 milligrams of pioglitazone. Sir, as far as insulin resistance is concerned, NAFLD is concerned, would you give different dosage for different condition, or would you stick to whatever patient can tolerate without heart failure?
What we have seen is standard treatment for Indians, 15 milligrams of pioglitazone is good. But if the patient has a fatty liver or a NASH or MASH, means his SGOT-PT is high, then the dose of pioglitazone should be 30 milligrams. 15 session, 30. So that would be the indication for 30, but 15 milligram works well. And there are many patients on 15 milligrams only who still have very low sugars. Those are the ones you can give 7.5.
And sir, if I'm giving 30 milligrams, I will not be scared of heart failure in those patients because they are having a good.
See, if he has a heart condition,
only then, not otherwise. Please.
Otherwise, kuch nahi, it protects the heart here.
Thank you, sir.
Thank you both
Yeah.
masters, and
Thank you.
come for one photograph. For next session, I will call upon to chair this session Dr. Kamlesh Nayak and Dr. Malay Parak.
So good afternoon, all of you. So without wasting much time, now I am invite Dr. Jain Panda, sir. At least no introduction required for sir. He is a professor and ex-HOD, PG Department of Medicine, Medical College, Cuttack, Odisha, and FICP, FACP, FIMS, FRSC, and Fellow of Diabetes India. Consultant in Diabetes Metabolic and Critical Care Medicine, Vice Dean, Indian College of Physicians, immediate past National President, CCDSI, immediate past Chairman, API Odisha State Branch, President, Cuttack Club, 71 national and international publication, and Principal Investigator of international and national trial. So without wasting much time, hand over to you, sir, please.
Thank you. Thank you, Chairpersons. And it's a honor at DRS. And I thank my good friend, Dr. Manoj and Dr. Purbi, as well as Dr. Banshi and the whole team of DRS for the invitation and this grand show in the Geo Convention Center where so much of good science is there for last 3 days. My job is to tell you about the type 5 diabetes. And many of you know where from this term came. Long back, we had a concept of MRDM or malnutrition related diabetes mellitus. This type 5 is just a new avatar of MRDM, but they have presumed that chronic malnutrition results in maldevelopment of pancreas, so less insulin secretion. So there is a phenotype in diabetes where the insulin secretion is less, beta cell development is less. Clinically, there are features of malnutrition and they have a profile entirely different to the type 1, type 2, LADA, as well as other type of diabetes. So last IDF at Bangkok was launched a task force which will work on this, a working group which will work on type 5 diabetes, and then the president of IDF, Professor Peter Schwartz, announced a working committee for the Indian team as well as Dr. Meredith Hawkins from the Albert Einstein College of Medicine. I have started working on the concept. So I am just taking you in the lane of history 50 years back where Cuttack started working on this phenotype, and this article published in 1984 in Lancet, the observation on clinical patterns of diabetes mellitus in India, which first time described the malnutrition can be a etiology for diabetes, because in our area we get a sizable number of patients who have features of malnutrition and at the same time diabetes. So our concept that diabetic or obese with insulin resistance is not always true, and to your surprise, 1/4 of patient of diabetes are either lean or normal BMI with a good amount of insulin resistance. They are not type 1, they are not LADA, they are type, neither they have everything matching to type 2, they are a special class apart. And then Professor Tripathi, Professor Kar, and a group including Professor Keshi Shamal, Professor Siddhar Das, Dr. Alok Kanungo had multiple publications, and in fact this publication way back in 2014 I did with Professor Das regarding islet B cell response and glucose homeostasis in low body weight type 2 diabetes. So the confusion was between the low body weight and MRDM. a group of people told that malnutrition cannot cause diabetes. So the term which was introduced to the WHO classification was subsequently withdrawn. But class of diabetic who are lean or underweight, they exist. So our study is still continuing. We are in the Young Diabetes Registry where we get the sizable number of patients who have clinical features. I'll tell, and from our registry, our profile, this picture is taken. This is a low body weight type 2 diabetes monogram published by ICP by Professor Siddharth Das. He had taken a group of people, including Dr. Mohan and then Anant Nigam and Shamar Banerjee and then different centers like Chennai, the Calcutta, Ludhiana, and then Coimbatore. They were all part of this study, and a complete publication was done. And this is the summary of the meeting which took place in 1995 at Cuttack. Here if you'll see who's who of diabetes of the world 30 years back. This is Hotel Akbari, Cuttack, where the International Workshop on Diabetes peculiar to tropic took place, following which the designation of MRDM, PDDM and FCPD came to the diagnosis of diabetes, and the description, the publication in the Diabetes Care in 1996 was the group supposed the WHO classification of NIDDM into obese and non-obese subclasses. Till then, the world believed that the type 2 diabetics are obese. So in some developing countries, non-obese patients constitute the more common category, and a proportion of them have BMI less than 18.5, which was taken at that point of time. And there are many factors that are not well understood in these subjects. With NIDDM and low body weight, as well as further research is required to this group, was the conclusion in the Diabetes Care article, and subsequently in 97 classification of ADA, if you see the terms, the MRDM and PDDM came in the heading of malnutrition. So I salute to my mentors, Professor B.B. Tripathi, Professor Siddharth Das, who has worked as head of department of SCB Medical College and taken this project till now. And I'll tell you a few classical features of these patients where the IDF is working, and we started working in 70s, and almost 50 years after, now it has got an international recognition, and you see the global work on this. So the first feature in this lean type 2 or the type 5 or the MRDM, whatever you tell, comes the nutritional aspect, dietary intake and response to treatment. Here there is very clear evidence of malnutrition. These patients didn't take a good diet, and they constitute vast majority of diabetes seen in India and other developing countries, mostly Africa, and internationally they are classified as obese and non-obese. And here these patients, the type 2 diabetics with BMI less than 18.5 had little fat depot, neither poor nor undernourished, but the habitus is lean much prior to onset of the diabetes and continue to be show with prolonged metabolic control. So this is, as I told you, almost 1/4 of the patient of type 2 diabetics were lean in India, and in different cities have presented this profile of nutrition. And I'll show you how they improved. The second feature was clinical profile and complications. And if you see these features, the comorbidities, the hypertension, the coronary artery disease, the peripheral vascular disease, neuropathy, nephropathy, retinopathy, infection like tuberculosis and other infections. The Cuttack study showed very high incidence of infection. Jaipur study showed good number of cases of tuberculosis, but majority of patients had peripheral neuropathy in most of the centers, which showed a poor control and an increased risk. And then coincidentally, the macrovascular disease like coronary artery disease or peripheral vascular disease were less in this group of patients. And the prevalence of complications, there, as I have told, the peripheral neuropathy was there, and then hypertension and coronary artery disease were less common, and none of the subject revealed the presence of peripheral vascular disease or retinopathy. So the dietary practice and advice pre-counseling and post-counseling was different. So the carbohydrates, protein and fat were much less in intake, and they were counseled about the diet with improvement of the nutritional status and improvement of the diabetes as well as the A1C. So if you will see the low body weight, they had a average BMI of 17.4 across 21.7 in normal body weight and 28.3 in obese in our study. And fasting blood glucose was highest in this low body weight group, with vitamin B12 which was also in between the healthy and the normal, and then RBC folate was also very high, and the other parameters like growth hormone was high. So most of the patients were on oral drugs, and insulin was there with few of the patient, but they were well controlled with the oral drug, telling that they're more akin to the type 2 than type 1. So they are the centers which collaborated, and the inflammatory markers like HSCRP, the adiponectin, and nuclear factor kappa B were not raised, showing no inflammation in this group of patients. So the special feature 3 includes the pathogenesis, which showed the insulin resistance in the peripheral bed and beta cell dysfunction and increased hepatic glucose output. So big question came, is the lean built consequent to chronic malnutrition? Do they have poor beta cell reserve for insulin? Is the low insulin level responsible for the persistent hypoglycemia? And does the metabolic profile have any bearing on the morbidity pattern? And interesting data are there ensuring this. So high basal and non-suppressible level of growth hormone is a marker of natural adaptation to chronic nutritionally deprived state. And in this patient, it shows a very high value of growth hormone. So that tells that low body weight has always been conceived to the legacy of chronic undernutrition, and you can see here the basal and non-suppressible growth hormone level in this MMDM patients, which are much more higher than the type 1 as well as the type 2. So these are the curves which were taken after different type of diets, the carbohydrate rich, the protein rich, and the fat rich diets, and which were interpreted that fasting serum insulin in lean type 2 was higher than the controls. And the glycemic challenge, the rise in insulin levels was brisk in control, modest in lean type 2, but poor in the MRDM, and this testified that there was beta cell unresponsiveness to the glucose challenge, but not to the non-glucose substrate, which is a typical pathophysiological characteristic of type 2, telling that this is more nearer to type 2 than type 1. And fourth classical feature was disparity between the circulating level of insulin and C-peptide. And these were low. The circulating level of insulin were low when compared with the classical type 2 in the first state and the fade state. And after years of follow-up, this continued to have substantial level of circulating insulin with preserved beta cell response to glucose more after change in the dietary pattern, which tells that this is correctable. This shows about basal post-glucose and post-glucagon level of plasma insulin and the C-peptide. So beta cell non-responsiveness to glucose was obvious in low body weight as well as classical type 2 diabetes, and this was a common feature in both. The rise following glucagon was very brisk in the classical type 2, not insignificant following of the oral glucose, and response was similar in both groups for the C-peptide as well. The fifth special feature had the hyperactive metabolic state of liver utilizing excess of insulin vis-a-vis producing excess of hepatic glucose in lean type 2 diabetes. In hepatic bed, we had excessive insulin, which was proved with the enzyme glucokinase, which was raised in these patients. So the drugs like antipyrin and lidocaine were used, and they were also showed the increased insulin in the hepatic bed, and then carbohydrate cycle was different in these patients. This shows the glucokinase is high in these low body weight patients, and that was statistically significant, as well as the glucokinase the levels were demonstrated. The special feature 6 tells that the type of dyslipidemia, effect of glycemic starters on the urinary protein excretion, what happens to albuminuria, and further studies on the insulin reserve and beta cell function using homeostatic model, that's the HOMA-IR. So here we can see that the patients had the different levels, the at entry, at the 1 year after and 2 year after. This shows from all the centers that the lipid profiles were different, where the you can see here the triglyceride in the low body weight were very high, and the LDL cholesterol was not very low, and the fasting insulin was very high, and fasting C-peptide was or mediocre, where the normal weight had almost 280 fasting insulins. The final feature, the seventh feature, has the beta cell starters with regards to autoimmune damage, and I have already told the autoimmune markers are not there, and taking all this GAD antibodies, the islet shell antibodies, the tyrosine phosphate, and then these markers of type 1 diabetes were negative in this class of patients. So this shows the auto antibody status, and then this is the summary of that. So to conclude, ladies and gentlemen, lack of markers of autoimmune destruction and adequate beta cell reserve in the HOMA beta and the insulin resistance in the HOMA IR despite gross lack of obesity indicate that low body weight lean type 2 diabetes are neither a slowly progressive type 1 nor LADA but are phenotype variant of classical type 2 diabetes mellitus. And then in our distinct study, we have got all the features without low HDL, raised triglyceride, BMI below 19, and they are lean with clinical features of malnutrition, low values of homocysteine, HSCRP, and nuclear factor kappa B, and negative GARD antibody and islet shell antibody. So peripheral neuropathy was consequence of poor glycemic state and increased susceptibility to infection and endothelial dysfunction as proteinuria dominate the clinical picture. Due to associated infections, coexistent severe hypoglycemia and glucotoxicity persisted, and many initially may not respond to OHA, but subsequently many were controlled with oral drugs. The insulin resistance observed in type 2 diabetes lean is due to anthropometric parameter, the central obesity, and an waist-step ratio, but could be integral part of their pathogenic mechanism. So to summarize, the malnutrition associated clinical features and the parameters are different than that classically we see in type 1 or type 2. So what has been detected 5 decades back in Odisha, in Cuttack, has a sense, and the type 5 has been taken for that, and there are studies comparing the different phenotype, and we have a contribution from our registry related to that, and in future we'll know more about this diabetes. And in your practice also, you note all those who are having a BMI less than 19 or 18.5, you keep their clinical profile, keep their GARD antibody, keep their HOMA IR and HOMA beta, and then see how they are behaving, and then you will know that they are more towards type 2, and maybe you will get a history of malnutrition related. A significant class have pancreatic diabetes as well. So I do a CT scan of pancreas routinely, because now ultrasound only is not approved to rule out the pancreatic diabetes, the FCPD or pancreatic calculi. So this profile in future will tell us more about type 5. By that time we have to be sure, and remember, India and Africa are the countries which face the brunt. So world looks to us to tell more about this entity. Thank you all for the time.
Yeah, thank you, Dr. Jayant Panda. It's a beautiful talk. Actually, when I joined BHU as a MD student, at that time, Professor J.K. Agrawal asked me at that time, that is Dr. Samulan Tripathi, you do know them. And probably at that time, I don't know this because I was quite young at that time. But of course, this is the thing you were telling MRDM. You have shown one slide where actually the growth hormone is high. If you will see malnutrition itself induces a state of growth hormone resistance. So whether someone is diabetic or non-diabetic, any sort of malnutrition increases the growth hormone level. So have you taken without diabetes and versus diabetes to see what was the growth hormone level in only malnourished people having no diabetes versus those who have developed diabetes? Have you any data you have taken?
Actually, this data is from the study, the YDR study, where the growth hormone was done. In all the patients, they haven't done, but they have done in few section of the patients where there is clear increase in the growth hormone in both diabetic and non-diabetic. And in diabetic patients, it shows relatively higher increase in comparison to non-diabetic patient. But that is evidence of correlation of previous malnutrition and poor development of the pancreas.
Sir, in the management of those patients, suppose I have a patient who is 30 years old and he's lean, thin, diabetic, and then I tell him that, okay, you eat your diet properly. I mean, he says, now though I'm eating properly, but I don't know why I'm lean, thin.
Yeah.
So
actually,
I tell him, you are genetically like that. I cannot do anything for you.
Yeah, very right. Very right. Actually, the time when the patient presents, he may not be nutritionally deficient.
Exactly.
So, along with the diabetic assessment, complication assessment, you have to do a nutritional assessment also, whether the protein calorie malnutrition is there or any point of time in the childhood, because most of them have a history of malnutrition in the childhood, which has resulted in poor
to this phenotype.
Yeah,
exactly.
in
So
this phenotype.
so now per se, when we know that we cannot do anything of the history of the past, and the phenotype is already in front of you, do you have any specific mode of treatment for them? Are you more aggressive in neurological deficits? Are you more in methylcobalamin and all that,
Actually,
what do you actually, how is your frame of mind when you come across such lean, thin diabetics?
Yeah. In management, as I told, they are managed like type 2 diabetes. If they have a very high blood glucose, glucotoxicity or infection, you have to give insulin for some time and change over to oral drugs. Almost 80% of them, they respond very well to oral drugs, telling about beta cell reserve and a phenotype of type 2 diabetes. But regarding the complications, you have to manage like other complications, but more regarding the profile and the requirement of the insulin and especially the newer drugs like GLP-1 and SGL2 need to be tested, because this is a very old study. We don't have much experience regarding that, but now they need to be managed like a type 2 diabetes, insulin followed by oral drugs, and complications as usual.
Fair enough. Thank you.
Thank you, sir. I think we are running short of time, so I'll end the session here, and I'd like to call the next speaker. So thank you, sir. Thank you so much for the presentation. So for the next presentation, I'd like to call Dr. Abhay Sabu from Bhubaneswar. He is a professor of endocrinology and organizing secretary of SECON 2018, 12 and 16. And he is a principal investigator in 3 ongoing international trials and recipient of many awards. So over to you, sir.
Thank you, respected chairpersons. At the outset, I'm thankful to Dr. Manoj, Dr. Purvi for inviting me for this topic. So it's an interesting topic because nowadays everybody is actually going for weekly things. Probably after a few days, monthly thing will come, but everything weekly once GLP. Then I am going to discuss weekly once this DP4 inhibitors. This is telagiptin. So of course, if we'll discuss telagiptin, I will discuss about what is telagiptin, what is its role in diabetes, unique once weekly dosing, and what are the trials or evidences with us to support that how it works and what is the significance of that. So it's a novel oral DP4 inhibitors mainly approved in Japan, and it is highly selective T cell activation antigen non-specific action CD26. So the most important thing is probably it is not available throughout the world, and it is approved in Japan and also in South Korea. Then it is recommended as an add-on therapy. Which are the drugs you can add? Of course, metformin, as we everybody know, you can add to metformin. On top of that, you can see it can be added to sulfonylurea, SGLT2 inhibitors, insulin. So we have now studies it can be added to each and every molecule which is available with us as an add-on therapy. And what is the significance? That it differs from the other gliptins like citalina, that it is once weekly therapy. That is the significance, because whenever we discuss India, our HbA1c is low. One of the most important thing comes to our mind that probably compliance is one of the biggest issue for particularly Indian population, where you are adding diabetes, hypertension, dyslipidemia, everything are adding multiple pills. So if you can reduce the pill burden, probably that is one of the greatest thing for the patients. And the last one is, it is actually already approved in Japan, and it is discontinued in US, Europe due to cost issue, because we know once we are going for a US FDA approval, it itself takes quite a lot money significant. That's why they did not do that. Yeah. So what is the basic pathophysiological mechanisms? Main important thing, it's a DP4 inhibitors. As we know, like other DP4 inhibitors, it increases the GLP and GIP. It prevents the inactivation. And in pancreas, it increases the beta cells from the insulin release and also increases the glucagon release. Glucose uptake increases, glucose production reduces. Ultimately, we know that it is effective for blood glucose control. So, if you see what is the basic pharmacokinetics, if you see pharmacodynamics, it is a DP4 enzyme inhibitor. Its potency is actually strong DP4 inhibition versus alogliptin, because alogliptin is another important drug where its inhibition is up to 80% even if at 7 days. So that is the beauty of this molecule, that even if at 7 days the inhibition is still persisting at 80%. And efficacy, of course, it is a very high GLP-1 level, almost 4 times, because normally we discuss all GLP-1 DP4 inhibitors, they increase the GLP by 2 times. But it increases up to 4 to 5 times of GLP level, which is much more potent. And significant HbA1c reduction, and also improves fasting insulin, C-peptide and HOMA-beta, as I have discussed, and comparison with similar efficacy in fasting glucagon, insulin resistance and HOMA-beta action. So, yeah, so if you see the pharmacokinetics, Cmax is very high, reached at only by 1.5 hours, and elimination half-life is 19 hours after 72 hours. That means even if after 3 days, after that it takes around 90 hours, and it will take 5 times 5 T-half, it is close to 168 hours, and this is the reason why it is once weekly is prescribed. And it is metabolized by cytochrome CYP2D6 enzyme. Majority is excreted to kidney. So 76%, and protein binding is very less, close to 30%. So that is the beauty. And if you see the renal, probably it is contraindicated in severe renal failure, but in mild to moderate renal failure, it can prescribe that with a dose of 50 milligram once weekly, not the full dose 100 milligram. So 50 milligram once weekly is sufficient in mild to moderate renal failure patients. So what are the advantages? If you see that it has once weekly dosing, very simple. It is better adherence because less frequent dosing, comparable efficacy, will show some of the data with us. HbA1c and DP4 inhibition, low pill burden, improves quality of life, also similar safety profile like other DP4 inhibitors. From the side effect point of view, from the efficacy point of view, it is almost similar, and there is no difference between that. So, if you see the DP4 inhibition and the potency of the telagiptin, which is highly selective, very long-acting DP4 inhibitors. It is a non-covalent binding. That is, if you see probably sitagliptin, this binds covalently, but here it is non-covalent binding. Is there substrate competitiveness is reversible. It is a very slow dissociation. That is the reason why once weekly is given, very potent, up to 4 to 12 times more potent than alogliptin and sitagliptin. And it is a sustained efficacy, as telagiptin contributes to more sustained efficacy, and also that is the reason why we used to give once in a weekly therapies. And if you see the adverse events point of view, very well tolerated, comparable like alogliptin and others. Common adverse effects are usually nasopharyngitis, which is also seen in other DP4 inhibitors, and also another adverse event is actually some sort of pruritus, which is also found in some of the patients. And hypoglycemia is very, very minimal. It is like other DP4 inhibitors. It can be like what we, in the COVID era, we used to tell the safest drug is to prescribe DP4 inhibitors, even if by telephone. So it is like that. It is very safe from the hypoglycemia point of view, and in the cardiovascular lab safety point of view, probably there is no data from the dedicated trial is not there from the cardiovascular safety point of view. But of course, there are some factors like ECG, vital signs and lab tests are there, but a dedicated cardiovascular outcome trial is not there with telagiptin. And you will see the contraindications, as I have discussed. Hypersensitivity is there. If there is severe renal impairment, it is contraindicated. And no clinical drug interaction is found with commonly used drugs, what classically we do in the clinical practice. So from the safety point of view, if you see from the renal impairment point of view, as already I have discussed, if someone is having mild to moderate renal failure, probably 50 milligram once weekly is sufficient. those who are having severe renal failure or GFR less than 30, probably it is contraindicated. You cannot give this drug, but up to GFR above 30, 50 milligram, 30 to 60 is 50 milligram is sufficient. Above 60 is you can give full doses. You cannot, no need to change the drug. For hepatic impairment, as I have discussed, in mild to moderate hepatic dysfunction, you can prescribe, but those who are having severe grade T or child CPG grade C, probably they are contraindicated, they should not be used, but up to mild to moderate hepatic dysfunction, they don't require any dose modification because majority is excreted to kidney, so dose modification is usually not required for particularly those patients. Again, elderly patients, it is absolutely safe, can be given full doses, no dose changes or no dose requirement or no dose modification is required, no hypoglycemia is found, also no interaction with other drugs because a lot of the time elderly people take polypills, multiple drugs for multiple diseases, usually no adverse events or no drug interaction was found any other drugs, so they can be safely prescribed in elderly patients without any hesitations. But this is the most important thing, those who are having dementia or cognitive dysfunction, they might take multiple doses forgetting the weekly dose, so that should be kept in mind, and that should be actually given some instruction to their family members that instead of weekly, if someone is taking daily, because due to cognitive dysfunction, that might create problem. That thing should be taken care, otherwise no dose modification is required for those patients. And this is the comparison of different Sita, Abhida, Saxa, Lina, Alogliptin and Teneligliptin and Telagliptin. You will see that Telagliptin is scores that comparable HbA1c efficacy like daily other gliptins versus Alogliptin and Sitagliptin as a directly trial, which has shown there is almost similar, there is no difference is there. And you will see again the other parameters, similar efficacy was there from the HbA1c, binding capacity, renal failure, renal safety, hepatic safety, all are actually almost similar, same thing like other gliptins, so there is no difference was found between this as I have discussed. Coming to the efficacy and safety of Telagliptin, this is the one study, it is phase 3 study, multi-center study, Telagliptin 100 milligram for 52 weeks, and type 2 diabetic patients inadequately controlled on diet and exercise or with any of the anti-diabetic, one anti-diabetic drugs. More than that is usually they have not taken. What they found, so this is the adverse events was not much higher, it was almost similar to other drugs what is used. Serious adverse events and hypoglycemia is also similar, there is no difference was there. HbA1c reduction was a additional 0.7% was lower in comparison to those who are actually previously tested, and fasting glucose was actually significantly reduced. So that shows probably it is very good and can be safely given to the all type 2 diabetic patients with particularly only one drugs. So this is well tolerated, and weekly Tela is found to be safe and efficacious as a monotherapy or in combination therapy. So this is another study, those who are already on Sitagliptin. Those who were already on Sitagliptin, they were shifted to Telagliptin once weekly. So what they found, this is that 12 weeks comparison and subsequently 12 weeks compliance follow-up study. And what they found, this is a 37% reduction in adverse events, that is adverse event was less, their weight has come down. Usually naproxen it was found to be less with Telagliptin in comparison to Sita. But this is the thing, they try to 6-point testing, pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner and post-dinner, blood glucose in those groups. You see, every time the blood glucose is less in comparison to Sitagliptin. That means better control was found in all 6-point testing in comparison to Sitagliptin. So at every point it was 6 milligram and 7 milligram at breakfast, it is 0.1 to 0.4 milligram and 36 at the post-lunch, and dinner similarly there was reduced. So that shows the probably the glycemic control is better with Telagliptin in comparison to Sitagliptin, and if you see the glycemic variability, that is also found to be less variable with Telagliptin in comparison to Sitagliptin. Again, that shows that probably 6-point testing what classically we do, that shows better result with particularly with Telagliptin. So that concluded that a stable glycemic control was maintained, no major side effects, and once weekly Tela is switching from any version which is on any GWP4, if you are shifting to once weekly Telagliptin, probably you are giving better results in comparison to what daily gliptins what we are using. We have a lot of trials, these are the trials, different lot of trials with Telagliptin, and that all has clearly shown that Telagliptin is found to be safe. It is found to be safe in elderly population. It is use of Telagliptin has shown the improvement in the quality of life. It is the study which has shown that Telagliptin has actually shown the improvement in the quality of life in comparison to those who are taking daily gliptin. So again, that is one of the important things. If you look at QL scoring, that shows better improvement with particularly Telagliptin. So if you see the dosing, adherence and clinical consideration, it's early DP4 inhibitors. So requiring, not daily requiring dosing is not required. So you have once weekly sufficient, long-acting DP4 inhibitors, better patient adherence. It has impact on the non-adherence, as I have discussed. Those who are having poor compliance, probably this is one of the drugs which will be a miracle for those group of patients. ADO recommendations, patient-centered approach to improve the treatment adherence. Adherence barriers are actually patient factors, dosing complexity and healthcare system issues all are there, which usually taken care if we are going to once weekly therapies. And it is approved in Japan, and weekly dosing is based on the renal function. Now it is approved in India also. It is also available in India with particularly with 100 milligram once weekly dosing. Which these people see the PK or PKPD requires dose adjustment in the moderate renal dysfunction, but for elderly people for having hepatic, mild to moderate hepatic dysfunction, dose adjustment is not required. Contraindicated and severe renal impairment, long half-life allows once daily using, and its PKPD profiles vary across DP4 inhibitors, as I have clearly shown that. I think with this much I am finishing my topic. Any questions, any queries? It is everything is, yeah.
If anybody has questions, we can take it now.
Cost?
I don't think it is 100 rupees.
Yeah,
approximately 100 rupees.
150 rupees per.
100
rupees. That is a weekly.
105 rupees. 105 rupees. Yeah.
Any other side effect associated with any increased risk of infection, skin rashes?
Yeah, actually, I have shown all those trials have shown to mainly nasopharyngitis and also skin rashes and pruritus. These are the common side effects. No other side effects was
But
found.
is it increased compared to other
No, compared to placebo, it has increased. High compared to placebo. Yeah, but compared to other drugs or other gliptins, it is similar. There is no difference in comparison to other gliptins. I have used only 8 to 10% because it has come only for 1 month like that. So I have used only 8 to 10% and I have not followed up yet because that's why I cannot tell because only I have given for last 1 month. Because classically we follow the patients after 2 months, 3 months. So I have not followed up, but I have given 8 to 10%. And nobody has actually complained anything or that is like from the adverse events point of view, that is, I did not get any call from any patients.
What about the dialysis patient you cannot?
Yeah, absolutely, because it is contraindicated, even GFR below 30 it is contraindicated. So if someone goes with dialysis, probably it is below 15. So it is contraindicated, we cannot give in those patients.
So I think we can close this topic right now. So
Yeah,
we will
thank
move
you.
to the next session.
Thank
Thank
you.
you, sir.
Yeah.
Thank you so much. So for the next session, I would like to call upon Dr. Shashank Joshi, sir. He needs no introduction and he has been a legend and guide for all of us. So he'll be speaking on ICGM. Over to you, sir.
So, yeah. So thank you so much. Thank you, Manoj and Purvi, Bansi. This talk is titled as Updates in ICGM Accuracy and Performance Standards because CGM is becoming standard of care. I hope what you listen, you learn. What you learn, you will adapt. This talk has a duality and conflict in diabetes care, which makes Libre FSL 2.5, which is just launched in India. And this is also dedicated to people living with diabetes because I have many family members who live with type 1 diabetes. So we clearly recognize that A1C matrix moved beyond just simple glucose parameters to a CGM matrix, and it's here to stay. And clearly now we are looking at terms like time in range, time in tight range, and that's becoming a standard of care. So glycemic monitoring has evolved as a standard of care. And clearly in that space, we have a Libre platform for a digital health solution for a personalized diabetes care. And a lot of startups in the ecosystem of digital diabetes care have actually piggybacked on this entire Libre View, Libre Link Up, Libre Link for monitoring, insights and connection and connected care. One thing is clear cut, that sensor-based glucose monitoring has better outcomes, better time in range, better quality of life, decrease hospital admissions, decrease hypoglycemia and glycemic variability, dropping of A1C and decreasing work absenteeism. So it's a behavioral tool. It has evidence base which is overwhelming. We have it to be used and integrated it in our day-to-day care. But when we are looking at accuracy and performance standards, we recognize that the glucose meters were looking at capillary glucose. And the CGM was looking at the interstitial fluid. So clearly the premise of this talk is that CGM improves glycemic control, reduces hypoglycemia risk compared to self-monitoring of blood glucose, but safety of your patients is paramount. And we have the innovation space, and these are all the innovators in that space, including companies like Eversense, which make it once in 6 months, once a year. We had the Medtronics of the world, the Roches of the world, and the Dexcoms of the world, and we have the Libre 2, which is available in India. Unfortunately, in India, we have only Libre, which has been there for some time, and Libre 2 Plus is which is just launched. And then we have this entire ecosystem coming from Asia of the genericization of these players. So that's why we need to have some standards. So these new players have entered the market, and that's where these standards are there. So just like when we buy a good, like a technology good, we have a CE mark, and that stands for Community European. It's a compulsory for most products which are approved in the European Economic Zone, and it has a manufacturer declaring safety standards. So high safety and health and protection environmental standards for performance criteria. So CE Mark Plus for CGM specific performance standards are necessary for any approval process. It's a process quality. Just like for pacemaker, we have an ISO standard with a CE mark, BGM for insulin pumps. But when it comes to CGM, there was no such standard available, and the FDA had to look at making a standard of care. In 2018, a system was designed to reliably and securely transmit glucose measurement to digitally connected devices, because we are going to use more and more of it. Our mobile phone is going to see more and more of this data coming in through our Bluetooth and other technologies, and we'll have to look at automated insulin dosing systems with conjunction of digitally connected devices to manage disease and glycemic control. So the FDA put out a classification for special controls based on robust clinical data on accuracy for the population to be used, like type 1, type 2 diabetes, demonstrate an analytical clinical performance throughout the entire sensor wait time. You know that for the first day and the last day, you can have challenges in a dynamic range, a demonstrable reproducible accuracy in the pediatric as well as adult population, specified performance standards for all measurements for low and high sugars, rate of change with a specified performance standard, and then the security of data and reliability of data in meaningful time intervals. Remember that when you transmit data, it gets logged on into a space like a cloud. And then we need to have clinically acceptable performance standards, and we need to look at potential interfering substances. And we also need to ensure that the disposable sensors cannot be used beyond their claimed wear period. So these were a very stringent rigor of international standards of blood glucose meters, which we all know of, and clearly overall accuracy was looked at in these standards very, very clearly. In accuracy for individual measurements also was looked at, and accuracy of trend arrows was also looked at, and for children the accuracy was looked at, and during the wearing the stability was also looked at. So when we look at all the performances, you could see that the Libre 2 and 3 systems perform below 70, 72, 180, above 180 across all ranges, while the non-ICGM systems did not perform, and that's something which we recognized. And therefore different authors have published these standards of care for accuracy, because we are going to use more and more CGM in our practice. And Pemberton, Chantal Matthew, David Klonoff, many of these people who we know personally looked at integrated continuous glucose monitoring with FDA accuracy standards. So you need to look at that standard, and therefore it's important to distinguish non-ICGM approved CGM devices outside of US and then look at their accuracy their publications, their peer review, and standard of care. So clearly we recognize that CGMs not meeting rigors of accuracy standards can raise safety concerns. For example, an issue with the device accuracy, patient reported safety outside US was in Italy. A poor accuracy for low and high glucose levels for a CGM device was awarded, and it was having serious that the clinicians recommended to go back to finger stick monitoring. That's why you should be cautious and careful. So it comes at a price, it comes at a cost. Our endeavor is to reduce the cost, but at the same time don't compromise on the quality. And therefore in the Europe, Chantal Matthew, who's the president of ESD second time, she and her group put out these minimum expectations for market authorization for eCGM devices. So the proposed accuracy standards in EU are that you need to have it performance tested with good analytics, good data, variability has to be measured, changes in performance, and system design safeguards. And clearly this has been studied. So remember, when we are looking at CGM standards for acceptable criteria, we have to look at wear sites because right and left arm will differ. We have to ensure that the extension is not beyond wear period. During the wear period, the consistent analytical performance should be there. There has to be a stable transmission of the data which is guaranteed. They have to be ensuring that the glucose variability of in clinical investigations should reflect the glucose changes in real life situations. The performance also should be ensured that it doesn't do any harm and all the interferences are taken care of. Also equally important is data privacy, cyber security, skin allergies, and full data disclosure. And when you look at all the CGM devices available and time in range when tested for type 1 population, type 2 populations, every CGM has a different standard. And the innovator standards are very different from the non-innovator standards. And that data is also in public domain now. If you go on the FDA website, you can see a lot of that. And many of that has been put out by a vigilant for people living with type 1 diabetes. So we now know that when we are looking at making clinical decisions based on digital health, which CGM is our connector. And therefore accuracy in the intended use population like type 1, type 2, adult, pediatric pregnancy needs to be reproducible, accurate, precise, and have a very low coefficient of variation. And we need to ensure that it is robust. So my entire, point of this talk and dialogue, which Manoj was very keen that I do, was to tell you that CGM is here to stay. And it is changing the way we treat people living with prediabetes, with diabetes, with 1, 2, as well as gestational diabetes, as well as people with complications. And therefore, it's very, very important that we look at clinical outcomes and look at patient safety. And not all CGMs are created equal. US FDA is very mindful of it, that they have got an integrated CGM which has the rigor from any regulatory authority, and Europe also has a consistent standard of safety, and we should be mindful of that. That was a simple exercise which I was given, and I hope that I have been very clear that CGM is here to stay. Use it efficiently, try to keep your patients in range, ensure that the hypos and hypers are corrected, and ensure that you use a reliable CGM which has met the safety standards. Thank you so much for a patient hearing.
So if anybody has questions, we can, sir is here to answer them.
Like to come on for the group photo?
I think, sir, nobody has questions, so we
Sure,
can
thank
just end that question.
All the speakers for the group photo.
So now, now we can proceed for the lunch, and we'll be back by 2 o'clock for the next session. Going to start our next session. My point of view, experience matter. I'd like to call up the chairperson, Dr. Sheetal, and Dr. Manas on the chair.
Thank you, Dr. Kinjal. Welcome to everybody for this post-lunch session. We introduce our next speaker, that is Dr. Arun Kedia from Raipur, who's going to speak on bone health and diabetes. Dr. Kedia is a consultant physician and head of ICU in Lifeworth Hospital in Raipur. He is a life member of DIPSI, ICSSM and IRA chairman. He is a EC member, RSSDI Chhattisgarh Scope certified obesity physician. He has been a part of various clinical trials and has a lot of publications to his name. Over to you, sir.
Good afternoon. Thank you, chairpersons, for the kind introduction. And I know the post-lunch session is always a bit lazy session, so I'll try to keep myself very short and crisp, and yet try to create some sort of interest in a new aspect of diabetes where we have been ignoring for the last few years, and that is the skeletal health. So not many of us actually talk to the patients about skeletal health, and not many of us actually know how to evaluate for osteoporosis in diabetes. So it's a very important topic. It is increasingly being recognized, especially in the hospitals where patients are getting admitted for fractures, and the patients have diabetes as one of the comorbidity as well as one of the risk factors. But unfortunately, this problem is very, very poorly understood, and I'll take some effort to make you understand the concept of skeletal fragility in diabetes. So this would be the outline of my presentation. I would speak on the epidemiology, then whether the risk is different from non-diabetics, whether the risk is only in type 1 or type 2 or both. If yes, what leads to the risk factors? What are the effects of anti-diabetic medications? How do we assess and how do we manage? So if we talk about the pathophysiology of skeletal fragility or the fractures in any person, you need to have either a decreased bone mineral density, or there could be a decreased bone quality, and upon this you need to have a third factor, that is a frequent fall. So if any of these three factors or a combination of these three factors exist, then the patients are likely to have osteoporosis and fragility fractures. And we all know that diabetes is one of the risk factors for frequent falls because of peripheral neuropathy. But I will not focus on the risk of fall. I'll rather focus on bone mineral density and bone quality. So if you see the fracture risk in diabetes, there's 32% increased risk of any fracture in diabetes compared to those without diabetes. The risk is higher in type 1 diabetes compared to type 2. But within type 2, there is a higher risk of fracture in all sites in men, probably because they are physically more active than the women. And if you see the prevalence or data from India, there are very few studies, but they have shown that almost 30 to 40% of patients with diabetes may have osteoporosis. So this was a study which was published in Osteoporosis International Journal of 2021, where they did a population cohort study of more than 65 lakh people, followed up for 7 years for diabetes type 1, type 2, as well as non-type diabetes. And what they found was there was a higher fracture risk at all sites in diabetes compared to non-diabetic. And there was a higher risk of fracture at all sites in type 1 versus type 2. And the risk was highest for hip fracture. Now, hip fracture, highest risk, again, they could not find out any reason, but that was what they found epidemiologically. And surprisingly, in type 2 diabetes, they also found that there is something called obesity paradox. So to begin with, a type 2 diabetes patient has a lesser risk of fracture, probably because of obesity. So all newly diagnosed type 2 diabetes patients, they have a decreased risk of fracture, but with duration of diabetes, they have increased risk of fracture. So there is definitely an opposing effect of obesity as well as diabetes risk related complications. So once the microvascular complications actually set in, then these patients again land up in risk for fractures. So there is a bimodal presentation of these patients. So what are the risk factors for fractures pertinent to diabetes? So type 1 diabetes definitely is a very high risk because of lack of insulin and insulin growth factor. Type 2 diabetes with more than 5 years because of the accumulated micro and macrovascular complications. Poor glycemic control with HbA1c more than 7.9 in type 1 and more than 9% in type 2. Presence of microvascular complications, and those patients who are on insulin, sulfonylureas and thiazolidinediones, they have a higher risk of fracture compared to the other anti-diabetic drugs. Now, why we are worried in diabetes patients? Because once you have a fracture, there is an increased mortality in diabetes compared to non-diabetic patients. And even after a fracture has been operated, there is a poor prognosis because of delayed healing, more frequent infections, longer hospital stays, higher post-operative cardiovascular complications, and of course, all these lead to greater rates of readmission. And we have seen that diabetic patients actually are tough to have wound healing, and they become tough to have a good glycemic control in post-operative state. Now let us come to the basics of skeletal fragility. So if you talk about bone strength, it depends on two factors. One is the bone quality, the other is the bone quantity. So traditionally we have been talking more about bone quantity, and this bone quantity is measured with something called as bone mineral density. And we have DEXA machines to measure the bone mineral density. But unfortunately, if you see the total number of DEXA machines in our country, there is almost one DEXA machine per 7 lakh population. So that is the dearth of DEXA machine, and that is the dearth of the DEXA scans which are ordered for diabetic patients. So it's not only bone quantity that matters, but also bone quality, because 70% of the variability in bone strength is only determined by bone mineral density. The rest 30% also is dependent on the bone quality, and that is why we have to assess both bone quantity as well as bone quality. So if you see the pathophysiology in type 1 diabetes or a young onset diabetes, BMD is lower in type 1 because the patients are unable to achieve their peak bone mass. There is deficiency of insulin, there is deficiency of insulin-like growth factor. And if you have a young patient of type 2 also, then they also have a higher fracture risk, because this apparent paradox could be due to poor bone quality, that they will have poor microarchitecture. And these patients are likely to develop early microvascular complications, frequent falls, and of course they will be on insulin at a very early age. So if you see this cartoon, which clearly shows that if you get diabetes at a younger age, pointer is not working. You have a lower peak bone mass, and that leads to diabetic bone disease. Upon that, you have a high prevalence of vitamin D deficiency, and then these diabetic patients also have an early age at menopause for the women. So all these accumulation of various risk factors lead to actual diabetic bone disease. And if we go into the molecular level, you can see that hyperglycemia leads to formation of advanced glycation end products, which leads to oxidative stress, and that indirectly actually leads to osteoclastic activation. At the same time, hyperglycemia leads to decrease in sclerostin, which leads to decrease in osteoblast formation. So on one hand, you have osteoclastic activation leading to osteoporosis, bone resorption, and you have decreased osteoblastic formation leading to decreased bone mineralization. In type 2 diabetes, again, we have a lot of accumulation of bad adipose tissue, which is a very active inflammatory tissue, leads to a lot of inflammatory cytokines, and that leads further to oxidative stress, which again has a negative effect on osteoblast and a positive effect on osteoclast, leading to finally bone resorption. So if I have to summarize the mechanisms, on one hand we have hyperglycemia, which leads to decreased osteoblastogenesis and at the same time leads to derangement of calcium and parathormone activation. On the other hand, we have increased adiposity, which leads to decreased leptin and decreased brown fat, leading to increased sclerostin. And then we have the inflammatory pathway, which leads to increased reactive oxygen species, leading to osteoclastic formation. So then how do we assess diabetic patients? So for type 1, we have a clear-cut guidelines by ISPAD. ISPAD says that from late adolescence, particularly in the presence of comorbidities like celiac disease, you must start ordering DEXA scan for type 1 diabetes patients. And at any age in patients with poor glycemic control or known vascular complications. So this is for all type 1 diabetes patients, but this does not hold true for type 2 diabetes patients. And that is where we'll talk about bone quality now. So bone mineral density was almost directly related to hyperglycemia, but bone quality is related to something called microarchitecture of the bone. And that is where the DEXA machine does not catch. So for that, there is a new tool called as trabecular bone score. And there are multiple other tools which are still in research, like hip structural analysis. There is high resolution peripheral quantitative CT scan, or you could do a bone histomorphometry, but that is an invasive technique. So what does a trabecular bone score does? It does a computer software based pixel gray variability of the spine DEXA images. So standardized is lumbar spine. So you take the images of lumbar spine from L1 to L4 and do a pixel drawing, and based on that there is a 3D reconstruction of the structure of the bone. So what it does, it gives you an overall score which is calculated after transforming the 3D structure on a 2D plane. And these scores have been validated but not validated clinically. They are still in research. There is no WHO defined reference range, but for all practical purpose, this has been proposed that if you have less than 1.2, then it is a serious degeneration of the bone. So the limitations are, it is applicable only to the lumbar spine. So this was one of the papers which was shown that you can have, the odds ratio of TBS for osteoporosis could be 2.6 compared to bone mineral density, which is measured by DEXA. So in type 2 diabetes patients, your DEXA may be normal, but trabecular bone score may actually predict the risk of fractures. So what are the correlates of trabecular bone score? So it negatively correlates with all the markers of insulin resistance, be it BMI, waist circumference, HOMA2IR insulin resistance, fat mass percentage, and HbA1c. Now the next question comes, very common nowadays, weight loss. How does it affect the bone health? So a rapid weight loss is accompanied with a decreased bone mass with increased bone fragility, and that is why rapid weight loss is not advisable. And there have been interventions which have shown that if you have a modest bone loss with rapid weight loss, and maximum bariatric surgeries have shown rapid weight loss leads to increase in the bone fracture risk. Then we also need to see the effects of diabetes treatment on skeletal health, and we all know that metformin, DPP, negative effects are seen with thiazolidinediones, canagliflozin, sulfonylureas, and insulin therapy. And what we need to keep in mind is keep HbA1c under control to keep bone health into control. Do we really have any bone markers? As of today, no bone markers except CTX, but CTX is also applied only for looking for response to therapy, not for assessing bone fragility. So how to approach type 2 diabetes patients? We need to calculate the fracture risk with BMD, thoracolumbar X-ray, or a fracture risk calculator. And the fracture risk, I've already told that it is duration more than 5 years, medications, vascular complications, HbA1c more than 8%, and hypoglycemic risk. But when we do a DEXA scan, we need to do this especially for the diabetic patients. We reduce the T-score by 0.5, or when you calculate the fracture risk, you have to increase the age of the patient by 10 years, or you can use rheumatoid arthritis as a comorbidity, or you could include TBS if you have that facility, or you could use a type 2 diabetes specific calculators. So how to approach these patients? We need to treat them very judiciously with the drugs which are having positive or neutral effects to bones. we need to check and treat blood pressure, vision, and neuropathy. And if at all there is osteoporosis, then we need to prefer bisphosphonates over the other therapy. So this is the key management for all patients of diabetes. If you have the risk factor, assess their skeletal health and work accordingly. We need to consider anti-osteoporotic treatment if the patient presents to you with any fragility fracture, or he presents to you with BMD score less than -2 on DEXA scan, or if the patient has fracture risk above country specific thresholds for that particular disease using any of the adjustments on DEXA machine. Which drug to use for treating osteoporosis? The preference is usually bisphosphonates. For hip fracture, we use IV zoledronate preferably. For vertebral fractures, we normally go for anabolics like subcutaneous teriparatide. And for no fractures but increased risk, still bisphosphonates is the drug of choice. So precautions that we need to keep in all patients: select low glucose lowering medication smartly. Don't use drugs which increase the risk of fractures. Maintain adequate vitamin D levels. We need to give higher supplements for those patients who are obese. Adequate amounts of calcium along with vitamin D. Maintain active lifestyle, weight-bearing exercises, balancing exercises. Limit alcohol, quit smoking, and keep on assessing the risk of falls in all patients who have neuropathy. So with that, I thank you all. We know very little, so our knowledge can only be finite. But as I say, in science, our ignorance must necessarily be infinite so that we are always ready to learn, and that is why we have all these educational CMEs so that we keep updating our knowledge. Thanks to Dr. Manoj and Dr. Purvi for engaging us in these scientific discussions, and I wish Dr. Manoj all the best for the upcoming Vice Presidential. So we all be with him. Thank you, Chairperson.
Thank you, sir, for the excellent presentation. Any questions?
Sir, will you give any guideline for HRT in menopausal female who are diabetic?
Guidelines. So it is a recommendation, sir. And now ADA has clear-cut specific exercise guidelines for everyone. It's not only specifically to postmenopausal women. HRT, sir, for diabetic patients. So it is the same as what is for postmenopausal osteoporosis. There's nothing specific for diabetes, sir. All we need to understand is the safest drug is a bisphosphonate for young patients. For those patients who have estrogen is not recommended.
Thank you, sir.
Thank you.
I now invite our next speaker, Dr. Bijay Petni. He is a consultant physician and cardiodiabologist and HOD of Diabetes Wellness Clinic, Kolkata. He is going to speak on OH combinations. Over to you, sir.
Good afternoon, and thank you, Dr. Manoj Chawla and Dr. Purvi Chawla and the DRS team for inviting me. We have a topic OHA combination, and we need to look at the good, bad, and ugly aspect of these combinations. So we all are aware that it is a chronic metabolic disorder characterized by the insulin resistance, progressive beta cell dysfunction leading to hyperglycemia. The reason is that this is only going to increase the risk of micro and macrovascular complications. So whatever we do, it has to be a comprehensive management as a management tool while managing people living with diabetes. And we are also aware of what are the oral hypoglycemic agents. They can be broadly classified into sensitizers, secretagogues, incretin-based therapies, glucose excretion enhancers. So you have a whole basket now available. Each class definitely works through distinct mechanism. So we have a combination among these classes. So one should be aware of the fact the combinations should have a synergistic action with less of side effects. So why and what is the importance of combination therapy? One thing is for sure, monotherapy is often insufficient for long-term glycemic control due to the progressive nature of type 2 diabetes. There is a progressive beta cell dysfunction, approximately 4% annual decline, worsening insulin resistance with age and weight gain, and development of adaptive mechanism limited drug therapy. So these are the reasons why probably the monotherapy is not going to suffice. So we need a combination therapy to target the multiple pathophysiological mechanism or defects lying with type 2 diabetes, thus improving the glycemic control. The recommenders across the globe had clearly said combination therapy is recommended if the HbA1c is above 1.5% of the target. So early combination therapy should be used if it's not in targets. Now we are going to discuss the good, bad and ugly of the combination. Let's look at the good part of the combinations. One thing is for sure, it leads to about 1 to 2% of HbA1c reduction when you have an effective dual combination therapy. Along with that, almost the patients who can reach the HbA1c is about 60% vis-a-vis the 45% with monotherapy. Now, there is a reduced risk as well of the treatment failure with the combination than monotherapy, up to that strength of about 39%. Now we have a trial, verified trial. You all are aware of the fact that when they used the early combination of vildagliptin and metformin, what they did was a delayed treatment failure by about 2.4 years compared to the sequential monotherapy. So a fixed dose combination or an early combination may work better than the sequential increase which we do in most of the patients. Rather, that was the norm. So therefore, it demonstrates the legacy effect of combination therapy, because the earlier you achieve the glycemic target, the effect remains for a longer period of time. Next is, when you have a better glycemic control, what you do is you reduce the complications. And this is the age-old UKPDA studies which have taught us that the microvascular benefit along with the macrovascular benefits can be achieved if we have early glycemic targets which are achieved. So every 1% reduction of HbA1c can lead to 37% reduction in the microvascular combination, 21% reduction in deaths related to diabetes, and 14% reduction in myocardial infarctions. Now, if you look at the individual component of this combination, they have their own benefits as well. So just look at the SGLT2 inhibitors. They can be having 26% reduction in heart failure hospitalization, 40% reduction in renal disease progression, and significant reduction in CV-related death in the high-risk patients. Similarly, the GLP-1 receptor agonists, we have enough studies nowadays discussing day in and day out, probably every weekends, which have clearly shown there is at least 14% reduction in the MACE criteria and 22% reduction in the CV death. So these individual molecule in the combination, they can have a positive impact, and that is a good about the combination therapy. Now let's look at the common beneficial combination which you can have. We have an age-old combination metformin and sulfonylurea, and most prescribed, I would say, presently in India. Here, it is a cost effective, which is important. It's the amount of HbA1 reduction, which is extremely substantial rather, and that is important. But there could be a chance of hypoglycemic risk. They have a fixed dose combination as well. Now look at the metformin and SGLT2 inhibitors. Even they have a HbA1 reduction of about 1.3 to 1.8%. But along with that, you have the weight loss positivity, BP reduction, and cardiorenal protection. So you have an added benefit for these combinations, and they are also again available as a fixed dose combinations. Now the third one is the metformin and dapagliflozin. Again, the weight HbA1c reduction is similar, weight neutral it could be, but low glycemic risk. So each one has a potential to be introduced in a appropriate patient. That's very important. Again, they are available as a FDC. Now, the novel approach which we have seen for last few years is the DPP4 SGL2 combination. Now, they can actually target most of the pathways or pathophysiology defects in type 2 diabetes, And the reduction of HbA1c can be tune of 1.5 to 1.9%. So most of them can reach to the targets. Along with there is a weight benefit, and they again are available in the FDCs. So this is particularly benefit in patients with established CVD or high CV risk with moderate hyperglycemia up to 7.5 to 9%. So next is now what we have in India is a triple therapy combination which are available. Now you have metformin, your DPP4 with SGL2, metformin, sulfonylurea DPP4, metformin, pioglitazone DPP4. One need to understand again, some of them have the benefits and concerns as well. If you look at metformin, DPP4, SGL2 inhibitors, the benefits definitely you have a minimum hypoglycemia, you have a the weight loss as well as potential cardiorenal protection. But if you look at metformin, sulfonylurea, DPP4 combination, it is cost effective definitely and a good robust glycemic control, but there could be some concern with the weight, the hypoglycemic risk and potential weight gain. And if you look at metformin, pioglitazone, DPP4, the only concern you need to choose your patients properly. So the concerns are definitely edema, weight gain, heart failure risk with pioglitazone part of the combination. So if you choose the appropriate patient, like those who have insulin resistance, then probably this combination will work. So in India, triple therapy is initiated when dual therapy doesn't work or doesn't achieve the target within 3 to 6 months, or when the HbA1c more than 10%. Now let's come to the bad aspect of the combinations. Now, one major problems obviously is concern is the hypoglycemia, and they are particular of importance is that categories of population, be it elderly, renal impairment, history of severe hypoglycemia, hypoglycemic unawareness, long duration diabetes, or multiple comorbidities. If you have these features, you should be a little concerned about the combination which you are giving, whether the combination need to be given, or the oral hypoglycemic agent need to be given, a combination of those. So what does Indian guidelines recommend? Indian guidelines recommend avoid sulfonylurea based combination elderly patients and those with irregular meal patterns, which is very, very common because we have this tendency of religious fasting very commonly practiced in India. So you should be aware of those. It might work in the younger population, but usually in elderly population, you might end up with serious concerns. Now, the next one is the individual component of this combination, which can lead to serious gastrointestinal side effects. So you have metformin, you have GLP-1 receptor, you have alpha glucosidase inhibitors. All these are available in various combinations. So you need to understand this can multiply. It can have an incremental effects as far as gastrointestinal side effect is concerned. So one should understand how to actually initiate this drug. You should go slow, up titrate, take an extended release formulation, which might work as in case of metformin, and then at times like in GLP-1 receptor agonist, small frequent meals can help you out. Adequate hydration is also important, and you might have to get a proton pump inhibitors along with that as well. So GI side effects significantly impact the medical adherence, with studies in the Indian population showing that 15 to 25% discontinuation are basically due to the GI side effects. So one should be aware of that as well. Third is obviously the weight gain with certain drugs. So when you are trying to combine, and if you have two drugs which are basically known to cause weight gain, probably that may not work in some population, because weight gain is particularly concerning with the Indian population who have thin fat phenotype with higher visceral obesity at a lower BMI compared to the Western or Caucasian population. So one should also be concerned, particularly with thiazolidine, sulfonylurea combined together. We have combination of that as well. So their weight gain can further exacerbate the insulin resistance and thereby worsen the glycemic control and can lead to increased complications associated with diabetes. Now let's look into the other bad aspect, which is very common, drug interaction and contraindication of the individual component of those combinations. So look at the metformin consideration. Drug interactions can be used with cimetidine, alcohol, etc. Caution in India because there is a high prevalence of chronic kidney disease and vitamin B12 deficiency. Thiazolidine, obviously, if you have undiagnosed heart failure, you should be aware of the fact and it's contraindicated by NYHA class 3, 4 and active liver disease. If you look at SGLT consideration, loop diuretics drug interaction is not very uncommon. It's not contraindicated, but it's not very uncommon. So one should be aware of that. So severe renal impairment along with diabetic ketoacidosis is a known features or side effect. Then caution in India, why? Because we are living in a tropical environment and here the chances of genital mycotic infection are very high. So DPP-4 looks better, the safest class as far as the polypharmacy is concerned, and probably a year ago, there is a different efficacy in different Asian population. Now let's look at the ugly side of the various combination. The ugly side is basically gone because most of the older molecules which have probably been banned, rosiglitone, sulfonylurea, the older ones, they were responsible for adverse CV outcomes. So one should be very careful about one such combination sulfonylurea with SGLT2 inhibitors requiring careful monitoring of hypotension, especially in elderly patients and those on multiple antihypertensive medications. Just give me 1 or 2 minutes extra. So another factor is obviously kidney damage risk. Improper use of certain OHAs can lead to kidney disease or worsen the renal functions. Metformin, a known side effect, lactic acidosis, is very rare, I can tell you. And then you have to understand the EGFR before initiating or before continuing, or dose adjustments required. SGLT2 inhibitors, again, a potential acute kidney injury is known, but we hardly see those. Paradoxically, rather, they have a renoprotective effect. And sulfonylurea, hypoglycemia is a risk only when you have a bad kind of combinations. DPP-4 inhibitor mostly safe. Few dose adjustment with certain DPP-4 is required. But what is more important is diabetic kidney disease prevalence is high in Indian population to the about 30 to 40% in type 2 diabetic patients, and therefore regular monitoring is essential, which may not be possible in the rural population. Second, obviously, is the ugly, which is the increased infection risk. Obviously, that is mainly associated with SGLT2 inhibitor associated infection. So whenever you have a combination with SGLT2, you should be very careful about the various risk factors outlined here: female gender, history of genital infection, poor glycemic control, poor hygiene, immunocompromise. And along with that, you actually tutor the patient whenever you are trying to initiate the SGLT2 inhibitors, that you need to have these preventive strategies in order to cut down on the infection rates. So special consideration, because we are living in a hot, humid climate, the chances of their dehydration is high and you might have more of infection. So detailed patients education is critical. Now, we all are aware of the fact that there is a progressive nature of type 2 diabetes. So combination therapy can only delay, it cannot prevent, number one. So most of them need will intensification, you might have to go to injectables. And third one is, if you have different combinations, different pills which are combined, then obviously there will be adherence issue, number of pills increases, but if you have fixed dose combination, they are much better. So again, the cost do play an important role. So that's very important. So last but one is that you need to use the right combination on the various factors: the glycemic efficacy, comorbid condition, weight consideration, cost and access, patient's preference, hypoglycemic risk. Don't make it one pill for all or one combination for all. Always consider these factors before planning out which combination are best for those individual and how to start it, how to escalate it. Monitoring and follow-up is equally important because you have to have specific monitoring to be done with different group of drugs. So to summarize, let's look at the good part. Improves the glycemic control, reduces the microvascular complication, cardiovascular and renal benefits newer drugs, weight benefits with select combinations, delay treatment failure compared to monotherapy, and fixed dose combination definitely improves the adherence. The bad part is hypoglycemic risk with sulfonyl combinations, GI side effects, the weight gain with certain combination, drug interaction should be kept in mind, complex dosing consideration also should be avoided, and cost and accessibility issue has come down with the fixed dose combination. The early past, we were concerned about the cardiovascular concern. Now with those older agents going out of the basket, probably that's not a big issue, but kidney damage risk with improper use, increased infection with SGLT2 inhibitor, progressive nature of the diabetes definitely means you need an escalation. So that should be kept in mind. And lack of long-term safety data for newer combination I still awaited. So key recommendation for Indian context, friends, is consider early combination therapy with complementary mechanism. Prioritize fixed dose combinations when available to improve adherence. Account for high infection risk with SGLT2 inhibitors in our climate. Consider cost constraints and insurance coverage. Monitor more frequently than what the Western guidelines say. Thank you.
Thank you, Doctor, for such a comprehensive overview. In view of shortage of time, we'll have all the questions at the end of the session, please.
Okay.
I now
Thank you.
invite our next speaker, Dr. Ramesh Dargat, sir, who's a consultant cardiologist and lipidologist. He has an overall experience of more than 30 years. He has many awards and recognition to his name. He is a managing committee member of the Cardiological Society of India. He's a joint secretary of Indian Society of Electrophysiology and has been a past president of Association of Physicians of Vileparle and Andheri. So we'll speak on a very important topic of lipoprotein A, which is a novel marker for CVD. Over to you, sir.
Thank you, Chairperson, and thanks to the Manoj and Purvi and Bansi Sabu for giving this appointment at the last moment for me. I think after the osteoporosis and this diabetic combination drug, we are going to go to cardiology or lipidology, which is a very important thing and probably neglected in our Indian context. LPA, a small novel marker. I think we hear a lot of young deaths actually every day in the newspaper come, people below 40 getting myocardial infarction or something. But many times their LDL are not that bad. They have been controlled. In spite of that, we are getting this thing and we have not been screening people for the LPA small molecule is not commonly screened. So this is what we are every day saying. Of course, this is the data we have. Cardiovascular leading cause of the death, what else? 18 million compared to malignancy, respiratory disease or diabetes itself. So cardiovascular still remains, and especially in Southeast Asia, India, we have much younger age group and with a high prevalence of diabetes actually. This was a man, a Norwegian man, who invented the lipoprotein A molecule. This is Kari Berg actually. This is actually ApoA and LPA, LDL-like molecule, are covalently bound to the ApoA. This is the LPA molecule circulating in this actually. It's genetically determined and the level should remain constant throughout the thing. LPA is a pro-atherogenic and pro-inflammatory both. Atherosclerosis is one part of it, like LDL does it, and also it is the inflammatory molecule actually. LPA is a cholesterol-rich LDL molecule containing ApoA covalently bound to ApoB. In addition to pro-atherogenic property, it has a pro-inflammatory property, so some anti-inflammatory drugs might be helpful in managing the LPA. LPA layers are 90% genetically determined by variants of LPA gene, we're going to see, and gender, age, and environmental illness and diet have very few influence actually changes. Once you have a LPA particular level, it will not hardly change with the diet, environment factor, all that thing. It will remain for the lifelong same risk actually. Currently, the physiological role of LPA remains determined and potential role of LPA for the prothrombotic activity remains unproven. This is the molecule LPA which we are going to discuss along with the LDL. Already we all know, and we have been hampering with statin, high dosage, ezetimibe, bempenetic acid, all we have got it actually. So these are the various isoforms of this Kingle 1 to 40 there are, and some of them are very important like 4, 8 and 24 and 40. These are genetic markers for this LPA which are important actually. LPA is both most common monogenic CVD risk factor, one of the strongest genetic CVD risk factors, and actually the genetically determined. Elevated LPA is not rare, about 1 in 5, so 20% of the people will have high LPA level as a cause of cardiovascular death disease. Because 80% may be related to 81, but I think out of 5, 1% will definitely have LPA as a cause, which has never been routinely tested. Liver lipid profile doesn't include LPA, and it's been only done when the patient have a younger age group, a very strong family history, or something is actually, we first come to that. In comparison to family hypercholesteremia, established monogenic CVD risk factor, and an estimated prevalence of 1 in 33 people, 25 million worldwide. And of course, India has very high incidence actually, we find actually Africa and Asia, Southeast Asia, compared to the Western countries which have around 15% to 20%, we are around 30 to 25%, and even the Australia and other countries have 10 to 20%. So we are quite higher. Ischemic prevalence is between above 50 milligram will be taken as an incidence. The Interheart study, which was Sarem Resource actually study by the Indian origin Canadian man, who study showed that the median LPA concentration is highest in Africans and lowest in the Chinese. LPA levels are very across the ethnicity, which are partially explained by the genetic variations across. So you see the Latin America, the Africa, Middle East, Southeast Asia and Africa has the highest, and the Chinese and other people have lesser actually. So LPA gene responsible elevated has been found to be strongest genetic cardiovascular risk factor. LPA gene is fully expressed at a very young age group actually. By the age of 2 years, LPA gene is fully expressed, and by adults, LPA levels are usually attained by the 5 years of age. So what at 5 years you do, maybe remain throughout the life. So maybe need much younger patient to be screened for this actually, very younger age group, where they especially have strong family history or something. Genetic influences, I think these are SNP, single nucleotide polymorphism. 2 LPA SNP variants actually have been very strongly associated with increased LPA level. And LPA gene variants, several LPA gene variants have been now reported that decrease the LPA concentration. These variants include loss of function, mutation, and splice action. And KIV2 repeats, as the individual expressing the few KIV repeats, resulting in a small ApoA isoform, which an average markedly higher LPA concentration than individual carrying the large APO. So what therapeutically, how can we go? Elevated LPA and LDL levels are independent risk factors. So in contrast to secondary prevention, there is Copenhagen general study that showed the incidence rate of the MACE associated with the elevated LPA level was maintained despite varying levels. LDL was brought down below 55, 40 as per the newer guidelines. In spite of the LPA is high, people will carry the cardiovascular risk, such that LPA associated with severe risk, independent of LDL. So LDL has nothing to do. We have been a lot of drugs now for LDL. Now, of course, statins, of course, we are eating hard, especially the secondary prevention is going with the 40 mg rosuvastatin, 30 mg atorvastatin, ezetimibe, bempedoic acid, and PCKS. But I think for the LPA, we are only very limited drugs. So 4 meta-analysis prospective population-based studies adults demonstrate the increased risk of MI at LPA concentration more than 30, and increase when it is 50, 70 or above. The LPA concentration above 30 do not show strong correlation, linear risk of actually either. The LPA levels primarily determine the LPA gene, which we have already seen actually. These are 4 genes which were actually 4, 8, 24 and 30. They were the most important actually marker. The atherosclerotic heart disease incidence linearly associated with LPA. You can see the findings of UK Biobank challenge. That's actually the LPA associated risk with the interim gray zone. It should also consider the other risk factor. So LPA level increases CV risk as the level goes up from 50, 100, 150, 200. And they have seen families which have more than 300, and they have very strong history, the third generation now getting into angioplasty and all that thing. It increases 3 to 4-fold MI risk. Aortic wall stenosis, AS, now which is typical with the TIV, actually lot of younger people, bicuspid wall, another thing is actually the aortic wall disease. Ischemic stroke again, the neurological problem also 1.6%. Heart failure is increased by 1.5 to 2%. CV mortality over is 1.5 higher by LPA, and all-cause mortality is also increased. So especially the MI, aortic wall stenosis, ischemic stroke, and heart failure all are increased with LPA. Genome has shown this thing actually. The 20% risk reduction in MACE could be achieved with LPA, lowering 50 milligram over 5 years. The risk can be reduced by the LV reduction, LPA reduction by whatever methods we have certain drugs which will go. Particle concentration, the mass concentration is the same number of particles, but the mass concentration is a different actually shown. The major influencers genetically predominantly control LPA concentration, 70 to 90%. Lesser influencers, chronic kidney disease, LPA will slightly go up, GFR will go. Liver diseases, LPA will slightly go. Hypothyroid, again, like lipids go up, LPA slightly go. Menopause also slightly LPA go. And any inflammatory process acute reactant, the transient LPA will go up. Any inflammatory process actually when necessary. And limited lifestyle changes, diet, physical exercise, limited or no impact on LPA plasma concentration. You will find hardly any change by lifestyle modification or the exercise or the diet. LPA remains the same, but I think these are some of the factors. And LPA and the CV risk, as you see, the non-fatal MI and coronary death is increasing, ischemic stroke is increasing, and of course non-vascular death also. The genetically predicted LPA coronary heart disease risk is actually genetically predicted. LPA concentration that goes on increasing actually. The increase in absolute risk caused by the increasing LPA category. The atherosclerotic cardiovascular risk increases. The aortic stenosis, which is also now we have an aging population, geriatric population much, and a lot of people after 65, 70 do cut aortic stenosis. And of course, the surgical part has now been replaced by the transcatheter wall replacement. but there is a large population who is coming with a high gradients actually. The LPA will be another cause of that. Reduction needed to mitigate the increased CV risk caused by the LPA depending, because we don't have anything, we do want to reduce the at least LDL to some extent, and then what we can do for LPA. The chronic kidney disease is one of the most common diseases worldwide. In addition to impaired kidney function, patients with chronic kidney disease have increased risk of atherosclerotic cardiovascular disease. And to a lipoprotein conscious statement that European Association made, impaired kidney function may increase the levels of many studies document the patient the impaired kidney function and chronic kidney disease have a high plasma lipoprotein, and so then actually they have also a high levels of the coronary artery disease along with the kidney disease. Association of the lipoprotein with severe degenerative aortic valve disease. This was actually one of the trials shows that aortic stenosis is increased with high levels of LPA. So in fact, LPA level more than 100 significantly associated with the risk of the severe degenerative AS, subsequent aortic valve regurgitation, regardless of basis severity AS. Such associations were not observed in other etiologies of the severe AS. Of course, the aging and all this thing. This was published by the American College of Cardiac Physicians actually. So aortic stenosis, it will again lead to atrial fibrillation, I think or potential cause or mediator of that. As the aging population goes on, we are getting lot of people of atrial fibrillation and the risk of stroke and anticoagulation again. After I think 75, almost 5% of the population will have atrial. The LPA is one of the causes for the high incidence of atrial fibrillation. The drugs which are available to us, nicotinic acid is a very cheap drug available to us, but actually we are very fond of it actually, but it went out of the market because of 2 trials we're getting. Mipomazan is one drug which reduces it 20%. Lometamide is another which has 17%. Statin doesn't decrease LPA, in fact, contrary, increase it. Ezetimibe fibrate bile sequestration neutral. PCKS inhibitors only have 20 to 30%, and lipid apheresis is actually 70%. So mainly the stage now PCKS inhibitors are the only drugs which have. The PCKS inhibitor effect of LPA is quite significant. The median change was LPA, the Evolocom was almost 26% to 30%, and individualized variability of the response was seen in the Fourier trial, which is the Evolocom was a PCKS inhibitor. Predictive magnitude of the LPA lowering, variety of genetic estimates ranging from 66 actually, they have shown that there is a lowering, of course, the help to reduce the risk actually. Pelicresan is a new drug which is going to come in the market, still not available to us. It's a very potent drug, and 286 patients, a small trial which actually was used and is shown to be a very good drug, will be available to Sun. It affects pelicresan, the hepatocyte directed second generation ASO design target, bind ApoA, and this is actually demolished. It lower the more than 50% the additional pharmacodynamic effect and ideal safety profile initial. The prolonged pharmacodynamic effect allows monthly dosing and prolonging the actually benefits in patients. So once a month injection actually. So mechanism of pelicresan, this may review actually, it works at the liver level, LPA and mRNA, RNA blocking actually, and preventing APO production, leading to decrease in the LPA particles. So what is drug which is going to? Horizon study was actually antinuclear administration monthly injection at 7,000 patients, and the study was positive, has shown a very good result in the LPA reduction, and of course reducing the cardiovascular mortality, in fact actually compared to the placebo subcutaneous injections. Olpasiran is the other mechanism which actually is again small interfering RNA directed to the liver. The antisense actually RNA induced silencing complex. This binds to the ApoA, leading to its degradation, preventing markers. So the olpasiran actually was 10 milligrams, 75, 225, 225, and placebo was compared, and 75 was proved to be quite useful without a high dose in the trial, Ocean trial, a dose trial to study. The changes actually was shown, the olpasiran was 75 milligram was found to be quite sufficient compared to the 10 milligram, and higher doses of 225 were not required actually. So achieved LPA by baseline LPA, higher doses achieved nearly complete suppression LPA regardless of baseline concentration. This other guy, olpasiran was compared with Ocean A outcome studies, actually 6,000 patients, and data is still actually coming this year and going to be under. So pelicresan, olpasiran, SLN phase results actually has shown a very good. So I think couple of days current ES recommendation, low risk actually the green part actually, then yellow part is the moderate risk, and the red part is the high risk. So high risk patients should be of course to be tried actually. Just 1 minute. A Canadian Cardiovascular Society guidelines management dyslipidemia and prevention of cardiovascular disease recommends lipoprotein A measurement for everyone once at least in lifetime. Our LPSA standard is still work in progress. We do not have a data of treating patients as well in lifetime, and less than 5% of the elevated LPA with a statin is a cost effective. So summarizing, the remarked evidence as a base support the casual role of LPA and CHDs, remains unknown how large or absolute reduction may be required to see the meaningful, at least 50% reduction, or to bring it down below 50, which is right now actually. We want to wait and lower LP lowering therapeutics to newer drug, olpasiran, pelicresan, all these things are coming up. Traditional therapy mitigation recommended high risk individuals with elevated LPA concentration. The tremendous promise and enthusiasm regarding the LPA lowering therapeutics are in development. Of course, all these are research molecules, going to be quite expensive. and this is the LPA, both most common monogenic CV risk factor and one of the strongest genetic CV risk factor. LPA gene expression remains genetically stable throughout the life. 3 genetic influences contribute to LPA level: SNP, LPA gene variants, and KVI. As a genetic. The genetic influences predominantly elevate LPA levels associated with the risk of MI, ischemic stroke, peripheral artery disease, valvular disease like aortic stenosis, among others, and genetic lowering LPA associated with the reduce all these risk of death. And pelagrasone targets the LPA gene at mRNA level and prevents upward production, leading to decrease in the LPA particle assembly. This is the one a polling question now, which is the following statements are true or correct. LPA concept primarily genetically determined. Individuals with high number of single repeats have considered statins are effective in reduction. So I think the answer is 1 and 2 is correct. All are not correct actually. So LPA is a small molecule neglected actually. So quite common in Southeast Asia, especially India, with a very high cardiovascular mortality. At least measurement should be done. And whatever measures, I think drugs are limited today, but I think VCK is the only thing. I think for the future, there are a couple of drugs are coming up, and hopefully they will be soon available to us at a cheaper rate. At least inflammation part we can target with a simple molecule like colchicine, which can be used and actually can reduce the inflammation. There's a lot of data of colchicine with inflammation and can reduce the mortality. Thank you very much.
So questions will be at the end of the session. I now invite our next speaker, Dr. Asma D. She is a chair of pediatric endocrinology at the chair of Research Ethics Committee at Abu Dhabi. She is a clinical professor of pediatrics at Khalifa University in Abu Dhabi. She is a current president of the Arab Society of Pediatric Endocrinology, a former chair of communication at the European Society of Pediatric Endo, and a former advisory member at the ISPAD. She is an associate editor of Pediatric Diabetes and editorial board member of Diabetes Technology and Treatment. She's a keen researcher. She has significant leadership skills and has multiple peer-reviewed publications to her name, and has received multiple distinguishing awards as a clinician, researcher, and a leader. Ma'am will be having a keynote lecture on lipodystrophy and autoimmunity. Over to you, ma'am.
Thank you very much indeed. Good afternoon, ladies and gentlemen. I'm delighted to be here again in India. I've been a few times. I'm fascinated by your great nation, and congratulations on all your progress in economy, science. You should be proud of yourself. Thank you very much for inviting me. Manoj asked me to talk about lipodystrophy and autoimmunity. I'm not going to talk like rocket science, but I thought this area is a little bit neglected, and I hope you will find it interesting. I didn't know much about this condition, and I'm sure you might be saying, this is too rare. Why are we hearing about it in such a conference? And my answer to that, if that's the way you're thinking, yes, it's too rare, but it's quite a bad metabolic condition that I thought I will share with you. I didn't know much about it until the last few years when I got introduced to lipodystrophy through some families that I have met. In fact, one of our publications was out just last week in Hormone Research in Pediatrics, and I'd like to share this case with you because it's really fascinating. This is the comment from mother of that child who is adamant that her girl is cursed. This is nothing to do with medicine, she says to me, but there's something really wrong in terms of evil spirits that's happening to her child. Before I go and present the case, I would like to tell you just a tiny bit about lipodystrophy, just to refresh your memory. So it's a rare disease, but it can be quite life-threatening, and it's valid for such a conference because of its large impact on insulin resistance, hypertriglyceridemia, and diabetes mellitus. And it's very interesting because what happens is there's redistribution of fat. So people lose fat from wherever the fat is, and it gets accumulated in the wrong places, leading to these metabolic effects. So again, in line to what we have been hearing about the abnormal metabolism and the cardiovascular risk and the fatty liver disease, this is basically what happens with the severe comorbidities of lipodystrophy. So liver, we get hepatic steatosis, kidney, glomerulonephritis and proteinuria, heart, cardiomyopathy, atherosclerosis, and pancreas. Interestingly, with the elevated deranged lipid, we get repeated episodes of pancreatitis, in addition to the rest of the hyperandrogenic features manifesting as infertility and lipodystrophy. One major issue in lipodystrophy affects the brain, so it's related to leptin and leptin deficiency. So leptin deficiency in this condition leads to decreased satiety and significant hyperphagia. So I don't know how many of you have seen patients with lipodystrophy. I haven't seen many, but we managed to see a few. In the Arab region where I practice, there's a lot of consanguinity. I'm not sure to what extent that is the case in India, but we do see lots of autosomal recessive conditions. So I was lucky to see some of these fascinating patients. So lipodystrophy can either be generalized or localized. It depends on the way you classify it. You can classify it as generalized, and under that it goes congenital generalized or acquired generalized. You can also classify it as partial, where it goes as familial or acquired, and there's no actual distinction in terms of clinical features to take you here or there. So if you look at these, for example, patient number A, you see how lean this person is around the limbs. And patient number B, you can see some accumulation of fat in the tummy and in the neck, and then very lean at the buttocks and the legs. Patient number C has accumulation of fat in the tummy and quite hypertrophy of muscles and lack of fat in the limbs. And patient number D, you can see the accumulation is in fact in the thighs, and there's absence of fat in the limbs. So it's quite fascinating clinical picture, and each of these abnormal fat distribution leads to specific position in the category of the patient. So this is, for example, the generalized lipohypertrophy. So you have one on your left-hand side and another one on the right-hand side, and you can see the distinguished feature of the prominent muscles and the absence of fat and accumulation of fat in other places, like in this case in the liver and in the spleen. Patients develop severe insulin resistance, and as you can see, there is a deep acanthosis nigricans and xanthomas, indicating the wrong distribution. And this form is the partial one. So you can see that lady in the middle, she had lots of fat around her face, neck, and tummy, but she has nothing in the limbs, and the opposite with the other lady. A very cardinal feature of lipodystrophy is hyperandrogenism. So you see the abnormalities in the ovaries and in the acanthosis nigricans. And there is a way to put your differential diagnosis, because you might say, okay, well, we get loss of fat in scleroderma, for example. That's not what I'm talking about. You get loss of fat in HIV. This is again not the condition. You get loss of fat in progeria, where the patient has those senile features. What I'm talking about is the lipodystrophy, which is either associated with the autoinflammatory or after exclusion of HIV and others. So let me take you through the case I was asked to present. So these are just some of our publications on lipodystrophy that has been recent between 2024 and actually the middle one that I'm presenting today, or actually the bottom one, is the one that came out last week. So let me just tell you this story of the child whose mother thinks that she is cursed and she doesn't believe that this is medicine, and she stopped coming to doctors. So this is a lady who presented at 2.5 years of age. These are photos for her when she was younger, just a normal child like any other one. And then when she presented, mother said that my daughter became very slim, but only around the legs and arms. And then this girl started accumulating fat, so her abdomen was looking significantly distended. Parents are first-degree cousins, and she has 2 other healthy siblings. So I got some photos for her just to show you. And if you write from your left-hand side, so you can see that her limbs are becoming very slim, and her tummy is becoming distended, so having a very sort of specific physique. And if you look closely to her buttocks, you see those areas with lipodystrophies, like holes in her buttocks. She doesn't have diabetes and she doesn't inject insulin, because some of us have seen this thing as lipodystrophy in patients who do not rotate injections. But that's what happened with this girl, completely spontaneously, with no any triggering factor. And you can imagine, I met her when she was around 12, and she had significant body dysmorphia because she was completely skinny around the limbs and her tummy was very hypertrophied. Something that made her even more concerned about how she looks is the muscle bulk in her limbs and her veins. The veins around her body became hypertrophied and looking like those of footballers. So she wasn't very happy about that. She had significant acanthosis nigricans, as well as in her neck, as well as in her axillae. Now, despite this dramatic clinical features and phenotype, her metabolic investigations were not that bad. Yes, a little bit of derangement of her cholesterol, but her HbA1c was normal, her LFT were normal, and her leptin level was normal too. So we thought this must be genetic. Let's do the genetic testing. So we did an extensive panel for lipodystrophy, and everything came back negative. But this is next generation sequencing. So people said, oh, is this something acquired? It is not genetic. But again, remember, in the panel of genes, you need to remember there are limitations. We could have missed some underlying genetic condition because the analysis does not actually exclude any variants or in regions that we didn't examine. She could have deletion, she could have insertion, so we don't really know. If you have any idea, please do let me know. So let me take you through her progress. So she presented at 2.5. At the age of 4 years, she developed alopecia and vitiligo. And when she was 12, she presented with exophthalmos and swelling of upper eyelids, and she had a clear-cut exophthalmos and biochemical features of Graves' disease, having suppressed TSH, high T3, T4, positive antithyrotrobin antibodies, and diagnosed with Graves' disease, started on antithyroid treatment. Now in pediatrics, I am a pediatrician, we do see Graves' disease, but we don't see as much as you guys do in adults. We don't see those complicated Graves' orbitopathies, and I was a bit nervous I must admit, managing her, because one day she came suddenly to the hospital saying, I can't see a thing. And I said, oh my God, what's happening? I haven't seen this in Graves. Perhaps this is migraine. That's what I thought. And she's having amaurosis buccax. But then I learned with colleagues from adult endocrinology that this could well be a feature of Graves' oculopathy. So I obtained an ocular MRI, and as you can see, perhaps there, her extraocular muscles are very bulky, and she started having this sudden vision loss when she gazes to a certain direction. So severe Graves with significant oculopathy. And she was started on steroid treatment. So this is a girl who had alopecia, she had vitiligo, she had Graves' disease, she lost her fat all over her body and got accumulated in the tummy, started getting some metabolic derangement, but it didn't stop there. And that's why mother thinks that somebody is putting some evil spirit on her, because every now and then she come up with a new disease. And then at the age of 14, she started to pigment. She used to be similar to my color, and then she started to look much darker and darker, as if she was turning black. And then her mucous membranes, so she stuck her tongue out, and there were those hyperpigmented area, and she failed her synaptin test. So another autoimmune disease has developed on this little unfortunate young lady, and we started her on steroid replacement. Her growth was okay. She went into puberty all right, and she had spontaneous menarche. Her leptin level remained normal. So I don't know how you feel, because at some stage I was thinking about this evil spirit and what mother is thinking. And then I said, okay, well, I've done 20 years of pediatric endocrinology by now, and we know that multiple autoimmunes do exist, and especially with lipodystrophy. So now, for those of you who used leptin treatment to treat leptin deficiency, I would like to remind you of what leptin is. So produced by adipose tissues, it has quite a short half-life, but it has a lot of peripheral effects, and that's why people with leptin deficiency, they use it and they manage to lose weight. The question is, will it be beneficial if I use it in this girl? Let me tell you something else about leptin. So leptin has been approved not only in leptin deficiency and severe monogenic obesity, but it's also FDA approved for congenital and acquired lipodystrophy. It's also EMA approved. So I could have used it. And leptin in these people is not used for treating obesity, because even though they have hyperphagia, they are not necessarily obese, but it's used for the metabolic effect. So we've heard lots about pioglitazone. We heard a lot in this conference about insulin resistance and how to treat it. But leptin has been proven to work in people with lipodystrophy who have a lot of metabolic defects. My problem with this girl is not the metabolic defects. My problem is with the abnormal fat distribution, giving her that body dysmorphia, as well as the multiple autoimmune diseases. This is an example for metroleptin used in congenital lipodystrophy. And you can see these are the 5 people who are treated, and you can see each one belongs to the one underneath it, and it does work if you have it. We do have it in Abu Dhabi, but I wasn't sure that it will be beneficial for this child. So I hope I managed to stimulate some thinking in you about this rare disease, lipodystrophy, and I'd like to remind you that it does exist and coexist with multiple autoimmune diseases. So this girl remained on carbimazole For Graves' disease, she remained on multiple steroid replacement. For Addison disease, what I didn't know why, and I would love if any of you can tell me, even after I replaced her with steroids, her color remained very dark. Even though with her ACTH coming beautifully down and mother reassuring me of the compliance, she didn't improve in terms of skin color. So ladies and gentlemen, I'll just finish by concluding that acquired lipodystrophy can be associated with extensive autoimmune involvement. And as you have seen the sequence of development of autoimmune diseases, this explains that the disease is perhaps progressive in nature. I don't know what else of autoimmune disease spectrum she will have next. And despite her extreme physical features, her metabolic findings were minimal at the moment. I don't know what will happen with her, and her leptin was normal. My question to you, do you think I should start her on leptin, which is available and it's reimbursed for her tier of insurance in Abu Dhabi? And would you think that I should perhaps do a whole exome or whole genome? I might be missing something. I did an extensive gene panel for lipodystrophy, which came back negative. And with those questions posed to you, which I don't have any answers for, I stop and thank you very much indeed. Thank you.
Thank you, Dr. Asma, for such a wonderful presentation on such a rare topic. I now invite questions from the audience for the speakers.
Can I? Thank you for, as the chairperson said, Dr. Asma, for this conversation on often not a very common discussed topic. You took us through all the images, the case studies that you've been seeing, but a lot in the audience today are also family physicians where these patients would be probably seen by them first. Just a quick couple of clinical pointers where to think of lipodystrophy or any of these conditions to think about, and then refer to a pediatric endocrinologist or take it from there.
A very quick one, examine the patient. We in pediatrics, we are good at that. You maybe adult physicians see much more numbers compared to us, so your clinics are packed, but examining the patient is critical. Number two, in geriatric medicine, perhaps you are used to see multiple comorbidities. In pediatrics, if you have more than one disease, then there must be, or there might be, some underlying disease that combines all these. There isn't much chances for multiple diseases in pediatrics unless it's the evil spirit again that mother's talking about. Thank you.
Thank you, ma'am. So are there any questions for the speakers?
Till Dr. Hardas Malani comes in, one quick question and requesting for quick answers. Dr. Vijay Patni, you spoke on combinations. Your quick message to again the audience here, which is the ugliest one? To remind others who came in later, you spoke on good, bad, and the ugly combinations. Which one is the ugliest one?
See, let me tell you one thing. You need to understand the patient first. Understand the phenotype of the individual, and then plan out any therapy, be it a mono or a combination therapy. So just to say this is an ugly for this individual may not be ugly for the other one, right? So what I would say, sulfonylurea plus glitazone, until you have a serious insulin resistance, should not be combined together, right? So that is one thing which one should be aware of it. Otherwise, if you said ugly, then the best one would be the newer novel approach, that is SGLT2, DPP4 and a metformin as a triple therapy, or a DPP or SGLT2 is a good combination. What we have realized over decades,
even a sulfonylurea and metformin does very well in almost all the cases. Just make sure that the patient don't end up in hypoglycemia or has not been monitored. Yeah, please.
Sir, yesterday also we had a lecture where they said sulfonylureas are not to be so critically looked at, because don't think about the aftermath before it has actually occurred. All the time you're saying you go into cardiometabolic protection, which is not there in sulfonylurea. You are thinking about the bombing first only before the bomb is made and all that. So why you are thinking of the aftermath? Now, sir, in all the conferences and wherever my teachers have been there, they told us that your CKM starts 10 years, 15 years before your diabetes is actually emerged. Now, when somebody tells me like this, that before you become old, your hair is going to become gray first only, or your renal problem is going to come first only, your cardiac problems are going to come first, your atherosclerosis is going to come first, then I am forced to think, okay, why not I also think in the same direction what my teacher is trying to lead me to, that I go for a drug which is going to give me cardiometabolic protection even if I don't have diabetes. And we have already got it in the EMPA-REG, DAPA, CKD and all that.
Absolutely.
So then why should I vote for a layman when I've got somebody who's a super layman?
Right, the question is very pertinent, but let me tell you one thing. There are two things out here. I think what we don't want to advocate is that you start the SGLT inhibitor, GLP-1 in all the patients, all population. That's what. First thing first.
That is my question. Why?
No. Obviously, it's not being recommended. There's no guidance about it. Whatever we say is evidence-based. Okay. Number one. Number two. What has changed from 2015 onwards? So obviously, whatever we say is definitely having some kind of evidence. So 2015, we were talking about glucocentric, right? Thereafter, we have made all the changes, whatever. In 2025, we are talking about CKM, holistic, obesity, everything else. Even MASLD, you have to think about that as well.
Yes.
And now the gut dysbiosis as well. So if you ask me, gut dysbiosis is the culprit of all the metabolic syndrome which we are having, right? So these are going to be there. But what we need to understand, what his question was, which is the best combination or the ugly combination for a glycemic control associated with the benefits.
Yeah.
That's what I'm saying. We have reasonable combination. We have fixed dose combination as well. Now you have to decide. I never said sulfonylurea is bad. Rather, I said sulfonylurea and metformin we are using for decades and we're doing very well. Just keep a track on monitoring. That is very important. You need to monitor your subject. Just don't leave it.
No, we will not leave the gold. We have lived that for so long.
Absolutely.
Sir, one more thing. Don't go away. Sir, Dr. Duggard is not there. He spoke on LPA. Now see, LPA, statins, if we all
we can discuss, no issue.
And I've got other big people.
All big bosses around.
Sir, LPA, he said that statins are actually worsening the LPA. And he showed us a slide. I have the click of it.
Okay.
He showed it very clearly. Anything above 100 will be bad LPA. And when we are giving statins, and we have been promoters of statins, we are fan of statins for so long, it brings down the ApoB also. ApoB is supposed to be good. I have got it, sir. I've got it. I'm not lying. And statins are worsening the LPA. Dr. Dargad is not here. He was, in fact,
I think the mechanism we talked about, not that worsening of the statin is the
increases LPA. That's what it says.
The primary objective of any kind of management is statin. You all agree? I think that's all. Why the talk was there was very important. Lipoprotein A or small a has been a neglected talk, right? Lipoprotein A, let me tell you, because we are discussing, just give me a 1 or 2 minutes time. Way back in 1997, I had done a small study in West Bengal on lipoprotein small a, and you won't believe the incidence of high lipoprotein A was to the tune of 35.4%, above 30. Okay? So you well imagine, because we have so many patients
who has recurrent cardiovascular event and we don't even look into the lipoprotein A, which we are supposed to do at least once in a lifetime.
Yes.
Right? So at least you can recognize those patients. So if you do a regular lipoprotein A as a lipid parameter, then probably you will be able to recognize those patients. And we have enough patients to document it that this was one candidate probably responsible for recurrent CV events. And I can give you many examples.
We are aware, sir. We are
Many
aware.
examples.
Yeah.
Yep.
Yeah, in fact, in our center, we did this LP screening for 100 patients. Surprisingly, we had 25% of the people who had an LP elevation for study. In fact, I worked on this, what sir is described as the Palakastron. This molecule, I was one of the principal investigators in the study. The results are going to be published soon. Okay, thank you.
Thank you, sir, for the engaging discussion. May I now invite all the speakers on the stage for a group photograph? For the next session, I now invite our chairpersons, Dr. Arun Kedia and Dr. Pradeep Gardi.
For the first talk, I would like to invite Dr. R. Bala Murugan. He is going to speak on cognitive dysfunction in diabetes. Dr. Bala Murugan is Chief Diabetologist at Kovai Diabetes Specialty Center and Hospital. He'll be delivering this talk.
Yeah, good evening, and thank you very much, Manoj and Purvi and Chair. And I'll be talking on cognitive dysfunction in diabetes. Diabetes being a multifaceted metabolic disorder has transitioned to a complex condition with potential implications far beyond glycemic control. Every one of you sitting here will definitely agree with me. When you talk about the cognitive impairment, what does it mean? Deficits in memory, attention, language, and executive function. It represents a significant challenge to the affected individuals, their families, and healthcare providers. We talk about the pathophysiology, several potential pathways, vascular factors, oxidative stress, inflammation, insulin resistance, and microbial gut-brain axis. Everywhere today talking about the microbial gut-brain axis. But look at the central nervous system, what are all the various factors which can contribute to the cognitive dysfunction? As I already said, the microangiopathy, macroangiopathy, hypoglycemia, hyperglycemia, glycemic variability, and poor or tight glycemic control all can lead to cognitive dysfunction. What are the risk factors for a cognitive decline? Again, talking about both hypo and hyperglycemia, oxidative stress, and vascular complications of diabetes, mitochondrial dysfunction, aging, drug therapy, and obesity, lack of physical exercise, and neuroinflammation. All things, insulin resistance from IRS1, PI3K, AKT, they can go in for the cognitive decline, and you can look at the formation of the amylin beta plaques and the p-tau based tangles. They are one of the pathological hallmarks of this disease. And you look at the diabetes, one hand can have comorbidity and medication, on the other hand, genetic predisposition, which with underlying mechanisms like atherosclerosis can cause a brain infarct, and microvascular disease, which can cause an incidual ischemia and glucotoxicity, which can lead to advanced glycation products as well as oxidative stress. And again, looking at the insulin, there can be increased secretion of insulin. Again, there can be breakdown of amyloid. All can cause brain pathology. One is vascular aging and Alzheimer type, which can lead to dementia. So how many people develop cognitive dysfunction? Who will develop? What is the major mechanism? Is it preventable or delayed onset? Look at the genetic factors: ApoE gene, amyloid beta production, immune response in the brain, the TREM2, and HTARA1, vascular cognitive impairment. These are all the factors which are indicated in genetic factors. Here, look at on the left hand side, you can see PSEN mutation without ApoE mutation. On the right hand side, you can see PSEN1 mutation with homozygous ApoE3 R136S mutation. On the left hand side, you can see that down you can see the amyloid burden, the tau burden, hypometabolism, hippocampal atrophy, everything is high. So the age of onset is quite young, 43 to 45. Here almost the dementia comes at the age of 49 to 50, and these are all the major the effects in similar to Alzheimer. On the other hand, whenever there is a mutation with the homozygous ApoE mutation, you can see the major one defect is the amyloid burden, and other things are less, so that the pathology, the age of onset is later. See, what is called NLPR3 inflosome. The chronic hyperglycemia can activate the node-like receptor protein 3 inflosome and induce the inflammatory cascade, resulting in cognitive dysfunction. Dear colleagues, kindly bear with him because this new topic, which are a lot of research is on, and we are still trying to learn. And I have learned when started preparing for this topic. So, a lot of newer terminology and a lot of pathophysiology. See, this is how the NLPR3 acts, and when you look at when the ATP, the potassium enters, then the calcium enters. When the mitochondria create the reactive oxygen species, there can be a active NLRP3 and NLRP3. There is an interaction between there's a complex, inflosome complex, then leading to pro-caspase 1, and again there can be a lysosomal dysfunction, and there can be NFK beta, which can prime and cause all the inflammatory mediators like pro-interleukin 1b and pro-interleukin 18. So these are the various mechanisms of the neurodegenerative disorders. Again, looking at the oxidative stress, reactive oxygen species, and blood-brain barrier breakdown, and inflammatory cytokines, and apoptosomes, and mitochondrial damage. And this is what happens in diabetes. One is that hyperglycemia, which can cause glucose neurotoxicity, and advanced glycation products, which can cause NFKB1 and reactive oxygen species, which can cause vascular endothelial dysfunction, inflammation, oxidative stress, which can lead to impaired cerebral microvessels and neuronal death and cognitive dysfunction. On the other hand, look at the insulin dysregulation, can cause the ID reduction, and which can cause the tau phosphorylation, which can cause the neurofibrillated tangles. On the other hand, impaired the insulin signaling can also lead to that amylin beta and amylin beta secretion clearance, thereby amyloid beta plaques are deposited. So do pathological findings. One, on the left hand side you can see the impaired cerebral microvasculation and neuronal death. On the other hand, formation of neurofibrillated tangles and amyloid plaques, both can cause cognitive dysfunction. This is gut-brain axis also. Okay, so there is an alteration in the gut-brain axis, which can also basically, how does gut connect to the brain? It is mainly through the vagus nerve as well as the neurotransmitters. Whenever there is an alteration in the gut-brain axis, this can also cause lead to the cognitive dysfunction. And what are the specific manifestations? When looking at the pathophysiology, hyperglycemia in the brain, insulin resistance, cerebrovascular disease, other mechanisms like mitochondrial dysfunction, neuronal dysregulation. And on the other hand, what are the clinical manifestations? One, attention and concentration deficits, memory impairment, and executive function dysregulation, and visuospatial ability decline, and language dysfunction. So, what is the role of these drugs? Flavonoids and omega-3. They can have a beneficial effect on the vascular dysfunction in terms of endothelial impairment and atherosclerosis. Again, looking at the metabolic impairments in type 2 diabetes, mainly at the amyloid metabolism. And here also the flavonoids can be useful. Again, at the inflammation also, flavonoids and the omega-3 fatty acid can be useful. Do the probiotics have any role in this? Yes. And look at there's an interconnection between the pathways to the neurodegenerative diseases like mitochondrial dysfunction, protein misfolding, and microbial metabolites. And on the other hand, you can look at the microbiome targeted therapeutic intervention using lactobacillus can also be helpful to ameliorate this one. And what is it? The mTOR and citrulline targets. Whenever there's an overnutrition, physical inactivity, and a chronic anabolic state, what happens? There's increased amino acid and glucose flex and impaired insulin signaling, which can cause an mTOR overexpression. Unrestricted mTOR hyperactivation can cause endothelial dysfunction. On the other hand, if you are able to suppress the mTOR activation by drugs like SGLT2 and GLP1, there can be improvement in the endothelial dysfunction, reduce the oxidative stress, and reduce inflammation. So this is one of the important therapeutic option, and this is the basic mechanism how the neuronal dysfunctional dementia occurs. I already explained in detail most of the time. There's an inflammation, impaired metabolic hormonal system, and hyperinsulinemia and brain insulin resistance, which causes a downregulation of insulin transporter at the blood-brain barrier, and insulin receptor lost by the amyloid beta oligomer, abnormal insulin signaling, reduced clearance of the amyloid beta plaques. And again, the microvascular disease can cause morphological changes, and the amyloid beta deposition and tau hyperphosphorylations are very, very important things in the mitochondrial dysfunction, which can lead to the neuronal dysfunction and dementia. Again, looking at the hypoglycemia, the neuronal cell death, platelet aggregation, and fibrinogen formation, receptor damage can lead to, again, neuronal dysfunction and dementia. Again, looking at the inflammation also can responsible, and impaired nigrostriatal dopamine function and nigrostriatal dopamine depletion can also lead to the neuronal dysfunction. The role of SGLT3 inhibitors and GLP1 analogs, basically these two can act on, apart from the reducing the blood glucose level, it can reduce the body weight, blood pressure, that can cause a reduction in the endothelial dysfunction, increased nitric oxide bioavailability, and reduction in the systemic inflammation and oxidative stress, and reduction in the mTOR signaling, and reduction in the ROS and sympathetic neuronal hormonal pathway, and reduction in the fatty acid oxidation, increased glucose oxidation, and reduction in the amyloid beta plaque aggregation, and reduction in the tau hyperphosphorylation. And by all these mechanisms, these drugs seems to be promising in addressing the cognitive impairment in diabetes. This is fingolimod. This sphingosine kinase actually it's a modulator of the receptor, SNP receptor modulator, which can also help you, which will make the lymphocytes are available in lesser numbers so that there's less inflammation and leading to the lesser cognitive dysfunction. This is the mTOR inhibitors, rapamycin analogs like sirolimus and everolimus, and we have ApoE targets, reducing the ApoE4 levels using antisense oligonucleotides. These are short synthetic sequences of DNA or RNA that can bind to and degrade specific mRNA molecules, effectively silencing the gene. One. Second, the CRISP or Cas9 gene editing. This technique allows for precise editing of DNA sequences, potentially enabling the knockout of the ApoE4 allele or its conversion to a less harmful isoform like an ApoE3. Other gene silencing methods are also into vogue. And dear friends, I just try to take you through what is cognitive dysfunction, what are the various possible mechanisms of cognitive dysfunction. We are talking about the mTOR overexpression today, and we are talking about the tau phosphorylation or hyperphosphorylation, and what are all the different therapeutic modalities. Many things are under research, and right now the drugs are not approved for the management, but a lot of research is on. And so cognitive dysfunction in diabetes is a neglected entity. unless you look for, you cannot find it. See, a basic understanding of physiology is essential. Glycemic control is the key, along with the addressing various metabolic insults, and precision medicine with SGLT2 inhibitors and GLP analogs may be helpful. Don't think I am talking this talk on behalf of GLP-1 and SGLT data, because some data are available and the mechanisms also explained, and lot of newer advanced therapies are in the research, and right now they have a limited role. In the time to come, we will get more answers. Thank you very much.
Thank you, sir. So we'll keep all the questions at the end.
Sir, I am leaving. Do we have any question? I am leaving.
Okay. Does anyone have any question for sir on cognitive dysfunction?
Yes.
Quick one.
So would you advocate that we should start GLP-RA if we find some amount of dementia?
That's what I'm saying.
We should, or we, and
Please
are you doing it?
Please understand, and this is a new entity and new disease per se we are looking into. And I just tried to present what are all the data available and the mechanism address it. But right now,
we are in the learning.
Right now, these drugs are not approved by the regulator. Like Indian Regulated Drug Control Journal of India have not approved these drugs for the specific indication, but the mechanisms, possible mechanisms by which the GLP-1 and SGLT2 can benefit in this I explained.
One small thing. Omega-3 fatty acids and alpha lipoic acid.
Everything I said, there are some data, but still we need more robust and more studies still categorically to get the interest to be. Thank you very much.
Thank you, sir. Thank you. So moving on to the next session, before I introduce the speaker, I just want to reiterate that now the biggest medical breakthroughs that we have seen in the last 2 centuries, which has wiped out infections, is probably the vaccine. The only good discovery after vaccine is probably the clean water. So to address vaccines and their use in type 2 diabetes, with significant role of herpes zoster vaccine, we have none other than Dr. Amit Saraf, and I think this crowd needs no introduction for him. He is the Director and Department of Internal Medicine, Jupiter Hospital, Mumbai.
No introduction.
So over to you, sir.
So in the interest of time, I'm glad that no introduction, and thank you, chairpersons. I will generally not take much of your time. It's a Sunday evening. We've already kept a lot of people away from their families and home this weekend. But I appreciate the enthusiasm of the crowd for a Sunday evening. They're still here. And as always, thanks to Manoj, Purvi, Bansi Bhai for this opportunity. And as the chairman has rightly said, I think this is the encompassing diabetes conference. If you see the topics from day one to now, it has really covered the entire spectrum of diabetes patient care. And I'm sure this topic also will add to that. So I am here to speak to everybody on herpes zoster and how do we prevent it in a diabetic individual. To begin with, we are aware of this slide, nothing new here, that diabetes overall has been a global challenge, is a global challenge, will be a global challenge till we do something about it. And to add to that, CKD is also rising. So combine these two together, we see that there is a huge cause of mortality with a diabetic landing up with actually diabetic nephropathy and hence a CKD. Diabetes carries a high healthcare burden in almost 1 in 10 individuals predicted to have this combination by the year 2045, and that attributes to a lot of other comorbid conditions including a retinopathy issue. Diabetes also is a major risk factor for chronic kidney disease, which affects up to 1 to 8 in the global population. And look at the economics behind it, it's adding to a lot of financial burden as well to the patient and overall the healthcare system. We are talking about this in a topic of vaccination against herpes zoster, because if you see the small little bracket there on the left top, infectious disease are much more predominant in an individual who's diabetic and lands up with CKD. That is the reason these initial couple of slides were taken to show you that the moment there is a diabetic, there is a higher incidence of herpes for sure. The moment there is diabetes and one more comorbid, especially the kidney getting involved, there is even more chance of the individual landing up with an infection like herpes, and then what do we do about it? So thereby coming to my topic at hand, herpes zoster in a patient of diabetes mellitus. The association between them was established. We as clinicians have seen it in our daily practice. The research has shown it. Evidence has shown it There is nothing new here. It's all being shown, all these reviewers over their past experience that have put on paper that diabetes is the independent risk factor for herpes and thereby post-herpetic neuralgia. The PNH stands for that. Patients with diabetes have a higher incidence of herpes zoster as compared to healthy individuals. And these are healthy individuals. So anybody who has diabetes automatically, if you see the graph, has a higher scale. And I would want to add on to this slide, it doesn't matter regarding the control of diabetes. We've all seen a well-controlled diabetic also has that bit of an extra chance of developing that particular herpes zoster infection. Probably the key lies in the molecular mechanics, the key lies in the immunogenicity, the key lies maybe in the lowered immunity over the period of time. But for sure, even a well-controlled diabetes has a little bit more chance than a normal individual. And what does that cause as an impact? It contributes to a glycemic deterioration. So not only does diabetes cause herpes zoster, herpes zoster can also deteriorate a good glycemic control in your patient. It is noted that almost 24% of a well-controlled diabetic patient have increased A1C levels after a herpes zoster infection. And the risk of herpes is no different in all these comorbidities. We are discussing it with diabetes, but look at SLE, look at rheumatoid arthritis, COPD, cardiovascular conditions, inflammatory bowel disease, a kidney involvement, asthma, all of them have shown an increased incidence of herpes zoster. So multiple comorbidities, more the chance of herpes zoster is what this slide is saying. It's a no-brainer. It's an established fact, but the fact the moment you have diabetes add on, so diabetes with a cardiovascular, diabetes with a heart failure, diabetes with a COPD, this goes exponentially higher, and that impacts the quality of life. So the moment we, as clinicians, I'm sure come Monday morning, we are all going to go back to our clinics and tell our patients walk more and be happy and healthy and smile more and be stress-free, and see what herpes is doing to all of them. They can't walk much, the relationship suffers, the normal workload suffers, the mood takes a hit, general activities, enjoyment of life, and the sleep, because of post-herpetic neuralgia is absolutely a deterrent. I mean, I'm sure so many of my colleagues here must have seen a patient of post-herpetic neuralgia complaining of pain and pain forever and forever if you don't treat that herpes or rather prevent that herpes in time. So all of these impact the quality of life. It negatively affects the health quality, as we've just seen, including the post-herpetic neuralgia. So not only the infection in the acute phase, once the infection has healed, the enmeshment of the nerve, the dermatome involved, will lead to a post-herpetic neuralgia, which can also affect the quality of life. So that brings us to the next part, that we've seen what herpes does in a diabetic individual. So how do we prevent it? So we come to the efficacy of this particular vaccine. It's a non-live vaccine. It elicits a response against the varicella zoster virus. It enhances the immune system towards the viral antigen, and it also causes an adjuvant system. The AS01B enhances the immune response to IgGE, and thereby causing a robust immune response also at the time of vaccination, and a sustained one beyond it as well. So the long-term immune response also has been shown to be quite good in this patient of vaccination with herpes zoster. Shingrix was thoroughly investigated in two large pivotal phase 3 trials. One was called Zoe 550 and one was called Zoe 70. The Zoe 50 had, if you see the sample size, 16,000 plus individuals there, and the Zoe 70 also had 14,000 plus individuals there. One arm was given a vaccine, the other arm was given placebo, and what did they find out? They found out that individuals in more than 50 years of age had 97.2% of prevention of herpes happening when they were vaccinated, and individuals who are 70 years and above at 97.9. So a robust data came out of this trial of a large sample size of patients in both these age groups. It thereby significantly reduced the risk of both the post-herpetic neuralgia, the other complications related to shingles, and the efficacy was proven in both these kind of clinical scenarios. Thereby, Shingrix became effective against herpes zoster for people with medical conditions at enrollment themselves. So people who have diabetes, hypertension, coronary heart, asthma, and believe me, gentlemen and ladies, when they come to you for a diabetes naive individual coming to you for the very first time is the most amenable to all your suggestions. So when, for example, come Monday morning, you're in a clinic and somebody for the first time comes to you with a hyperglycemia report, he is the most amenable of that time to if you convince him for vaccination. That's what this slide is saying, that if you try to vaccinate a patient with comorbidities right on the first consultation, I think you've done your job well. The Zoe 11-year data, overall vaccine efficacy was shown to last quite a bit. 11 years is a long period of time of follow-up. Almost, if you see the confidence intervals, was very much statistically significant over the period of time. Adverse reactions, the left-hand side shows the local one. So pain, redness, swelling, nothing new there. Any vaccine you give, that's expected. Simple paracetamol can take care of it. And the right-hand side had little of fever, fatigue, systemic side effects of GI, headache, myalgia, shivering, if at all, but all transient, all short-lived, nothing permanent and nothing acute. The safety results support the favorable benefit and risk profile of Shingrix patient, thereby more than 50 years of age. It was overall compared with placebo, and a fatal side effects were not seen in the post-vaccinated individual as well. Thereby, it's indicated for prevention of herpes zoster, the Shingrix vaccine, and a post-herpetic neuralgia in any adult age more than 50 years, especially more so in a diabetic individual. It's given as 2 doses. Day 1 is the first dose, and between 2 to 6 months is the second dose of Shingrix vaccine. It's not to be freezed, it's to be kept in the refrigerator between 2 to 8 degrees Celsius. What about co-administrations? So all of these can be given with Shingrix. Influenza, pneumococcal, Tdap, along with Shingrix can be given. And as I mentioned, other than that bit of local effect and maybe a bit of systemic effect, there's nothing majorly seen in the patient. Therefore, it's by country approved in all these countries, and 92 million dosages have been given globally. To summarize the Shingrix bit, it has a more than 90% efficacy across age groups more than the age of 50. It has 11-year long-term protection seen, a recombinant adjuvant vaccine, a non-live vaccine. It's approved for ages and individuals more than 50 years, and it's usually well tolerated. So, coming to the last bit of my talk, then what are the recommendations of this vaccination in an individual with diabetes mellitus? So, if you can give it to a diabetic, you reduce the chance of infection. Even those will well manage the disease. So many times we are asked that, doc, I'm on diabetes tablet for last 10, 12 years, my sugars are very well controlled. Do I really need a vaccination? The answer is yes. As I mentioned in the previous slide, a normoglycemic or a well controlled diabetic also has a little of an extra chance of developing this infection. Thereby you vaccinate them. Individual with a high risk of serious complication from infectious disease compared to general population, thereby you vaccinate them. And therefore it's important to protect both these direct and indirect consequences of not vaccination. Most of the global bodies have supported Shingrix vaccination and diabetes, the CDC, the CITCO, the Italian Ministry of Health, and the ADA. Coming closer to home, our own API, the RSDI, the Indian Society of Nephrology have also given their guidelines and have supported vaccination of Shingrix to diabetic individuals. What's the schedule? As I mentioned, the first dose at whatever point in time, and the second dose between 2nd to 6th month after the first dose has been taken. And that's the guidelines for people who are on immunosuppressives. So what of people who are cancer survivors who are on immunosuppressives usually can be given. The two caveats are, if somebody is on rituximab and somebody is on corticosteroids, rituximab, wait till at least 6 months have passed till the last dose of rituximab, and then you give Shingrix vaccine. Corticosteroid patients are for multiple reasons on corticosteroids. You may, as clinicians, stretch your imagination, and right from reactive arthritis to so many indications we end up giving them. Wait till you have scaled that particular corticosteroid to less than 20 milligram a day, and then you give a Shingrix dose. These are the only two caveats to Shingrix. It can be surely given, but if you give it in these caveats, the patient is safe enough to take it. All the healthcare providers should be considering vaccination patients of herpes zoster, even those who have had herpes zoster in the past. Usually a time period of 6 months after the acute infection is safe enough to be given vaccination as well. That's the safety information. So to summarize my last slide, ladies and gentlemen, there have been numerous studies who have been found to have more than 24% increased risk of herpes zoster in individuals with diabetes than compared to those without. A pooled post ad hoc analysis of ZOE 50 and ZOE 70 data has shown that efficacy of Shingrix against herpes zoster was 91.2% with diabetes, and the risk of serious adverse side effects was hardly there. The RSDI in India has shown that the Shingrix, the non-live vaccine, is the preferred shingles vaccine due to its higher efficacy, the longer duration of protection in Indian setting, that's 11 years, and Shingrix is a good option for any diabetic more than 50 years of age. Hospitalization rate, but not the length of hospital stay, was increased after the episode of herpes zoster vaccination. Thank you so much for a patient hearing. Thank you.
We'll take the questions at the end. For the next talk, I would like to invite Dr. Ketan Mehta, who is a physician at Suchak Hospital, Nama and Asian Heart Institute. He is past president of IMA Mumbai West. He is a PG teacher at KJ Somaiya Medical College. Over to you, sir, for this talk on guidelines for diabetic dyslipidemia.
Good evening, everybody. Thanks, respected chairpersons and at the onset, my dear friends Manoj and Purvi for inviting me over here. And can I have my slides, please? So I would be talking on guidelines for diabetic dyslipidemia, and a topic which is very pertinent, and with a great surprise, I am seeing still the number of people who are attending over here. So let me begin with a quote from Alvin Toffler, who states that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And there are so many things which has changed in a recent past, which we need to understand which is there. We know that India is facing a severe storm of cardiovascular disease, and we have a huge burden of the metabolic disease associated conditions, be it hypertension, diabetes, dyslipidemia, obesity, and the high prevalence of one condition is going to lead to the detrimental outcome. And all these are not only just additive, but the multiplicative factors play a role. And we know the attributable risk factors for first MI or a cardiovascular event as per the Interheart study. There are various risk factors, and one of the most important factor is dyslipidemia. So imagine a diabetic patient with dyslipidemia. What is the burden? It's a huge burden. And you look at this IDS study 2022 of newly diagnosed type 2 diabetic patients in India, and what it had shown that 60.5% were classified as very high risk, 82.5% appeared to have at least one cholesterol abnormality, and 96% presented with lipid values above recommended targets which are there. So we know the complete compendium, how there is a CV continuum which happens. So you have not just one risk factor, there is a dysmetabolic factor. So you have a lipid, sugars, hypertension, and all leading to you have a concomitant end results. So where you are going to end up with a lipid abnormality and a vascular events, and we need to take care of those, which is very important over here. So the guidelines, when it comes to guidelines, how are the targets determined? So it's not that somebody just comes and talks, okay, no, you need to achieve these targets. It's an evidence-based approach. So LDL targets are not just arbitrary. It is population studies which has been analyzed. There are various randomized clinical trials which has taken into considerations, meta-analysis which has been studied, and there are various genetic studies, and then there is an expert panel discussing and coming out with the guidelines that, okay, these are the recommendations which should be followed. So now before I begin, can anybody tell me what should be the targets for LDL in a diabetic population? Is it very good? So for the first time in 2019 in international guidelines, European Society of Cardiology came out with the risk stratification. So if you remember when we, a decade back, it was a standard line that diabetic dyslipidemia means you target LDL at 100 milligram per DL. So gone are the days. Now you need to risk stratify, and what it has been shown over here in 2019, for the first time they risk stratify, and depending on the risk factors, if there is a moderate risk and younger patients, that is type 1 diabetic less than 35, type 2 diabetic less than 50 years, and diabetic duration less than 10 years without any comorbidity, they come in moderate risk, and their target should be at 100. Otherwise, high risk means diabetes without target organ damage, but diabetic duration more than 10 years with additional risk factor, it is high, which is 1.8 millimoles per liter, which comes to around 70. and very high where diabetes and target organ damage, more than 3 major risk factors, or early onset diabetes with long duration, it comes as very high, which is equivalent to target should be 55. So this was started in 2019. So moderate risk LDL target less than 100, high risk less than 70, very high risk less than 55, and then even they have gone that with recurrent events you can go even less than 40 also. Now, for the first time, our own Lipid Association of India, which came out with the expert consensus statement on management of dyslipidemia in Indian, it was in 2016. That was the part 1 came, and then there was a specifically for management of diabetic dyslipidemia in Indians. And this was the expert consensus statement from the LAI, Lipid Association of India. It has come. Now, look at them. They have modified over a period of time. The last one, which has come in 2024. Now, I want you to focus. There are 5 categories: low risk, moderate risk, high risk, very high risk, extreme risk. This is, we are talking of general population. But look at diabetes. Irrespective of the status, first a minimum come as a high risk category. So they come with 0 to 1 major ASCVD risk factors. Now, if they have a target organ damage, they will come as a very high risk. If they have got a more than 2 major ASCVD risk factors, again they will come as a very high risk, which is there. So you need to understand now, no more they come in the category of moderate risk, they come in the category of high risk. And what are the treatment targets for lipid lowering therapy for these groups? Now look at it, as I have mentioned, it is high risk and very high risk. So for high risk, less than 70, so it is not even 100. Now the recommendation is target of LDL less than 70, non-HDL cholesterol less than 100, and ApoB less than 80. For very high risk, again it is, should be further lowered down, LDL less than 50. Obviously for non-HDL you add 30, so it is less than 80, and ApoB is less than 65. And these figures you should be keeping in mind. So I have simplified this, the guidelines which is given. So you see it, diabetes, is it without ASCVD or diabetes with ASCVD? Without ASCVD, no target organ damage, high risk, LDL goal less than 70. Even they have a target organ damage or more than 2 ASCVD, very high risk, LDL less than 50. Now, diabetes with ASCVD with associated comorbidities, they come in extreme risk group category A, LDL goal less than 50, optional is less than 30. And now for the very first time, this is the additional group which has been put, diabetes with polyvascular disease or target organ damage. So somebody who had a stroke in the past, cardiovascular, acute coronary event in the past, they come extreme risk group category B, where LDL goal less than 30. This is what we are looking at it. Now, this is when we compare the ESC guidelines versus LAI with American Association of Clinical Endocrinologists guideline. If you see, the LAI don't put the diabetic population in a moderate risk. It straightforward comes in high risk, and now same is endorsed by American Association of Clinical Endocrinologists also. Now talking about the CSI, Cardiological Society of India Clinical Practice Guideline, they came in 2024. Even they have put diabetes with 1 or more risk factor as a high risk, and diabetes more than 20 years with multiple risk factors or target organ damage as very high risk. Now their target is little different. Instead of 50, they are saying less than 55. And for high risk, it is less than 70. Now RSSDI, consensus recommendation in diabetic. So again they talk of same high risk, very high risk, extremely high risk less than 70, very high risk less than 50, and extremely high risk less than 30, which you should be taking in mind. Now what are the guidelines specify about the statin dosage? When you say the high intensity statin, which are only Atorva 40 to 80 and Rosuva 20 to 40. Moderate intensity statins, you have varying dose of other statins also. And then you have a low intensity statins which just reduces LDL by 30% also. So algorithm for going is, when you want to treat it, start with high intensity statin. You have optimal control of the primary factors, reinforce the lifestyle measure, which is equally important. And if LDLC level, when we are talking of a very high risk, you need to use other therapies also, which includes ezetimibe, bempedoic acid, PCSK9 inhibitors, or monoclonal antibodies, which is required also. And this is a beautiful paper which has shown the intensity of pharmacological LDLC lowering. You might be wondering, can we reduce it? Yes. You use the statin, you have a reduction. So moderate intensity statin can reduce 30 to 40%. High intensity statin reduces 40 to 60%. And when you add on with other therapies, yes, it will have a further reduction also. Now, non-HDL cholesterol, so there is now the more talk has been given about the non-HDL cholesterol because it's a superior marker. It includes total atherogenic dyslipidemia component, and that is why the recommendation is, rather than only considering LDL, look at the non-HDL cholesterol. Plasma triglyceride, we know that it is associated with increased ASCVD risk, 32% increase with per 1 millimole per liter increase in men and 76% in women. This is as per the meta-analysis. And hypertriglyceridemia itself is a marker of insulin resistance, glucose intolerance. So you cannot ignore this hypertriglyceridemia also. And what is the recommendation? That is one point which you need to keep in mind as per the LI recommendations, that if the triglyceride is 150 to 199, again you need to take care of the lifestyle measures and the dietary modifications. When it is 200 to 499, you primary still should be targeting at LDL cholesterol, and that is where the statins come into role. But when the triglycerides are more than 500, you should be using therapy which is specific with the triglycerides. So besides the intervention in terms of lifestyle, fibrates, omega-3 fatty acids, and then adding another drugs which will be of relevance, which is very important also. And what are the medication? These are the drugs which can reduce the triglyceride levels, which is you will have to keep it in mind. Now here I want to show few real case scenarios of few patients. Look at it. Now this patient, if you look at only LDL cholesterol, you will be very happy. But look at the total lipids, that is total cholesterol 618 with triglyceride of 4732. Will you leave this patient like that? No. Now other values. Here look at the patient, same time, HDL and LDL, both are equal. So you can achieve these levels also. Look at this another patient. Now here it is very rarity. HDL is more than even LDL cholesterol. So this is achievable, doable. When you think it's an extreme high risk, it is doable. And the last one which I have shown, just to give you an example, look at this number, what they said, LDL is minus 45. This is because when the triglycerides are more than 500, if they calculate it, they will not get the right figure. They may not able to give actual measurable LDL, and that is, it will give a faulty reading. So quarter of a century of treating LDL, the dictum has changed. Earlier it was high is bad, then average is not good, lower is better, even lower is even better, and lowest is the best. So that is the formula we should be using. Ladies and gentlemen, to conclude, diabetic dyslipidemia remains a major risk factor for ASCVD. Lower LDL is better for reducing CV risk. No minimum threshold benefits persist even at LDL less than 30. Large trials and meta-analysis have shown safety and efficacy of aggressive LDL lowering, and non-HDL and TG should also be considered and kept at a target range. I would end with a Chinese proverb, meaning superior doctors prevent the disease, mediocre doctors treat the disease before evident, and inferior doctors treat the full-blown disease. We Indians are far superior doctors than our counterparts in the West. So let's be proactive, go for a preventive strategy. I invite all of you, we have a Last slide. Can I have last slide? The Lycon International 2025, which is happening in September 5 to 7 in Delhi, and we have a Maharashtra State first Mahalycon, which is happening on 12th October at Nasik. So would request everyone to join for it. So proud to be Indian. Our Indian guidelines has come. Thank you so much for your patient hearing.
Just before you conclude, did you really speak Chinese or did you make us a fool? So we'll take up the question after the last talk. I invite Dr. Rajesh Kesri. He's from New Delhi, and he shall be. So to all those who do not know, he was very active in conducting the NCD camp during the Mahakumbh at Prayagraj, and this was done in association with RSSDI. So he has some insights to share in the form of lessons that we can learn from the Kumbh Mela. Over to you, Dr. Rajesh.
Thank you. Thank you so much. So first of all, I'm very thankful to Dr. Manoj Chawla, Dr. Purvi Chawla, and the whole organizing team of DRS. Thanks for inviting me, and thanks for giving me the opportunity of sharing the Mahakumbh experience with all of you. So this Mahakumbh experience is not only my experience, it is the experience of many of us, the members of RSSDI. Very interestingly, the slide that you see, and if any of you can recognize the previous speaker, there's a pointer. Huh? I'm sorry, I think. Dekha? Okay. This one. So, this is our previous speaker. I'm very proud to share with all of you that we are together once again. So we have wonderful experiences together. We've been meeting, but one of the best experiences, I'm sure Dr. Ketan would also remember throughout his life, is the experience in the Mahakumbh. So this health awareness camp, or we called it diabetes awareness camp, Madhumeh Jagriti Shivir, was a wonderful experience. And the topic that Dr. Manoj Chawla had given to this is actually similar. It's sharing with you the experience and the findings and the outcomes of this community-based screening and risk assessment for diabetes, hypertension, and cardiovascular disease at Mahakumbh Prayagraj in 2025. So what is the background and the rationale? India has a very high NCD burden, we all know for that. The high prevalence of diabetes, hypertension, obesity, we have all seen the results of the final publication of ICMR in-depth study in 2023. So the impact of all this is that the NCDs contribute to 63% of all deaths in India, which is a staggering and humongous figure. What these religious gatherings do is that they give us an opportunity. They give us an opportunity to meet the people, the population, and it is a very unique opportunity to conduct public screening and health awareness camps. Purpose here was to leverage the Mahakumbh 2025 to assess NCD prevalence and promote health interventions. So we all know that it was a very unique event, the Mahakumbhs. Almost 65 crore people, half of the population of a country gathered at one place. This itself is a huge achievement and something unheard of, nothing to repeat. So it is an ideal setting for the large-scale screening and epidemiological data collection, because look at the in-depth study and other studies that we frequently talk about. It is very difficult to go over from house to house and examine patients and collect data. Here we had a great opportunity because people were coming there. So we just had to somehow move out amongst them or bring them to us, and we had this opportunity to screen and gather the data. So we know what is RSSDI. It is Asia's largest body of doctors, professional doctors treating and managing diabetes. It is only the second largest in the world after the American Diabetes Association, a body of professional doctors. Its focus is on research, training, advocacy, and technological adoption, and it partnered with Mahakumbh 25 to conduct NCD screening and awareness campaigns. So I'll show you some photographs, then we'll move over to the data so that you have an understanding what and how we did and the scale of things that we did was. This is Dr. Anubha Srivastav. She's from Prayagraj. She's in the medical college. She was very helpful in the organization. And these are the stalls or the camps that where we conducted the screening and testing. We also did an exhibition, probably we'll have in one of the photos, we put up these big posters where people could easily understand what they were told of. So we had a team of 20 technicians, nurses, and dietitians who were explaining to all those who had some problems, all those who had diabetes, hypertension, or obesity, the importance about diet, and giving them very short dietary advices and handing out flyers or advices on that. And doctors were there, like I showed Dr. Mehta, and I was there all the time, and many other doctors from RSSDI who were visiting the Mahakumbh. They offered their services and examined patients free of cost. And we obviously didn't charge. This is on one of the days, the whole team which was there from morning till evening. Patients, different types of patients, urban, rural, people visited. Professor Anuj Maheshwari sir, he is the President Director of RSSDI. He played a very vital role in organization of this camp. He gave his full and unwavering support, because of which I would say this organization, this camp as such was possible. And this is the inauguration. He himself came, he was there the whole day, examined patients, and he inaugurated the camp. Here we see Dr. Vanshi Sabu sir, Dr. Ajay Tiwari, and Dr. Professor Anuj Maheshwari sir. And these are some more pictures of the camp. This is the exhibition. We put a live exhibition. We put up things which people should eat and which they should avoid. And we were explaining them. So people actually had a very good visual understanding of the diet and things which should be done, which should be avoided. And this is the huge gathering we used to have every day. We have examined, we have screened almost 1,400 people per day. And this whole effort was a very coordinated effort. It was done in such a way that the team of 20 people could collect all their data, ask them each questions. There were 17 questions, there were 17 data points which were collected on all the patients. And there were almost 40,000 of them. So you can imagine the task that we had to perform. These again some pictures. So, what were the objectives of the study? It was to estimate the prevalence of diabetes, hypertension, and obesity, assess medication adherence during the religious travel, identify demographic and behavioral risk factors. Medication adherence during the religious travel or religious occasions is very important, because from my experience in the Mahakumbh, what I understood was many people, when they went for the snans, they stopped taking medication right from their home, because they considered it unholy or not pious. Since they're going for the snan, they should stop taking all medications. Many were on vrat, even though they were walking 20 kilometers from station to the ghat, but they did not eat anything and they did not take any medication. Now the timings of the Mahakumbh, it was from January to February on the banks of Ganga. You can imagine the cold it is there, the weather. The weather used to be 4 degrees, 5 degrees in the morning when people would take bath in the cold waters without any clothes, not taking their medications. Many had started 2 days back, left all the medications. I practice in an urban area. I am a physician. I worked in hospitals. I hadn't seen alcohol abstinence seizures, but I saw them in the Mahakumbh. I was treating patients on the railway platform. I treated patients with alcohol abstinence seizures on train. Why? Because they stopped taking alcohol and they were used to it, and there has abstinence seizures. The same goes for the medications. People simply stopped taking their diabetes, hypertension medication because they were going for the snan. So we collected the data. A questionnaire was filled up. Every question was asked to every person. We did measurements of height, weight, blood pressure, random glucose, and pulse. And the data was collected in sheets by our volunteers, and it was later on digitized. So the ethical committee gave approval for this study. After that, we started. We have a lot more data, but the data that we are considering in our analysis is the one that we started after we got the approval, which was a little bit later than the start of the camp. So we have some very interesting results. Gender of the participants: 33.4% females and 66.6% males. And in age groups, we see majority of them were in the age group of 40 to 49 and 50 to 59. So I think majority of the individuals that we screened were between 40 to 70. This forms the major chunk. Urban-rural divide, majority of them, 60% were rural and 36% were urban. And in BMI categories, so as you can see, majorly rural population, but the BMI is moving towards overweight and obesity. So this is a very good reflection of what is happening in our country. We talk about obesity, we talk about excess weight, but we talking usually in the urban centers, in the cities, in the metros. But see, this is what we have. Majority of the rural population here we see is overweight and obese with class 1 obesity. NCD prevalence. Diabetes 25.5% prevalence, hypertension 16.1%, CVD 5.2%, and any condition of these 29.9%. So now we'll have some diabetes specific findings that we had. This is the age. Now these are comparisons between people with diabetes and without diabetes. The mean age was 53% of those with diabetes and 47 without diabetes. And BMI almost similar. And in those who forgot medication, patients who had diabetes were more likely to forget medication than those who did not have diabetes. Alcohol use was more in patients with diabetes than those without diabetes. Tobacco use was similarly more in individuals with diabetes as compared to those without diabetes, because these were things we were recording, asking people, and they were responding. Hypertension was also significantly more. Almost half of the patients with diabetes had hypertension, and very few without diabetes had hypertension. CVD 12.9%, almost 13% with diabetes, whereas only 2.6% with diabetes. So these are self-reported. So what people have reported from what the questions were framed previously by the ethics committee, and they were put up to the patients in their simple language in Hindi, and they answered. And from there we have these figures. And now a little bit about the random plasma glucose, the finger stick glucose measurement that we had. This is a very interesting fact, that 8.8% of those who had reported not having diabetes were found to be having hyperglycemia. So most probably these are people who did not know that they have diabetes, but they actually had diabetes.
So Rajesh, you need to sum up.
Okay, so we've talked about diabetes. In conclusion, the high NCD burden, nearly 1 in 3 pilgrims had diabetes, hypertension, or CVD, highlighting the silent epidemic of chronic diseases, and demographic differences, higher prevalence in older age groups and among rural participants, emphasizing the shifting disease burden to non-urban populations, risk behaviors, significantly higher rates of alcohol and tobacco use in those with diabetes or hypertension, Medication adherence, large proportion of participants miss medications during the travel, 28.6 for diabetes, 43.6 for hypertension, creating a risk for acute complications. And mass gathering feasibility, the Mahakumbh demonstrated that large scale, rapid, community-based NCD screening is both practical and impactful. So what are the public health implications? Mass gatherings as health platforms. This is something new which we could utilize. Events like Kumbh can act as mega health camps, offering outreach to populations that are otherwise difficult to engage. As we've seen in the numbers in the previous slides, majority of individuals who were screened and treated were actually from rural areas. It may be very difficult to reach out individually to all of them, but here all of them had gathered and we could so well engage them and offer them some help. Policy value. Such initiatives provide real-world prevalence data for policymakers, supplementing national surveys like National Family Health Survey and the ICMR INDIAB study. Health system preparedness, screening at religious gatherings builds capacity for emergency management, triage, and referral systems. Behavioral health identifies urgent need for medication adherence support during travel and ongoing long pilgrimages. And equity in healthcare brings healthcare to rural underserved populations who form the majority of attendees. One more thing I would like to mention here is that not only we did the screening, we did the counseling and treatment, but we also gave them medication. So this also I think was very important event that happened, that medications were distributed to those patients. We actually anticipated that a lot of the patients may be forgetting insulin, may be forgetting their medications because of different reasons. So we went prepared, but we understood that our preparedness was not sufficient, not enough. So we kept on building stocks, and every day, sometimes hundreds or maybe thousands of patients were being distributed free medication as long as they lived there. So, recommendations, medication adherence provided pill organizers. Okay. So, this is the last slide, the conclusion. I think we have discussed a lot about it, so thank you. Thank you.
Thank you, Dr. Rajesh. Any questions before we start the valedictory function? Yeah, please.
This was regarding Shingrix vaccination.
You can ask, sir. We'll try.
Yeah,
you can
I
just
can
ask
ask.
us.
Diabetes have got no skin infection. So if they have an active skin infection, should we give the vaccination on that day or not?
So for any active infection, no vaccination is permitted.
Okay.
Any active infection, irrespective of whether it is a skin or a lung or whatever, any infection.
Thank
you. That he had cleared, yeah.
Sir, were you able to collate the data as per state-wise where diabetes was more prevalent according to the Kumbh, not otherwise?
Actually, it was very difficult because we didn't have that opportunity, as I was showing you in the pictures. So we collected some very basic data, whether diabetes is there or not.
So you
we
were
didn't
not
go
actually
into
doing
the we
HbA1c.
didn't go into the details of where they reside, from which state they come. People were there from all over India. So this is more or less a national data, and there is no bifurcation or segmentation into states. Dr. Manoj Chawla was also there. He also gave his services. Dr. Puri was there. So I would request everyone to give a big hand to all doctors of RSSDI and the EC and Professor Anuj Maheshwari sir, who contributed to, I would say this is one of its kind, unique. Mike.
So were you able to tell them to go to nearby centers where you could appoint?
So yes, what we did was we had built this process beforehand. Those who were having very high sugars or very high blood pressure or were having some problems, we referred them to the Prayagraj Medical College, and there were tertiary hospitals with whom we already had tie-up, and they were being referred there for treatment.
Very well. Thank you.
So I know of teams that have come from Harvard and looked at Kumbh Mela per se as, because it always scares them that, how can you maintain medical emergency movement, etc., in such a huge gathering. So they've studied that and people have gotten awards and publications out of that. But I think what we did was, what you conceived and what was implemented was just amazing leadership, because I think that kind of a screening camp, or because people were traveling from all over, and even though it was just opportunistically just catching them and okay, test kar lo and dekho kya ho raha hai. And the camp, I think, the stall was always full.
That's true. That's true.
So once in a lifetime experience.
That's true. That's true.
Sir, like Anil said, whether it was less in the Bimaru 5 state and more in the other states, because the previous data we know everything.
It is difficult for me to comment because we did not ask those questions. We did not ask those questions, so it is not possible for us. I would just like to add one this thing to what Dr. Puri was just saying. I had the opportunity on the very first Shahi Snan. We did a CPR to a sadhu, a Mahatma, on the banks of Prayagraj, on the bank of Sangam. I was amazed that we saw it, he fell down, and I had a doctor with me who was an anesthetist from the emergency department of Gangaram Hospital. We tried to save him, but within few minutes there was an ambulance which came to the Sangam. I mean, if you've been there, you would imagine how difficult it was just to walk, and ambulance was there in just few minutes. Ambulance was there, picked him up. They broke all the barricades, ambulance rushed in, picked him up and went off. So in that way, some things that I have seen personally, the arrangements were very good. So I think, thank you so much. Thank you.
So I invite all the speakers on the stage. Dr. Ketan, Dr. Rajesh, to the rest to a point.
Good evening, everyone. And at the outset, let me, I think, ask you to, if you've enjoyed the last 3 days, start the validatory function with some claps. Largely for all of you, the delegates who've been attending over the last 3 days, the industry, of course, and I'll come to each one of you, and the faculty and the organizing team which has worked over the last several months, I would say, and more so in the last few weeks to make this happen. The faculty, both international and national, that spent their time, their expertise and their weekend with us to enlighten us on how to improve lives of people with diabetes and obesity. So again, a big round of applause to all our speakers and chairs who've been here with us at DRS Kodi 2025.
let me start the validatory function by, can I have the slide up there? By this, what is connected? Yes. Let me invite here on stage Dr. Saurabh Srivastav, Dr. Vijay Patni and Dr. Rai to come up to announce the winners for the oral papers. So at DRS being here, we till last year hadn't gotten into asking for abstracts, and we this year did invite, and I want to thank one person who was instrumental in handling the abstracts, keeping Purvi and me completely out of it and taking the responsibility of getting the abstracts, pushing for the abstracts, the deadlines, collating, finding people to shortlist the abstracts and then review and pick up the ones which were good enough for orals and then the other for posters and reject many others which we which they felt was not appropriate. And that one person is Dr. Rutul Goklani. No, Rutul had to leave. His flight was preponed, so he gives his regards, and we give him our complete acknowledgement for what he's done. A lot of his team members are here who helped us. So for the oral papers judging, again, I want to acknowledge the judges who spared their time, and Dr. Mayur Agarwal, Dr. Sarita. I want to be very sure that I'm not missing out on any of the names, so give me a second. Right, so Dr. Mayur Agarwal, Dr. Sarita Kakani and Dr. Aniket Inamdar were the three judges. I know Mayur has left. Are Dr. Sarita or Aniket here? Aniket was there down there. Hopefully he joins in. So thank you, judges, for sparing your time. And we will, if the winners are here, we would want to call you up to receive your prizes from the three fine experts that we have. Purvi, you want to announce the names?
So once again, acknowledging Rutul and the entire team of experts who reviewed all the abstracts, and if someone can help me with all the names, I don't want to miss out any. So acknowledgement for them. And the DRS 2025, the oral paper winners are as follows. The first prize goes to Dr. Indrashi. And the second prize goes to Dr. Soumya Ranjan Mohanty. Of smoking, glycemic status and diabetes prevalence in adults, and observational study from rural Odisha. The third prize goes to Dr. Manisha Gupta. On her behalf, and I know he was one of the reviewers of the abstracts. The topic was type 1 diabetes and pregnancy. Is our approach uniform? The paper.
Okay.
Thank you. And fortunately, it was Dr. Hitesh Saraugi and Dr. Vikranti who were the judges for the e-posters. In the e-posters, they've selected one poster as the prize winner from the e-posters, and I'll ask Hitesh to announce that. You have the name.
Yeah.
Yes.
It was very tough this year, but the winner for the poster was Dr. Pratibha Shukla from DY Patil.
Thank you. Thank you. Right. One person who's really being missed here and part of DRS, of course, is Dr. Banshi Sabu. Let's hear it for him again. Banshi had multiple commitments and had to catch a meeting in Ahmedabad, so he did ask Puri and me, shall I change the flight and take a later one? But we thought, no, it's important that he continues to do the work that he does and be in Ahmedabad. So none of this would have been possible without Banshi's support, and largely being instrumental in making DRS associate with various and different international associations, and this time being the CODI international body headed by Professor Itamar Raz, who we've mentioned over the last 3 days for personal reasons couldn't join us this time. So thank you, Banshi, and thank you, Dr. Itamar Raz, for being our strength this year. We want to now invite a group of people who have been extremely instrumental in helping the entire DRS organizing committee. And for logistics reasons, I can see that a lot of my DRS organizing committee has traveled back, but I would request all the members from the DRS group who are present here to join us on stage. So I can see Dr. Ashna, Dr. Trija, Dr. Anirudh. I would please ask you to join us on stage. Right, please do. And if anybody else from the DRS, Dr. Mikhil is here. Right, please join us on stage. And while we have you join, I was trying to say, I want to have that one group of people who are our strength and who tolerate us, tolerate our irritable tempers, moods, make sure that while we are preparing for this conference, we also do our most important aspect of seeing patients and ensuring that things remain smooth is our wonderful team from Leena Diabetes Care Center and Mumbai Diabetes Care Foundation. So let me ask the entire team here, starting with Vidya, Sonam, Nikunj, Aarti, Dr. Kinjal, Dr. Shruti, Dr. Munira, Anam, all of you, please join us up on stage. You guys are the heroes for this. So, as I said, we have, is anybody else from the DRS group here? No, as I said, for logistic reasons, many had to travel. So we have a large group of the DRS family, essentially practicing diabetologists from Mumbai, Maharashtra, and some other parts. I can see Dr. Jainish joining in. Please come up here on the stage.
So we do keep taking a lot of feedback and a lot of suggestions from the group. And of course, as I said, the team from Lena Diabetes Care that you had also seen over the last few days running around and ensuring that things run smooth. So let's hear it for our team and allow us to go there and take a picture with our dear team who's doing all the work behind, and it's Puri and me who are seen as the faces and the cutouts and getting the credit, but it's them. The presence of Dr. Navneet Wadhwa, who's been instrumental in getting the newsletters, which we will be seeing some hard copies, but predominantly soft copies being circulated. Day 1, day 2, and you will receive day 3 as well of the newsletter. Thank you, Navneet, for that and every other aspect of work. We had called out for Dr. Aniket earlier, so Aniket,
Thank you.
Aniket, thank you for being part of the judging team and being with us for the last. Aniket comes from this beautiful town of Omarga, which is 70 kilometers from Sholapur, which he has promised me that he'll be inviting us soon to come and visit there and spend some time. Thank you, Aniket. Thank you. Now, we want to thank again our partners. Wouldn't be fair to say partners in crime, Purvi. So it's partners in again hosting this event. Again, a team that we worked with over the last few years. A team where we would put our thoughts, we would put our smiles, and we would put our angry emotions, and we would have all kinds of discussion with them. But everything that you see over the last 3 days, as somebody commented here earlier, that your team makes it seem it's just plug and play and everything moves so smoothly. So a lot of effort goes in planning the theme that you see, the creatives, trying to make it seem that Purvi and me are standing here and smiling to people as they walk inside, coordination with the sound, the travel logistics, the program, the invitation, and multiple things. So let's hear it for the Team RX, which is responsible for getting you all here and making sure that everything is running smooth and being the backbone of a conference like this. So ably headed by Dr. Hardik Chandarana and Neelam Chandarana, may I invite all your team members up here, please. And Hardik, you have to come here and call the rest of the team and their names. I want to request some of our faculty who've stayed back to join us on stage as we acknowledge our industry partners. May I request Dr. Abhi Chandani sir from Ahmedabad, Dr. Ashish Dengra from Jabalpur, and Dr. Rajesh Kesri from Delhi to join us on the stage as we wave out to Ankit and Neerav from RX team
who've been, working behind, and we're still working when we call the team, but thank you so much. Right? Are they joining us? Right? We'll also await Dr. Rajiv Chawla and Dr. Shalini Jaggi to join us, but I'm sure all of you agree to hold this massive event for all of you. None of this would be possible without the support from industry, which believes in continuing to transfer knowledge and exchange of knowledge and science, and supports us to do these meetings. So we would like to acknowledge all our knowledge partners, and we will call, and if anybody of their representatives are still around, we would request one or two from each company to come up and allow us to thank you. And I start with any of the representatives from Novo Nordisk. Yes, please. Eli Lilly. Thank you, Team Novo Nordisk. So anybody from Eli Lilly? Team USV, ably helped by Manoj Badoni. It's a whole team behind him, but USV continues to be a strong support. So Manoj has done a lot of work. Thank you, Manoj. If anybody here is Sanofi, Team Sanofi can join us. Team Cipla, if you have a representative from Team Cipla, can join us up here. Team LD5. Microlabs. Do we have anybody from Microlabs? Sun Pharma. Alchem. Is anybody here from any of these companies? Okay. Abbott Diabetes Care.
There is always
Intas, anybody from Intas?
Dr. Shalini Jaggi to join us on stage for the ceremony. Has been often dangerous.
Nutrition. Northern Pharma. Natalis. Glenmark. AstraZeneca.
Let me also acknowledge, you heard the sound, the clarity of the sound, the waves in Mumbai Chowpatty Hall, the sound from the railway station, the Mumbai Indian sound down, and the entire. So somebody said the AV has been absolutely flawless and wonderful. A big thank you to the entire AV team. But thank you to all of you, right, for doing a super job. We really have been blessed this time to get your team on our side. Thank you so much. Thank you. Yes. Let us acknowledge one aspect which has made this conference a little different from other meetings that happen in the diabetes segment in Mumbai and probably across India, and which is what we've been hearing from most of you who've come here. It's the venue. And if there is one thing which is added, as they said, Char Chand to this conference, it is this beautiful world-class venue, the Geo World Convention Center, which has become a partner and ally to DRS Cody 2025. The absolute service, their precision, their hospitality, their detail, their
Perfection.
Their perfection, their making sure that things are right, from food to how you're received to making sure the cleanliness and the venue in itself. And I don't know what these chandeliers cost, but they're supposed to be the probably the most expensive chandeliers that they have imported from wherever for this. So in short, big kudos to Team Geo, headed by Mr. Puneet Narula, the CEO of Geo World Convention, who met us earlier. Ronnie, Mayur, Clinton, the entire team which has been curating the meal and making sure that things run smooth. We will want to invite here two people from the Geo team that I see in a room, and I've made sure that Purvi and me have been able to survive these 3 days, probably eat a bit, move from place to place, and be able to function and also get a lot of pictures and selfies with all of you. Is Masui and Harsh, who've been standing behind, and the rest of the team Geo that I see. Can the members of team Geo maybe have you up on stage? Besides Masui and Harsh, I can see two other colleagues. Please join us up here. We would love to get a picture with you, and let's hear it for team Geo. So Chetan and Ritik, besides Masui and Harsh. Okay, so that gets us to the end of this function. I want to thank Purvi for bearing with me, and I believe she should do the same, but I'm not sure that she would. But again, thank you all for being with us. Yes. The dates for next year are released, and can we have that slide once more, and the memory stays with you as you leave. Please join us for high tea outside. And once again, let's hear the claps for everyone who stayed back on a Sunday evening thing, right? Let us, if we can, end this valedictory and the meeting by saying Ganpati Bappa Moria as we all get into Ganesh Chaturthi 3 days from now. Do we have a Ganesh song to play as we depart for the high tea? Or a dance, or I think that those who missed it, I don't know if you have a recording of that, you should have played that dance from the committee which did that from the inauguration for those who missed it.
Especially all you missed it.
You able to? Jabalpur special. Thank you, Dr. Ashish Denga, for this performance. This is a global phenomenon on YouTube as well. Ashish Denga.
Note, let's part and not part for long. We're going to see you all again next year, and we hope that all the standards that have been set, scientific, cultural, hospitality, everything can be maintained, and we keep getting inspiration from all our gurus, and we all keep inspiring each other. So, of course, there's a lot, some names were taken, but there are maybe hundreds more that we have missed. We feel that we are really blessed and grateful for the universe to have conspired for these last 3 days for this event to occur. So thank you very much. Of course, the rain gods also were in our favor for the last 3 days. So a very big thank you. And again, humble honor and gratitude for all that has happened. Thank you again.
Please join us for the high tea outside.